The power of one, if fearless and focused, is formidable, but the power of many working together is growth. Good morning, distinguished guests, esteemed colleagues, and dear delegates. I, Dr. Garge, and I, Dr. Spurti, welcome you all to AIIMS Bhubaneswar for Osasicon 2024, the 39th annual conference of ASI Odisha State Chapter.
This annual gathering, organized by the Odisha State Association of Surgeons, stands as a testament to our commitment to advancing the field of surgery and fostering collaboration amongst surgeons.
The kickstarting event for our conference will be the PGCME, which will be a lineup of PG paper competition, case presentation, guest lecture, PG thesis presentation, and surgery quiz. This event serves as an opportunity for PG students to expand their knowledge and hone their clinical skills.
With no further ado, let's welcome the judges for this session, Dr. Narendranath Swen, Professor and HOD, SJMC Puri, and Dr. Shribastar Mohapatra, Professor of Surgery and Senior Consultant, Vikash Binayak Hospital, Murda, Sambalpur, Odisha.
Good morning and welcome to Osasicon 2024. We are really grateful to the organization and Osasicon members for giving the opportunity to chair this session. Now this time, place and persons involved, I am really excited. The time is today is the Kartik Purnima. So this is a very auspicious time. And Lord Shiva destroyed Tripurasura on this day, and by his knowledge and skill, the surgeons destroy the disease that affects the humans. So this auspicious time, the place, the Temple of Learning is All India Institute of All India Institute of Medical Science at Bhubaneswar. Is the learning center and referral center for most of the teaching institutions. So the place is also auspicious. And the persons, the chairperson, Professor Manas Ranjan Sahu, and the organizer, Secretary Dr. Sanjay Giri, including our Director of Academics and our President and members of the association have rightly selected this place and the time and the persons involved. So I am really delighted to chair this session, and I will request the first, and I will give mic to Dr. Swine.
Good morning to everybody. The PG paper competition of the CME, the timing is 6 minutes for the candidate and 2 minutes for the question. 2 minutes question, it is from the panel or from the audience, whatever it may be like, but it must be 2 minutes. So I request the organizer to start this session.
A very good morning to all. So I would like to go ahead to invite Dr. Biswajita Rautray to present her first PG paper in this competition. So please. She is from MKCG Medical College and you are invited to give your paper.
Good morning, everyone. I'm Dr. Biswajita Rautray, going to present my paper on benefits of topical insulin in diabetic foot ulcer, study in Tertiary Care Center of Southern Odisha. So diabetic foot ulcers are quite prevalent, with a diabetic person facing a 34 times risk of developing a foot ulcer, which has a 5-year mortality rate of 30%, which increases to 70% when there is major amputation. In India, the commonest cause of preventable, non-traumatic amputation of limb is diabetic foot ulcer. So it is not only associated with impaired physical function and reduced quality of life, but also with increased healthcare utilization. Topical dressings comprise one of the important modalities of care for diabetic foot ulcer, and yet has been no ideal dressing found. Previous studies have reported the potential of topical insulin in promoting wound healing across various wounds, including diabetic wounds. But this subcutaneous injection directly at the wound site has often lead to systemic absorption of insulin and subsequently hypoglycemic episodes. So in this study, we'll be aiming to find the efficacy of topical application of insulin in diabetic foot ulcer with normal saline group as control, to study the safety and safe doses of insulin, and to study the effect of insulin on angiogenesis, and to see whether it can cause faster preparation of ulcer bed for skin graft and effect on graft acceptance. So this is a randomized control trial, which is a superiority trial with 90 diagnosed cases of diabetic foot ulcer in Wagner grade 1 and 2, admitted in MKCG Department of Surgery from May 2022 to May 2024 with additional 3 months of follow-up. The ulcer of any other etiology, Wagner grade 3 or more, and comorbid conditions like chronic liver disease, chronic renal failure, or any patient with significant arterial insufficiency were excluded from the study. So this is the study layout where patients with diabetic foot ulcer, when inclusion criteria were met, were randomized into group A, which is test, and group B, control. In group A, insulin dressing was applied. That was the insulin, mixed insulin as calculated, 4 units of insulin in 1 ml of normal saline per 10 centimeter square of wound area was applied. And for control, it was only normal saline increased gauze that was used. Daily dressing was done and ulcer characteristics were noted on day 1, 7 and 14. Wound tissue harvested on day 1, 7 and 14 were also sent for CD34 count by immunohistochemistry, and microvascular density was calculated for both the groups. At the end of second week, complete healing or need of skin graft was assessed, and patients were followed up 2 weekly for 3 months, and these are my observations and result. In this study, majority of the patients were elderly in the age group of 61 to 70. Majority were males with an average duration of diabetes 11 to 12 years. The metabolic and systemic risk factors in both the groups are comparable, with uncontrolled hypoglycemia and obesity being the major factor. Majority of the patients were of Wagner grade 2 with a single forefoot ulcer followed by hindfoot. Majority had a traumatic history. So comparing the reduction in mean size of the ulcer, as we can see, there is a significant reduction in test as compared to control, which is almost 2 times. Similarly, in the depth of the ulcer also, it was significantly reduced in test as compared to the control. Granulation tissues were also early and better in the test group. Microvascular density calculated was 21.2 as compared to only 5.4 in the control group. These are some images showing my result. We also calculated the mean fingertip blood glucose level before and after dressing. So it was found that there was no significant change in systemic blood glucose level after the application of insulin in the test group, as was found in previous studies. So the treatment response here is 16 out of 45 patients in control group in the test group had achieved complete wound healing, and the other who were taken for grafting, 24 patients, had a 78% graft uptake. But in control group, it was only 2 out of 45 who achieved wound healing, and percentage of graft uptake was only 45% in rest 13 patients who underwent skin grafting. During the 3-month follow-up period, there were 2 cases of recurrent foot ulcers in the test as compared to 10 in the control group, but this result was not statistically significant with a p-value of 0.06. None of our study subjects had to undergo major amputation, and we report no mortality in our study. So as we saw in this study, we found a significant decrease, that is 62% in the size of the ulcer in the test group as compared to only 34% after day 14, and 87% in the reduction in depth of the ulcer in test group as compared to only 38% in the control group. These studies are in line with previous studies, but we report no systemic hypoglycemia episodes. The test group exhibited a higher healing rate to the control regardless of the initial wound size. And 67% of the study exhibited the clinical triad of neuropathy, minor foot trauma, and foot deformity, and 22% had a symptomatic diabetic polyneuropathy, which might be the contributory factor for the recurrence. And most common organism that was isolated was Staphylococcus aureus. To conclude, this study shows that local application of insulin in diabetic foot ulcer can promote growth of granulation tissue. There has been no systemic absorption of insulin, so it can be safely used for dressing in chronic diabetic wounds, but also in non-diabetic patients as well. This study proves that the rate of granulation tissue formation, overall graft survival, and patient compliance all were higher in the test group as compared to the control. Thus, I conclude topical application of insulin as a dressing agent is both safe and effective in management of diabetic foot ulcers. Thank you.
Vishwajita, nice presentation. Have you done any vascular study before in both control and
Yes, vascular studies were done, and those were
Doppler study you have done for
Yes,
vascular
sir.
status
Yes.
on the control group and the test group?
Yes.
And there is no vascular deficiency?
No, sir. No gross vascular deficiency was found. If it was there, we had excluded them, sir.
How do you assess the distal vascular disease?
Sir, clinically by palpating the dorsalis pedis and clinically by.
Yeah. There are no sign of chronic ischemia.
No, sir. Those who had chronic ischemia, they were excluded from the study, sir.
Okay. Any study of the histopathological study of the fibroblast? How it changes the structural aspect of the fibroblast activity in the insulin given group and non-insulin group?
Sir, in the insulin group, the fibroblasts were lesser, and there were more as in chronic wounds, there are more fibroblasts and there is peripheral scarring. But after application of insulin, there were more keratinocytes as compared to the fibroblasts, sir. So keratinocyte migration was better, and hence there was wound healing, sir.
Have you used any antibiotics in the test group?
Yes, a systemic antibiotic it was initially we had given a coverage of metronidazole and ceftriaxone for both the groups, and after it was changed as per the findings in the pus culture and sensitivity reports. Sir.
Whether you are using the systemic hyperglycemic insulin or not?
Yes, sir. Yes, sir.
Any dose reduction requirement?
No, sir. No, sir.
Because no reduction.
So we have used only topically. We have applied the insulin. So even after comparing the fingertip glucose, so there was no systemic absorption and no episodes of hypoglycemia. Only local.
Any question from the audience, please?
Sir, mixed insulin, sir. Yes.
More participation. Mixed insulin you have applied.
Yes, sir.
Just before this ulceration occurred, if a person will be exposed to insulin on the area which is going to be ulcerogenic, no such.
Sir,
only on ulcer you are
insulin
applied.
absorption would be better when there is a raw surface, sir. When the surface is
Raw.
intact, there would be no local
No.
absorption per se, sir. So that's why.
Neovascularization occurs.
Yes, sir. We
early.
have calculated the CD34 and hence the microvascular density, and those are better in the insulin group, sir.
Thank you.
Thank you, sir.
Thank you. Next, I would like to call upon stage Dr. K. Ramesh Varga from SCB Medical College. Good morning, respected chairpersons, eminent faculties and delegates. I am Dr. Ramesh Bhargav from SCB. I'm here going to present on my topic. My topic is quality-based assessment of laparoscopic camera navigation for resident surgeons, a randomized control study. In the era of minimal axis surgery, the need for the younger generation of surgeons to achieve competence in laparoscopy is paramount. There are several studies worldwide regarding various operative techniques, standardizations, outcomes of various laparoscopic surgeries, but very few dealt with the camera navigation. A good assistance guides the chief surgeon towards a safe and successful surgery. However, laparoscopic camera navigation is a complicated task requiring specific psychomotor and visuospatial skills. Inappropriately handling of the camera results in poor visualization, which can lead to longer operative time, surgeon frustration, and most importantly, can compromise patient safety. Therefore, assistants who handle the camera require guidance and feedback in order to improve their navigation skills, thereby the surgical outcome. For this, objective structured assessment of camera navigation skills was developed as a tool based on five criteria. The five criteria for this objective structured assessment are view completion, horizontal alignment, scope orientation, instrument collision, and autonomy. The assessment scale scores range from 1 to a maximum of 5, 1 being the poor and 5 being able to do it independently. And these are the five criteria in which the assessment is being done. The aim of my study is to evaluate the effectiveness of objective structured assessment as a tool for improving camera navigation skills among surgical residents. It is a single standard randomized control study with general surgery residents as the participants. The inclusion criteria are the general surgery residents who are in second and final year of their residency. I have excluded the residents who have taken part in previous laparoscopic training programs or who have performed at least one laparoscopic surgery under supervision or independently. The sample size was 24 residents based on the total score of the assessment and the power and the alpha derived from the previous studies. And all these 24 members were randomly divided into two groups, the control group and the test group. Each resident, both in the control group and the test group, assisted at least 5 laparoscopic cholecystectomies over a period of 4 to 5 months. Each resident were evaluated, 1 by the operating surgeon and 2 by a senior surgeon based on the OSA criteria which I have mentioned before. To minimize bias, evaluators are kept blinded to the residents' group's allocations. So they don't know whether the person is a study group or a control group. The control group residents assisted the surgeries that they routinely do, and their scores were not revealed to them. Whereas the scores of that particular study group resident was revealed to that student so that he would know where his lacunae were. Then, at the end of the study, the scores of the study and the control groups were analyzed and compared in terms of mean, standard deviation, and t-test was done. A two-way ANOVA test analysis of variance was performed to look for difference in scores after each assessment within the group as compared with amongst the groups. Then a feedback was taken from the study group using Likert scale, and the statistical tests were conducted using SPSS and R code. So these are some of the feedback questions which I have taken. Then coming to the results. The mean, standard deviation, and t-test values of the study group and the control group. The average mean study group score was 19.88, whereas that of the control group was 16.1. The standard deviation in the study group was 1.5, and that of the control group was 0.4. Then I have performed a t-test which showed a statistical difference between the mean scores of the study group and the control group, and the study group have performed significantly better than that of the control group. The p-value was less than 0.001. The study group has better mean CNS scores than control group. Then an analysis of variance of scores was performed within the study group, and we can see that after each assessment, the study group's mean score was comparatively better than the control group. And after performing the analysis of variance, the study group scores were significantly better than that of control group after each assessment, which shows that once given the feedback, the students were able to know where the lacuna were and are improving the next time when they are assisting. So this suggests that objective structured assessment of CNS had a positive effect on the residents' performance. After the Likert score, after the questionnaire feedback, the study group residents opined that this assessment helped their understanding of camera navigation and felt such assessment was relevant during their residency. They also opined that the skills acquired during this study will help in their future practice. And finally, the residents felt confident with their camera navigation at the end of the study. This is a box plot showing the average scores. The green is the study group and the blue is the control group. So I would like to conclude by saying that the data from this study has shown that the objective structured assessment for camera navigation is a viable and a reliable tool. An independent objective assessment of camera navigation skills not only helps as a quality control, but also helps to improve the competence of the camera assistant. This structured assessment helps in improving camera navigation and has a great scope in the future with regard to surgical training. Thank you.
Thank you, Doctor, for completing your subject within the time. So, for this navigation, you must have the equipment.
Yes, sir.
Your institution have it.
Yes, sir. Yes, sir.
Yes, where it is not there, how can this residents will improve?
Sir,
any suggestion from you?
Sir, we can generally have assisted directly on the cases, sir. In my study, there are certain modules which are being coming up where we can take up such studies, sir. Have reviewed the literature. There are certain online navigation programs as well, where the software is available and you can install and do. But for that, you need to have a basic laparoscopic equipment, sir. As this test is mostly about the laparoscopic camera navigation, so minimum equipment are required to venture into it, sir.
Yes, you are right. Without instrument, how can you navigate?
Exactly.
So instrument is a must.
Yes,
But what the question is, the test group and the control group of residents.
Sir.
Is there any pre procedure instructions to both groups that this is the skill you need to during camera navigation? How the port will be introduced, how the camera should be introduced, where the target organ should be there, what is azimuth triangle, what is manipulative triangle. All these things are known to the test group, or they are blindly taken up as we take a technician.
We haven't given them any formal training before the starting of the test, sir.
Right. So they have not formal training.
Yes,
you
sir.
take them as you take an hour, sir.
Yes, as
if
regularly
you are alone
the
and you
residents.
take an hour,
Yes, sir.
that you study. Well,
Yes, sir.
this in the control group, the person knows that.
No, sir. The control group person doesn't know that he is taking part in the study.
Then how can you compare?
We can come, sir. The control groups are already assisting the cameras regularly in their OTs. The students.
They may be
residents.
regularly assisting without knowing the tricks and tips of the camera
Yes,
navigation.
even,
It's a
exactly,
knowledge
sir.
is required, no?
Yes, sir.
Knowledge.
That's the- yes, sir.
So
That's
it's
the
a
main-
knowledgeable group and unknowledgeable. That is how you have to
Exactly, sir.
assess.
That's the main purpose of the study, sir. Whether if the knowledge is imparted
Yeah.
in the right way, would it help the student improve the learning curve quickly or not?
What is azimuth triangle and what is manipulation triangle? That you know?
Sir, manipulation triangle is between the.
Okay, thank you. That is not your job. The time is over. Thank you very much.
Thank you, sir.
Thank you. But your slides are very congested.
Sir.
So you should make only 4 or 5 lines. You have made so much data in the slides.
Sir,
That is one. I could not read from here.
sir. Thank you, sir.
May I know Dr. Antriksh Mishra from PGIMER? Is he here? I think.
Sir, sorry, sir.
So,
Last time.
so I would go ahead to call the next speaker, Dr. Ramakant Mahanti from Vimsar Burla for his presentation. Please, Dr. Ramakant Mahanti.
Good morning, everyone. Respected professors, teachers, and delegates. I, Dr. Ramakant Mohanty, second year junior resident from Bhimsa Bulla, I'm here to present a paper on the effectiveness of the Mannheim Peritonitis Index in predicting the prognosis in patients with peritonitis due to anterior D1 perforation. Introducing the topic, there are many peritonitis due to hollow viscous perforation continues to be one of the most common surgical emergency that is attended by a surgeon on a duty. There are many causes of peritonitis, hollow viscous perforation being the most common and the risk factors being peptic ulcer disease. Despite significant advances in the diagnostic mortality, surgical treatment and the intensive care, the prognosis of these patients remain poor. Early identification, stratification of the patients with severe peritonitis can aid in the selecting the patients for an aggressive surgical approach. There are many severity scoring systems, with most reliable being the MPI and the Apache 2 scores. Others are shown in the slide. Most of these scoring systems are tedious to measure, require the latest diagnostic investigation, and needs multiple measurement of numerous factors. Hence, this needs to be analyzed in the context of a different populations from developing countries before generating their utility. This slide shows the 8 parameters of the MPI score based on all or none principles, which are self-explanatory with the exception of the definition of organ failure that has been given on this to the right. The maximum possible score for being 47, with minimum being 0 if none of the risk factors are present. The aim and objective of the study is to evaluate the effectiveness and accuracy of the MPI in setting up a developing country and to estimate the mortality and morbidity based on the MPI. This is a prospective observational analytical study with a sample size being 51 patients done in the Department of General Surgery, Vimsa Bola, over a study period of June 2023 to May 2024. The inclusion criteria being the hollow viscous perforation at duodenum only. Exclusion criteria being patients below 15 years, perforation due to trauma, secondary peritonitis due to the perforation in sites other sites of bowel, those patients who refused for surgery, and those who refused participate in the study. First, the patient with a provisional diagnosis of hollow viscous perforation was sent for pre-operative investigation with confirmation of the diagnosis using digital X-ray chest chest and erect abdominal radiograph. Following which, patient was resuscitated and taken up for emergency laparotomy. MPI score was calculated and was divided into three groups. Group A score less than 21, Group B between 21 to 29, and Group C score more than 29. Statistical analysis was done using chi-square test to compare the association of the MPI score with mortality and various clinical parameters of MPI with mortality. Results: out of the 51 patients which are peritonitis due to duodenal ulcers, male to female ratio was 3:1. Majority of patients, 64%, were from Group A, 22% from Group B, and 14% from the Group C. There is no mortality was found in Group A, 18.1% was found in Group B, and 71.4% mortality was found in Group C, that is score more than 29. This indicates the mortality significantly increases with the increase in the MPI score. This is the correlation of the MPI components with the mortality, with risk factors, survivor, non-survivor, and p-value shown in the chart. Sorry, sir. There was a positive significance of age, more than 50 years of age with mortality. The increasing age correlates with higher mortality. There was no significant correlation with sex, p-value being 0.76, with a male to female ratio being 3:1. There was a higher mortality in malignant etiology of perforation. There is a significant correlation between the fecal contamination with mortality to clear pleural exudate. This is the chart showing the p-value assessments. Coming to the discussion, the mortality steadily increases with the increase in MPI score. The various post-operative complications in our studies were mainly in the patients with a higher MPI, and the significant positive correlation between the fecal contamination with higher mortality. There is higher mortality in the malignant etiology of perforation. These results are in line with the similar studies done in the past. Concluding my paper, this study proves that the MPI score is the most reliable, simple, cost-effective, easily and applicable and reproducible scoring method for assessing mortality and morbidity. The higher MPI score helps to predict the significant increase in the mortality of the patient, therefore allowing for an early planning and judicious use of the resources for timely intervention to decrease the mortality. Finally, I will conclude by a take-home message, that is, MPI score should be routinely used in the clinical practice, especially in low resource settings, as higher scores are significantly associated with poor prognosis and mortality. These are the references which I used. Thank you, sir.
Okay. Thank you for completing within time. Any question from the audience? Audience question?
Very well presented, and it's a good. But this should be, these criteria, MPI criteria, should be used where facilities and I mean ICU care, everything is not available. So you can refer the patient if the PRO score is very high.
Yes, sir.
How do you know before surgery the characteristics of the fluid? Do you routinely aspirate the peritoneal fluid?
No, sir. This MPI score is based upon the preclinical evaluation as well as the intraoperative findings, sir. We use the MPI score to
that criteria of purulent, fecal, and clear.
Yes,
How you do intraoperatively?
Yes, sir.
So that means once you have entered, the prognosis you know is pure. Why you can't assess preoperatively? The patient may need an ICU care after the surgery. So, and you are in a primary health center or a community health center, whether should you operate this patient or not according to the MPI score?
Sir, we should operate the patient, sir, but sir, the decision we make during the inter period should be based on the MPI score. Basically, sir, if that the high score, if we are predicting it is a high score, we can go for an early source control of the infection and early cessation of the surgery, or we can go for a staged approach.
Yes, when the patient presents with multi-organ dysfunction and shock,
Yes, sir.
and most of the time in tertiary hospital they come in shock. What should you plan? You should go for direct surgery or you do something else?
Sir, first we in every surgery before taking a patient to the surgery, sir, always we first resuscitate the patient.
Patient in shock, peripheral circulatory failure, BP not recordable, and pulse is not recordable, but you know this is perforation, and
Sir, at least
MPI score is more than 29 or around 35.
sir, we would still prefer to take the
So
patient.
give frank drain, boss. Give frank drain. I explain with counseling.
Yes, sir.
Drain the toxic fluid. The source control is very, very important. In casualty itself, you can do under local anesthesia. Drain the fluid. Okay, thank you.
Thank you, sir.
Thank you. I know you, sir. Thank you. Sorry for that comment. That I know.
Thank you, sir. I would like to call upon the next speaker, Dr. Aditya Jain from AIIMS, Bhubaneswar, for his presentation. So again, I would like to any PG case presentation candidates present here. They may upload their presentations in the backstage, please, for the next session.
Good morning, respected judges. I am Dr. Aditya Jain from AIIMS, Bhubaneswar. The title of my paper is Observational and Comparative Study between Submucosal Gallbladder Neck Dissection versus Fundus Down Dissection in Difficult Cholecystectomy at a Tertiary Care Center. Difficult cholecystectomy is characterized by intraoperative factors that increase technical complexity and the risk of iatrogenic biliary injury. These factors can be intraop difficulty and procedure-related difficulty. Intraop difficulty includes frozen calyx or critical view of safety not achieved, distended thick wall gallbladder with impacted calculi at the neck, fibrotic and contracted gallbladder, and post-ERCP patient with gallstones. Procedure-related factors include unsatisfactory trial dissection, usually more than 30 to 45 minutes. Lap cholecystectomy is the standard treatment for gallstone disease, but difficult lap cholecystectomy might need bailout procedures, which include conversion to open, tube cholecystostomy, subtotal cholecystectomy, and fundus first approach. In this presentation, I'll be using terms like submucosal neck dissection and fundus down dissection. Both of these are types of stump management after subtotal cholecystectomy. In submucosal neck dissection, the tethered posterior wall to the liver bed, the dissection is done between the mucosa and the muscularis layer to be able to achieve a circumferential margin around the stump. In fundus down dissection, posterior wall is dissectable up to the neck, after which we do intracorporeal knotting. I like to show a video of the procedure. In this, we can see the stump is tethered to the posterior wall. The dissection is done between the muscularis and the mucosa. We are able to achieve a circumferential margin, after which we are able to securely close the GB stump. The aim of the study is to compare the efficacy of submucosal neck dissection of GB neck near porta hepatis to achieve a good stump for effective control of GB infundibulum or neck in case of non-dissectable thick adherent GB wall to the fossa with standard fundus down dissection technique, and also to compare the intra and post-operative complication of this submucosal neck dissection with fundus down dissection for completion of lap cholecystectomy. This is an observational study. Patients from 18 to 60 years of age who were diagnosed with gallstone disease on abdominal ultrasonography and underwent elective lap cholecystectomy from Jan 22 to July 24 were considered with standard inclusion and exclusion criteria. This is a technically challenging procedure, and patients were divided into two groups based on intraoperative decision by the operating surgeon. Group A included patients with submucosal neck dissection and Group B with fundus down dissection. Primary outcome were measured in terms of post-op bile leak and post-op biliary intervention. A total of 1782 lap cholecystectomy cases were reviewed between Jan 22 to July 24. After applying inclusion and exclusion criteria, 201 cases were included, 150 in Group A and 51 in Group B. Primary outcomes measured in terms of bile leak showed that Group A had 5.3% bile leak and group compared to Group B, which had 7.8%, which shows a trend towards fewer bile leaks in Group A, suggesting a safer approach in difficult cases. Only one patient in Group A needed post-operative biliary intervention compared to 2 patients in Group B. The duration of hospital stay and intraoperative bile loss were less in Group A as compared to Group B. Only one patient in Group A had subhepatic collection. Only a fewer patient in Group A required ICU collection, and no patients had residual stones. A chi-square test comparing bile leak rates between submucosal neck dissection and fundus dissection yielded a p-value of 0.62, which is statistically insignificant. However, trend towards lower complication rates and faster recovery in Group A supports potential superiority of submucosal neck dissection in difficult lap cholecystectomy cases. Our study shows that submucosal neck dissection shows fewer bile leak rates, shorter hospital stay. Only one patient had subhepatic collection and no patient had residual stone. A meta-analysis study conducted by Adriana Toro et al. Comparing 4 types of subtotal cholecystectomy showed results like bile leak in 12.2% patient, prolonged hospital stay, subhepatic collection in 3.4% patient, and residual stone in 2.7% patient. In our study, we were able to achieve better results because we were better able to manage the stump by circumferentially achieving the margin, which helped in safely closing the stump. The potential shortcoming of our study is that less number of cases were observed and it is a technically challenging procedure which has a steep learning curve. I like to conclude by saying that submucosal gallbladder dissection has better outcomes in managing tethered posterior wall. It is an alternate procedure to reconstituting or fenestrating type of infundibular management of subtotal cholecystectomy, which is technically challenging. Thank you. These are my references.
Okay, thank you for completing within time. How are you managing the post-op bile leak in your case?
Sir, in difficult lap cholecystectomy, we are placing drain in most of the cases. So bile leak subsides by day 5. But in cases which have prolonged bile leak, we go for decompression procedures like ERCP with stent placement.
Any question from the audience? Thank you.
The next speaker, Dr. Aravinda Kumar from AIIMS and Some Hospital, Bhubaneswar. I would like to invite Professor Devduti on the dais for judging the session also.
From IMS and Some Hospital. My title is The Use of Serial Early Post-Operative Lactate Level in Predicting the Post-Operative Outcomes in Major Abdominal Surgeries, a prospective study at a tertiary care center in Eastern India. Introducing, major abdominal surgery is still a greater contributor to post-operative morbidity and mortality in developing countries. Major abdominal surgery leads to hypoperfusion both during and after major surgeries, which has an impact on post-operative morbidity and mortality. Serum lactate is a good indicator of tissue oxygenation and perfusion. Therefore, the purpose of the study was to investigate the association between the hyperlactatemia and outcomes in patients following major abdominal surgery. Further, we aim to compare the efficacy of this predictive tool with an established predictor score such as SOFA score. During our literature, no study was found previously utilizing the SOFA scoring system to assess the predictive accuracy of the lactate level in major abdominal surgeries. My primary objective of this study is to evaluate the ability of serum lactate levels in the postoperative period to predict the postoperative complication, morbidity, and mortality. Secondary objective is evaluate the SOFA score in each of the above patients and correlate them with the lactate levels in predicting the outcomes. By utilizing the SOFA scoring system to assess the prognostic accuracy of the lactate levels. Method used here is it is a prospective observational study conducted in a time period between Jan 2023 to July 2024 in a tertiary care medical institute and hospital, involving a study group of only one group, patient undergoing major abdominal surgery with a convenient sampling of 216 patients. Inclusion criteria: patients above 18 years undergoing major abdominal surgeries defined under like laparotomy and laparoscopic techniques with an operative time of more than 2 hours. Exclusion criteria: patient less than 18 years, a patient undergoing abdominal surgery where operative time is less than 2 hours, and patient with a history of decompensated heart failures. The parameters used were arterial blood gas values and lactate levels were obtained on immediate postoperative admission to ICU. Lactate at 0, 6, 12th and 24th hour was obtained after the operation, and SOFA score was also assessed. The outcomes measured here were surgical site infection, septic shock with AKA ARDS, sepsis with fecal peritonitis, prolonged ventilatory support with sepsis, prolonged ventilatory support with septic encephalopathy, prolonged vasopressor support, mortality. Statistical analysis: all the data were collected and it was analyzed in SPSS version 27. Continuous variable were expressed in mean ST. The association between two categorical variables were expressed in chi-square or Fisher exact test. Comparison between two means was done by t-test or Mann-Whitney test. In this case, p-value less than 0.05 was taken as constant. Predictive ability of the serum lactate and SOFA score was expressed under like ROC curve, expressed as the area under curve. Study participant: 135 male patients and 81 female patients. This table shows the mortality and complications among the patient with a complication frequency of 94 and mortality with a frequency of 21 out of 216 patients. This is a comparison of SOFA score and lactate at different time periods with and without mortality, which shows that SOFA score and lactate at L6, 6-star and L24 shows significance with a p-value of less than 0.01, and the SOFA score also has a higher mean of 9.67 in case of mortality. In case of complications, SOFA score and L24 was significant. Results: comparing lactate at 24 hours and SOFA score for prediction of mortality by ROC curve. In this, like, sensitivity of the SOFA was higher than L24, but both are sensitive. The SOFA score has a sensitivity of 92. In this, in comparison of complications, lactate was more sensitive than the SOFA with a sensitivity of 94. This is a comparison of predictability of SOFA score and lactate for mortality and complications. In case of increased SOFA score shows a linear relation with mortality in this patient with a similar p-value of less than 0.01 and mean being 9.67, which was more than L24. But in case of postoperative complication, lactate was a better predictor with a p-value of less than 0.01 than the SOFA score. Conclusion: risks of postoperative complication and mortality was associated with higher serum lactate levels. Lactate level recording at 24th hour postoperative has the highest predictive value of the adverse outcome with a p-value of less than 0.01 for both postoperative complication and mortality. Thus, early postoperative lactate levels in major abdominal surgery was a better predictor of surgical outcomes of the patient. Our study showed promise and confidence in establishing serum lactate level as a good predictive tool for postoperative surgical outcomes. This efficacy of the tool was further enhanced when we compared with SOFA score, where it showed improved accuracy in predicting outcomes. Thank you.
Very good presentation. So I just want to know whether you've taken elective patients only or elective or emergency both patients.
In this case, most of the patients were emergency cases, sir. Few elective cases were also taken.
So if we say there is presence of one of the causes of acute abdomen is bowel ischemia, where the serum lactate level is supposed to be more in or raised in comparison to the other patients.
Yes.
So it will induce an bias or problem in your study, because you have taken patients who are not having bowel ischemia as well as some patients who will be having bowel ischemia, where the serum lactate level will be increased much more than those patients who are not having bowel ischemia.
Sir, it will not create bias, sir, because we are comparing, like we are predicting the predictive ability of lactate. So that is our study. It doesn't create any bias in that.
Next, I want to know how do you raise the sample size of 216?
Sir, it's a convenient sampling, sir.
What do you mean by convenient sampling?
Sir, using the inclusion and exclusion criteria, with that criteria I took those, sir. Like
How you
I didn't with
so
other
you
morbidities.
should have a sample size calculation formula, and you should calculate the formula definite sample size, and subsequently you
Yes.
arrive at a sample size. Next, I want to know what was the outcome. Okay, you measured, you find that serum lactate was is a better predictor of postoperative morbidity. Does it translates into a better patient outcome, postoperative outcome in your patients?
So to know the better positive postoperative outcome, like this is for seeing the negative outcomes, sir, and complications and other related conditions.
How does the patient gets benefited by your study?
So further study are required to correct the hyperlactatemia. By correcting the hyperlactatemia, patient can be. This is for like knowing the complications earlier, sir. This less invasive and easily we can find.
Okay, thank you very much.
Thank you, sir.
The next speaker, Dr. Somdeep Patnaik from High Tech Medical College. I would like to ask again any award PG case candidate in the hall to please upload presentation in the backstage, please.
Good morning, everyone. Today I am going to present a paper on the topic a comprehensive retrospective study on the role of various management modalities for fistula in ano with an analysis on follow-up outcomes. Coming to the background, fistula in ano is an abnormal communication between the rectum or anal canal and the perianal skin through a tract. It is one of the most common causes of proctological surgery and can have impact on patients' anorectal function and quality of life. The main principles of management of anal fistula are closure of internal opening of the fistulous tract, drainage of infection or necrotic tissue, and eradication of fistulous tract with preservation of sphincter function. The objectives were to compare the various aspects like perioperative complication, mean hospital stay in the treatment of fistula in ano using various modalities like fistulotomy, fistulectomy, setons, lift, ERAF, etc. Preoperative evaluation of fistula in ano using radio imaging techniques provide a handy insight of the fistula anatomy and helps in planning the appropriate treatment strategy. Aims and objective, this study helps in evaluating and comparing the following parameters: demographics of all the patients studied, comparison of various radiologic features, site, size, location and all other parameters of fistulous tract, comparison of various hematologic parameters, comparison of aforementioned features with individual following various surgeries like fistulectomy, fistulotomy, mucosal advancement flap, etc. The parameters that would be post-operatively studied like incontinence, perianal pain, cord-like sensation, etc. Various treatment strategies adopted to overcome the complication, analysis on the effect of various comorbidities on the recurrence of fistula, analysis on histopathological examination of the excised fistulous tract, analysis on wound healing during the follow-up visits. Materials and method, place of study, Department of General Surgery, High Tech Medical College. Study period 1st January 23 to 30th June 24. Study design, retrospective descriptive analysis. Around 163 patients admitted to High Tech for fistula in ano treatment, out of which 138 patients were selected satisfying various inclusion and exclusion criteria. Inclusion criteria, all the patients admitted to High Tech for fistula and ano management, all patients giving consent for surgical management, both genders and other comorbidities included. Exclusion criteria, all patients with high-lying fistula requiring staging procedure, complex fistula with additional anal pathologies like fissure, hemorrhoid, rectal cancer, perianal abscess, etc. OPD treatments, loss of follow-up of patients who underwent surgery. Results, out of 138 patients, 94 were male, that is around 68%, 44 were female. Most commonly age affected group was 30 to 40 years. The most commonly performed radiological investigation was MRI fistulogram with perineal screening and followed by X-ray fistulogram. The most common type of fistula as per Parkes classification was intersphincteric, that is around 57%, followed by transsphincteric 23%, and the size of fistula tract ranges from 7 mm to 53 mm. Various hematological abnormalities like deranged LFT in 15% and deranged RFT in around 15%. Most commonly done procedure was fistulectomy, that is around 52%, and fistulotomy in around 32%. Others like 20%, which included lift, ERAF, setons, etc. So this is the sex distribution showing 68% male and 32% female. These are the fistula types like intersphincteric, transsphincteric, suprasphincteric, and extrasphincteric. The operative procedures like fistulectomy considered the major and fistulotomy the second one. Others also a major percentage. The most common complaint of patient post-operatively was perianal pain, around 47%. Rare complications like temporary fecal incontinence, post-operatively managed with conservative like bath, local anesthetic, laxatives are given. Other comorbidities like type 2 diabetes mellitus seen in around 42%. Histopathological examination showed non-specific inflammation in around 87%, followed by tubercular origin showed in around 5%. Wound healing by secondary intention showed in around 87%. Rarely any intervention like collagen powder dressing was done in 4% of patients. This is the X-ray fistulogram showing fistula in ano. This is some MRI fistulogram showing transsphincteric fistula. So it is a study of small group of fistula in ano cases with a moderate follow-up of cases. Nonetheless, this study gives very useful insight into the overall management of fistula in ano. The above findings are very much consistent with the previously available literature. MRI fistulogram with perineal screen was the most commonly used investigation modality, which is not in concurrence with the conventional line of investigation, that is X-ray fistulogram. But MRI report gave an accurate understanding of the underlying pathology, and hence an appropriate management could be done. In our setup, the most commonly performed surgery is fistulectomy, which yielded very satisfactory outcome. The various comorbidities increased the length of hospital stay by around 2.7 days after statistical analysis. Addressing these underlying comorbidities was an important for holistic management. Post-operatively, the histopathological showed non-specific inflammation. In maximum cases, a complete wound healing was observed during the long-term follow-up visits. These are the bibliography. Thanks. Thank you.
Thank you for your presentations. Nice presentation. I just want to know whether you have included simple fistulas or complex fistulas in your study.
No, sir. Complex fistula were excluded.
So, what is the purpose of then you included suprasphincteric, extrasphincteric fistulas? You think these are simple fistulas?
Sir, as per MRI finding, if the tract is simple, since various management modalities are being adopted.
A simple question. Do you think suprasphincteric, extrasphincteric fistulas are simple fistulas?
No, our study group has very minor percentage of suprasphincteric and extrasphincteric fistula. And all the staging procedure like transverse colostomy, if any kind of require.
How do you know clinically a patient who is having simple fistula, or by default in every patient you advise MRI?
No, sir. As per Goodsell's rule, we try to palpate the internal opening, try to find the internal opening as per the external opening. So if it is anterior, we try to see the induration in the anal canal. Low-lying fistulas were maximum included. High-lying fistulas were tried to be excluded from this study.
Questions from the audience, please.
So you concluded the study about June this year?
Sir, yes, sir. Around 1.5 years.
So what was the follow-up period of this study, after study?
Sir?
Follow-up period.
Follow period around 6 weeks to 2 months.
So have you got anything in follow-up period?
In the follow period, the complications were managed. Means the wound healing was observed good. Means secondary wound healing was observed. Recurrence was noted in very minor percent of patients.
So what is the incidence of recurrence in those follow-up period?
Means actually the exclusion criteria only I have excluded maximum of the recurrent patients.
You have not mentioned various modalities.
Sir.
What are the other various modalities you have not tried?
Sir, like laser means.
Laser, and what is cell therapy,
Sir.
stromal cell therapy.
Yes, sir.
Now has come.
Yes,
Do you
sir.
know that?
Yes, sir.
Okay,
Yes.
thank you.
Thank you, sir.
The next speaker, Dr. Akar Saswin from AIIMS Bhubaneswar.
Good morning, all. My TRAM trial, is based on the effect of local tranexamic acid in reducing axillary drain output following modified radical mastectomy. Disclosures: this interim analysis of this trial has been presented in the Clinical Congress of American College of Surgeons 2024. So, modified radical mastectomy, it is still the most common surgery performed for breast carcinoma in India, with the most common complication being seroma, incidence reaching almost 18%. Now, the etiology of seroma formation, fibrinolysis plays a part in that, and tranexamic acid being an antifibrinolytic, the potential role of this tranexamic acid is being studied in this trial. So the primary objective is the effect of local tranexamic acid in reducing the axillary drain output following modified radical mastectomy, and the secondary objectives being the time taken for change in drain character, the day of drain removal, the role of local tranexamic acid in reducing seroma formation. The follow-up was up to 3 months, and the complications related to the local applications like flap necrosis, SSI. So the inclusion criteria: patients more than 18 years of age who were diagnosed with breast carcinoma, who are undergoing modified radical mastectomy were included. Some exclusion like pregnancy, relative contraindications of tranexamic acid like DVT, pulmonary embolism were excluded. So total of 87 patients were assessed, out of which 78 patients were enrolled, and they were randomized into tranexamic acid group and the control group. The tranexamic acid group received 500 milligrams, 20 ml of local tranexamic acid, which was infiltrated into the axilla and the flaps, following the completion of axillary lymph node dissection. The non-tranexamic acid group received normal saline application. Following this, postoperatively, daily drain output monitoring was done. The drain removal was performed when the output was less than 30 ml for 2 consecutive days, and the patients were followed up at 1 and 3 months. So the 87 patients were assessed for eligibility, out of which 9 were excluded, 78 were randomized, and 39 in each experimental and control group, and the follow-up was for 1 and 3 months. The baseline demographics of the patients in the 2 groups, most were matched except for one, which was in the nodal stage. Proportionately higher number of higher nodal patients were in the control group. So the results: the mean cumulative drain output was higher in the control group as to the experimental group, which received the local tranexamic acid, almost 100 ml difference with a significance. The change in drain character, meaning from completely sanguinous to serous, was also significant in the local tranexamic acid group. The average drain removal day was earlier in the group receiving the local tranexamic acid as compared to the control group. However, there was no significance in the rates of SSI among the 2 groups, as well as the occurrence of seroma at the end of 3 months. So I would like to conclude: the local tranexamic acid application in patients undergoing modified radical mastectomy, it significantly lowers the postoperative axillary drain output, allowing us to remove the drain earlier. It also helps in early drain character change, and there is no reported complication, and it is safe. The local application is safe. However, there is no significant reduction in the occurrence of seroma at 3 months follow-up. The limitations of this study is that there is a higher number of higher nodal stage patients in the control group, and a relatively shorter follow-up for the occurrence of seroma and a smaller sample size. However, this local application of tranexamic acid holds promise, and a comprehensive study with a sizable sample and a higher or a variable dosage and extended follow-up is required for ascertaining the long-term efficacy of this application. Thank you.
Thank you for finishing within time. How you apply the local tranexamic acid?
Once axillary lymph node dissection is done, the local tranexamic acid is applied in the upper and lower flaps and in the axilla.
The time period, contact period time.
Around 20 minutes after application, the drain is kept clamped, and after the patient is shifted, after 20-25 minutes, the drain is opened.
Any study with the intravenous tranexamic acid? Have you done? Any comparison with the intravenous tranexamic acid?
No, sir, I have not done. Earlier studies have been done with the IV administration, which has proved no effect in the seroma occurrence.
What is the time period? Day 1 to day 5 or 7 days or 14 days?
They received divided dosage for 3 days, 500 mg TDS.
Okay. Any question? Audience?
So I just want to ask you, if there no question from you. So what about the energy sources used for dissection? There are multiple studies that compare ultrasonic dissector with cautery regarding the seroma and drain output. Have you standardized that?
Method has not been standardized in this study, sir.
And what about the patients, the tumor volume in this patient? Some patients may have a very small tumor, some patients may have a very large tumor, or if patients may have been receiving NSCT with a decreased immune response. So this may be induce some amount of, they will act as a confounding variables in your study.
Sir. But in the baseline demographics, these factors have been taken into account and they are matched in both the groups. The NACT patients and the tumor stage has been matched. However, the nodal stage, as I have mentioned, is relatively the higher nodal stage is there in the control group, which might act as a confounding factor.
So all patients has undergone the level 2 lymph nodal dissection, or some patients has gone?
No, sir, all patients have undergone level 2.
How do you know this is lymphoria or seroma?
Seroma patients who have symptoms, who come back to us with swelling, whom we advise compression and multiple aspirations, I have included them as the complication of occurrence of seroma.
Drain is there. Mostly they are seroma or the lymphoria. So when you are dissecting in MRM, you are dissecting the pectoral fossa, and the lymphatic plexus is under the fossa. And when you are dissecting the axilla, all the lymph nodes and the channels, they get damaged. So there is more evidence of lympharia, isn't it?
Yes.
Than seroma. Seroma is oozing from the flap. So tranexamic acid, I doubt it has a role in the lymphoria. Thank you.
Thank you.
Thank you.
I'd like to invite the last speaker for this session, Dr. Antriksh Mishra from AIIMS Bhubaneswar, and we are on time for class. Respected teachers, honor of the dais, and my dear colleagues, I am Dr. Antriksh Mishra, second year PG resident at AIIMS, standing before you to present my paper on efficacy of platelet-rich plasma dressing in chronic non-healing ulcer. A chronic wound is commonly defined as one that fails to progress to an orderly and timely reparative process to restore anatomical and functional integrity, generally persisting for 3 months. Usually, traditional wound care methods were including debridement was done. Now, platelet-rich plasma and collagen-based dressings are emerging options with potential to reduce wound healing process. Autologous PRP is generally used. After activation of the alpha granules, this causes release of the growth factors such as platelet-derived growth factors, epidermal growth factors, TGF transforming growth factor beta. These all stimulate fibroblast activity, extracellular matrix synthesis, epithelialization, and angiogenesis, which are all essential processes in wound repair. This present study aims to evaluate the efficacy of PRP in enhancing wound healing rates in chronic non-healing ulcers and to compare its outcome with conventional dressing methods focusing on rate and duration of healing and the incidence of complications associated with each treatment approach. Objectives of the study: primary objective to assess efficacy of PRP dressing in chronic non-healing ulcers. Secondary objective to study the safety of PRP dressing. The study was carried out in Department of General Surgery at PGIMR after obtaining IEC approval. This was a prospective case control analytical study. Randomization was done for cases and controls of 25 patients each. Duration of the study was 18 months. All patients attending surgery OPD were included in the study population. Sample size was of 50 patients. These are the inclusion and exclusion criteria. Patients aged 15 to 80 years with chronic non-healing ulcers, ulcer duration of more than 4 weeks, ulcer size less than 15 centimeters square, hemoglobin more than 10 gram percent, wound culture negative, platelet count more than 1 lakh per microliter, diabetic ulcer controlled, traumatic venous and trophic ulcers were included. Uh, Exclusion criteria: suspected and confirmed osteomyelitis, chronic kidney disease, severe infection, presence of gangrene or malignant ulcer, cellulitis and culture positive wounds. Methodology: patients meeting the inclusion criteria were randomly assigned to two groups, that is Group A and Group B. Group A received platelet-rich plasma dressing. Group B, that is the control group, received conventional dressing. Detailed history, including the onset, progression, and duration, was recorded. Etiological factors were noted. Ulcers were examined and photographed for follow-up. Also, size was measured in greatest dimension by the help of sterile gauge pad and metric scale. Coming to the processing of PRP, 10 ml of blood was added to the test tube containing anticoagulant cited dextrose. First spin was done. Upper plasma and buffy coat layer were transferred to empty tubes. This underwent second spin. A homogenized PRP sample was made by mixing lower one third along with the platelet pellets present at the bottom of the tube. This platelet-rich plasma was then injected at the healing margins using insulin syringe after cleaning with 0.9% saline. Dressing was done using a pad and roller bandage. In one setting, maximum of 5 ml of PRP was used. Follow-up was done for 3 months. Outcome measurement: the endpoint was complete wound closure or the conclusion of the follow-up period. Adverse effects of the PRP dressing were also noted. Coming to the results, the total 50 patients were randomized into Group A, Group B. Age among these patients, age ranged from 21 to 70 years and showed a male predominance of 2:1. Etiology of ulcer: majority of the chronic ulcer were located in the lower limb, of traumatic origin and followed by diabetes. As you can see from the table, majority are traumatic followed by diabetic. Also location: about 92% of the chronic ulcers were located in the lower limb. Coming to the days of healing completion, the average duration of healing was significantly shorter in platelet-rich plasma group, that is Group A. It needed around 8 weeks plus or minus 2 weeks, which when compared to the control group was around 15 plus or minus 5 weeks. Similarly, the number of dressings required for complete healing was less in the PRP group, apart from the control group, where it took around 46 number of dressings. In the PRP group, it was around 24 number of dressings. Complications: most patients, around 80%, did not face any complications, and among the few who had complications, about 20% had only pain and fever. Coming to the discussion, our findings indicate that PRP group had significantly shorter healing duration compared to the control group. This result corroborates with the Gugliani et al., who reported a faster healing in PRP treated wounds. The mean number of dressings required for healing was significantly lower in PRP group. This finding is consistent with Agarwal et al. Study, which also observed a reduced need for dressing in PRP treated wounds. Conclusion: in conclusion, our study meets the primary and secondary objectives and demonstrates that PRP dressing significantly improves healing rates without any adverse effects. Coming to the advantages of PRP dressing, from my study, it was opined that PRP dressing causes faster healing rates, can be prepared from patient's own blood. It is safe, more cost effective, can be done in OPD basis. But this study has limitations that of a small sample size and short follow-up duration, no universal protocol for standardization of platelet-rich plasma preparation. Further studies with large sample sizes and standardized PRP preparation protocols are recommended to validate these findings and enhance the clinical applicability of PRP in chronic wound management. These are some of the references. Thank you.
Thank you for the presentation. So I just want to know whether it is a case control study or a randomized control study.
Case control study.
So you have done a case control study. So
the patients were randomized.
The case control studies are usually done for very rare diseases. We go back particularly just you see lung cancer and smoking association. So this is probably if you are applying a new treatment, platelet-rich plasma, better it should have been a randomized control study.
For healing of ulcers, you need fibroblast more. The platelets, how it activates the fibroblast or any other factor,
Platelets.
epithelial growth factor you told. Because this is stimulating the epithelial cells or it is stimulating or recruiting the fibroblast locally by activating the local stem cells.
This platelet causes activation of local stem cells. These can release fibroblasts. Also, there is alpha granules which are present in the platelets, which upon activation release fibroblast growth factors.
Yes. So those releasing factors, fibroblastic and growth factors only help.
Yes.
But there is a potential risk of these platelets getting conglomerated, means aggregated and getting lost. How are you analyzing that? How you assess the after application it is working or not?
So that's why.
How many days after application you see the dressing?
Sir, dressing was changed every third day.
Third day. You only dress with normal saline.
Only control group was only dressed with the normal saline, and this group was dressing was done after injection with PRP followed by normal saline dressing.
So you assess the granulation tissue quality.
Granulation tissue, length and width of the size, ulcer size. Any discharges?
Okay, thank you.
Thank you.
For leading this session in the most streamlined manner.
State Chapter. Dr. C.R. Das, Director, Social Welfare, ASI Odisha State Chapter. Professor G.N. Mishra, Chairman, ASI Odisha State Chapter.
Dr. Sudhanshu, Organizing Secretary, ASI Odisha State Chapter. Dr. Manas Ranjan Sahu sir, Organizing Chairman of the conference as Vice Chancellor, OUHS. Professor Dr. Shantanu Sahu sir, Professor, Department of General Surgery, AIIMS Bhubaneswar. Dr. Sanjay Giri sir, Additional Professor, Department of Plastic and Reconstructive Surgery, AIIMS Bhubaneswar.
Thirty-ninth Osasicon here at AIIMS Bhubaneswar. On the first day, we were conducting the ASICON 2019 PGCME. And for that, I'm now requesting Dr. Siyardas sir to speak few words.
Thank you, Dr. Sutar, and all my senior friends, my honorary secretary and president of the association, and organizing chairman, Professor Manas Sau, and organizing secretary Sanjay, and all the seniors sitting there. And this my good morning to all of you. And today, actually, this PG day was concept after 2019 ASICON election, and the ASICON in 2019, and there actually we have thought of making academic show for the PG students, and we have decided that the pre-conference day should be a PG day exclusively dedicated for postgraduate students. And for that, we have planned out things with the EC, and all the EC members they agreed. And I now request Dr. Patnaik, who was the organizing secretary of the ASICON 19, to speak few words and to tell detail about this. Thank you very much, sir.
Thank you, Dr. Siadas. So I'll just try to just give you a brief about how this conference happened. This is the we had this conference in 2019, and Dr. Siadas was the organizing chairman, and I was the organizing secretary. So it took place in SUA campus, some hospital, and it was from 18th to 21st of December, and it was done in association with the SARC Surgical Care Society. So this I've already spoken. These are few glimpses of the conference. This was the presidential dinner on the 18th of December. This was the inauguration, and we had the ISRO chairman as the chief guest. This again the inauguration, the convocation taking place, and this is the grand show which we had on the inauguration day. So it was one of the memorable conferences, and we decided to contribute a sum of rupees 10 lakhs to the ASI state chapter, and it was mutually agreed to use this interest accrued annually to conduct this PGCME in the name of ASICON 2019, and initiative to carry out some academic activities for the upliftment of the knowledge of the postgraduate students and expand their knowledge also and disseminate knowledge. And an agreement was made on 31st August 2021 between ASICON, the organizer of ASICON 2019 and the Odisha chapter to initiate this PGCME in the name of ASICON 2019. That's how it started. And the first this CME took place in Kalinganagar, I think in 22, then followed by in 23 in Barampur. Now this is the third one. So what it was decided, 70% of the accrued money will be spent on providing medals, gold, silver, and bronze medals to the first three winners in the following categories: clinical presentation, paper presentation, PG quiz, and poster presentation. So Dr. Siardas and me will be permanent invitees, and will have the privilege of distributing the prizes in the inauguration ceremony. And this PGCME will be preceded, at least a 15-minute inauguration time will be there when we start, and should be on the pre-conference day of the conference. So this is a few glimpses again. This is a presidential dinner that took place during the conference. Before I thank you, actually this was initiated for the upliftment of knowledge of this postgrad student, but to my utter surprise, I see a few PG students sitting here. I think either we took a wrong decision, I don't know, Dr. Sialas, now we have to agree and we have to take a call in today's our EC meeting, and we have to change the, I think, mode of the petition. We should see at least 200 PG students sitting here. So my request to all the office bearers of the ASI Odisha chapter to take a call on this. Let us change the modality so that we want involvement of PG students. How we do that? It's you to take a call. Thank you very much.
Thank you, sirs, for your kind words. We all know that writing a thesis things of Goddess Saraswati will further proceed for the session. We all know that writing a thesis can feel like a never ending marathon. But don't worry, we have an expert here to guide you through the twists and turns that comes with the territory. The lecture will be taken as an online Zoom session by no other than Dr. Geetanjali Padmanabham. Madam has been our esteemed director here at AIIMS Bhubaneswar, founder director at AIIMS Guwahati, mentor director for AIIMS Kalyani, and an esteemed member of World Health Organization. Without further ado, I request Madam to kindly take charge.
You are muted.
Madam,
Yes, sir, I can hear you.
Madam, good morning. Am I visible to
Good
you?
morning. Hold the mic closer. I can barely hear you.
Okay. Is it audible now?
Yes, better.
Yeah.
Yes.
Manas here.
Yes, sir. Good
Yeah.
morning.
Good morning. Good morning, ma'am. So, just before you deliver your lecture, it's my privilege and honor to introduce Professor Gitanjali Padmanabhan, the ex-director of AIIMS Bhubaneswar. Ma'am is online homecoming for you.
Yes, it is.
Yeah. So, uh, Professor Gitanjali Padmanabhan doesn't need any introduction to the academic society across the country. I had the privilege and honor of working under her able leadership of this institution as a head of the Department of Surgery in 2018 to till the time I left AIIMS. But ma'am was there here from 2017 to 2022 as executive director of AIIMS, and she was in charge of other two AIIMS as well. And during my stay, I have seen her passion in teaching the subject which she is now going to deliver. And this is so very important for the postgraduates actually to learn. As just before this program, the director academics and director social welfare, they are telling that even though the PG day is meant for PGs, but we hardly see any PGs here. We only see only 30 or 40. Ma'am, don't worry. We are making it online and we'll be live streaming it because nowadays PG students are also very busy, like the faculties and consultants. So they also don't have time for the day which is meant for them. So it's a pleasure and honor for me to welcome you for this online event. And I'm pretty sure your deliberations will go a long way in training our postgraduates in knowing the art of thesis writing, the techniques, tips, and the trims. Thank you very much, and it's a pleasure. It's the air and the auditorium, everything is yours now. Thank you, ma'am. Please.
Thank you. Thank you, Professor Manas Sahu, for that introduction. And as Vice Chancellor of OUHS, I'm sure you will take this fledgling university to the next level. So I am extremely happy to be a part of this program. So today I'm going to talk to you about something which is very close to my heart, the art of thesis writing, techniques, tips, and triumphs. This topic was given by Manas. So I'll just start off by saying that I really don't believe there is an art in thesis writing. It is purely science, and more than science, it is attention to detail. So whether you are writing a fantastic thesis, whether the quality is really good, it is pure science. And that is what we need to keep in mind when we start writing the thesis. So as the saying goes, it always takes two to tango. And who are the two? One is the guide and one is the student, the resident, the postgraduate. So the postgraduate as well as the guide need to collaborate closely together, be on the same page in order to come out with a good quality thesis. And if they are not in the same page and they're fighting like cat and dog, it's not going to happen. So this is something which has to be kept in mind by both the postgraduates as well as the guides. So I'm going to talk to you a little bit because it's a 15-20 minute talk, and obviously this is a very large topic. So I'm not going to talk about how to do research or how to do good quality thesis, but it's more about the logistics and the bringing out of a thesis and later on. So I'm going to talk a little bit about the execution of work, how to aid, how the guide can aid in writing and submission, and the student also can help in this and facilitating the defense and in publishing. So this is what I'm going to talk to you very briefly. So the first thing is about facilitating execution of work. There has to be regular meetings of the guide and residents, at least once a month, and it should be one-on-one, in which the guide knows exactly how the thesis is progressing. If you tend to meet only once in 3 months or once in 4 months, it's not enough. So regular meetings is a must. And then we also need to meet with the rest of the team. See, generally what happens, these co-guides, they behave as if they are some, they've given their name in this and they have no role to play in actually making the thesis. And that's a very wrong way of looking at it. So we need to have meetings with the co-guides also. Perhaps 2 times a year should be good enough. But the co-guides also need to know exactly what is happening. I used to insist when I was a guide, now it looks like a very long time back, that the guide has to maintain a logbook for all the laboratory work or the clinical work. Whenever he, examines a patient, he needs to have a logbook which will give all information to be recorded. This will also jog his memory. It might be nowadays people use notebook or something like that, and that's fine. But there has to be a physical record of what is done on a day-to-day basis when you are collecting data. I insist on that. How else can we facilitate execution of work? Generally, what happens, photographs get forgotten. And suddenly, when the thesis is going to end, you realize that you need some photographs to put into your thesis. So you need to take photographs from time to time, and then you can upload it in a drive or wherever you want to keep it. And then copies of all approvals. See, finally, when you're writing the thesis, you will need your ethics committee approval or the research committee approval, whatever approval is needed. Or if you are doing some outreach program, perhaps you will need permissions from wherever you are doing the work. So all approvals have to be filed, and then consent forms. See, ethics is vastly ignored, especially in academic thesis. And suddenly people wake up when you have to publish, then there will be one line saying that ethics committee approval was got. But this is the job of the guide. You have to insist that the postgraduates see that the consent forms are signed, and then reports of patients, whether it matches with the master chart. See, what happens is when you finally get all the reports and you check the master charts, there will be somebody who is, their age is not within the inclusion or exclusion criteria of your study. You will find that supposing the study is all done on all females, you might have some male who has been put in, or the form has been filled in as a male. So this kind of checking, no, if you keep it to the end, and somebody has to have a data set of, let's say, 100 or 200 patients, it becomes very difficult to check. So I would suggest that you take small chunks and check from time to time whether the entry into the master chart matches with the actual reports. Now let's go on to writing and submission. So the guide should encourage the resident to start writing early. Actually, you can start writing the thesis once data collection is underway. Many times it doesn't happen. The common mistakes we make is to wait till the last 3 months before submission to start writing. That's enough. There is more than enough time. See, actually, 3 months before submission, that is the time when the student, the postgraduate, also starts seriously studying for his exam. So he cannot actually give a lot of time. So don't wait for the last 3 months to start writing. Many guides think that it is too early to begin writing in the first year. Actually, this was a advice which was given to me by by a senior postgraduate in pharmacology, who said, by the end of first year, please start writing your methodology and all that. Because by that time, of course, our time there was no computers, we had to do everything by hand. So there were multiple revisions we had to go through. So the guide also feels that PG will lose interest. Nowadays, because we are using computers, it is never too soon to start writing. So what parts of a thesis can be written early? Obviously, review of literature, because you have done a lot of review for identifying the topic and also for your protocol writing. So you will have a good review of literature. You can always write. You can add on later. So there is no fear of, that this is the final thing. It's nothing like that. So you write, and then towards the end, you can read and add whatever needs to be added on. Certainly, the methodology, once the protocol is approved and your ethics committee has approved it, your methodology is not going to change. So your methodology can certainly be written. Of course, introduction, we tend to write it much later, but that can be written. I would also ask dummy tables to be written early. If you start thinking about the analysis and how your results are going to be presented, that would be a wonderful thing. So your dummy tables can all be ready. Only thing is, when you finally finish data collection, finally finish the analysis, you only have to populate your dummy tables. It actually makes work much, much easier. How do guides support the writing up? First is, guides should provide draft guidelines or templates for students or residents to find it easier to write their thesis. I'll give you an example. For example, supposing the resident is writing his discussion, the guide's job is to provide the template. So if I am guiding a student, I would say, okay, discussion, write your discussion under these 5 uh, headings or subheadings. State the main findings, compare results with other studies. What are the strengths and limitations of your study? Can you explain the unexpected results? What are the conclusions? So, if you are able to guide your resident to write the discussion under these 5 headings, your work is done. For the student also, it becomes very easy. Instead of saying, go read and write the discussion, your discussion is not good, it is very vague. So once you give a template, for example, if it is the introduction, what is the background, what is the problem to be studied, what are the objectives? So you break it down, then it becomes much easier. So provide draft guidelines or template. That's how you can support your resident. You can also support him by collecting full text papers, which will be good to cite. So many students do not download full text papers. They only read the abstract and try to write from it. This is something which we all should discourage. Read paper. You have to discuss topics which are linked to the thesis, so that the resident as well as you get a good understanding of the topic. So it is good that once every meeting, if you're having a meeting once a month, certainly you can discuss 2 or 3 papers, the gist of it together, so that you can think of what aspects of this paper should be cited in the thesis. And of course, you will have to help him with tables, figures, statistical analysis, and so on. Now, my way of doing it is, find out what the university wants as per the guidelines. What is the font size? What is the I mean, do you have to have double? Is it you have to give margins? How much margins do you have to give? What is the style? What is the reference styles? What style do you want to use? Do you want to use Vancouver, or do you want to use Harvard? So if you know that, please stick to that so that it becomes very easy. In the final thesis, there is not much to change. So find out the style and write your thesis, all your drafts in the same style so that you don't have to do much changes into the final editing. Okay, now what the guide has to do. So the guides who are here, I think this is something for you. And of course, for the postgraduates, they know what the guide is expected to do. So how do you support the submission of the thesis? First is the guide has to proofread carefully. It doesn't matter if you are using MS Word or you are using some software. We know that in English there are lots of words which with one letter or two letters, it has a completely different meaning. So you have to proofread very carefully, read each and every aspect of the thesis. Preferably, I generally use the review part of MS Word so that all your queries, everything can be done online if you are comfortable doing that. And you need to check very carefully. I had a problem with one of my own thesis student. For microgram, he had used this mu and then g. But when it got printed, because he was using a different software for printing, this was some time back when we used to use this Aldus PageMaker and all that. So they used a different software for printing. That mu got changed to m. So microgram became milligram, and the examiners were furious because they said, how can he make such a basic mistake? Actually, it was not his mistake because we did all the proofreading, we did it on one software, printed it on another, and we didn't realize that the software had changed the mu to m. Also, when you are the guide and the student should be with the same version of the software. Even in MS Word, you have a lot of word jumbling and things like that. So that is preferable. And then you need to check certificates. Literally, the guide has to check every single thing that goes in because ultimate responsibility is with the guide. You can't say, oh, my student was bad or my student was not very careful or something like that. How do you facilitate or prepare for the defense? If the thesis is returned with comments, you need to address each and every point in a table form. That is the best way of paying respect to the person who has given your comments. So make a table, say this is the comment which was made, this is our response to it, this has been modified in the thesis on this page, and send it back so that both the dean or whoever is looking at your comments and your reply, as well as the examiner, are very clear that you have been open and you have addressed each comment. And you need to revise and send whatever the university says. If it is a major revision you have to do, you might have to do that. Now, before a clinical or practical exam, you have to train the postgraduate how to present his thesis. Sometimes postgraduates even tend to forget the title. I know of postgraduates who don't even know their title. So you will need to be in a position to train them to present their thesis, go through the slides and so on. Also get him to rehearse in front of the faculty and peers, and more importantly, write down expected questions so that he is in a position to answer the questions confidently. This is something because I think now NMC gives about 20 marks for thesis defense. So you will need to prepare your students to be able to defend their thesis very confidently. Now I come to publishing. I would suggest you send for publication before the exam. Find some time because you need this. Gives a lot of confidence for the students, and it is good for you, your institution also, because you can say our conversion rate of thesis into publication is very high. Right now, it is extremely low, especially in medical colleges. We generally consider it unethical if it is not published, and you need to train the postgraduate to select the journal and prepare the manuscript. It has to be prepared in its own way. So try to do that before he goes in for the exam, into that exam preparation mode and so on. I believe it is the guide's duty to see the publication through. Many guides say it's not my business, it's his thesis, he should publish it. I think if you are a guide, it is your duty to see it is published. As I said, if it is not published, it is unethical. More importantly, it gives a good standing rating for your department as well as your institution. So, what are the common mistakes made by guides? One is thinking everything can be done in 3 months. Okay, 6 months before we start they have to submit, you wake up and say, ah, no problem. In 3 months, we can write the thesis. That is a very common mistake. Guides also tend to trust a lot, sometimes trust too much, and that's not good. You need to mentor and supervise quite a bit if you want to have a good quality um, uh, thesis, which is publishable quality. And so guides as well as postgraduates, they take it lightly, we have lot of time, we have lot of time, until you wake up and think that there is no time. The other mistake which people make is they think that examiner won't read the thesis. There are a lot of examiners now who know that research is being given a lot of weightage, unlike it was previously. So they do take the trouble. And I know even in good institutions of national importance, theses have been rejected. So don't think the examiner will not read the thesis and get a rude shock. So for all the guides, I say you should trust your postgraduate, but you should also verify, because there is a thin line between what is a fact and what is fake. So theses are rejected for a number of reasons. Sometimes plagiarism, frank plagiarism, obvious signs of cooking up. You'll find the total number of patients in the methodology is different. In your tables, it's different. In the final results, what you have written, it is different and all that. So if there are too many errors, it gets rejected. Sometimes references which are not cited are for that reason theses have been rejected and all that. So there is no one hard and fast rule why theses are rejected. Depending on what the examiners believe is very important, so examiners may reject when if they feel very strongly about it. So there are a lot of issues, some of which I may not even agree why the thesis is rejected, but then if it is, then it is up to you to be able to explain it. So some key tips already spoken. Start the writing process early. Full papers must be downloaded and read. I would say printed. Don't worry about cutting down trees, but you should read it and print. It should be printed and read because it's much easier. You can have it in your bag and read it wherever you go. Meet with your postgraduate at least once a month. Review literature continuously. And then plan data analysis early and document the decisions taken. Sometimes decisions are taken at guide, co-guide meetings. It's not documented. And then finally, the co-guides will complain saying that I had told this and this change was not done. So for these reasons, you need to document minutes of the meeting. So finally, what do examiners expect? Examiners expect a reasonable quality of work. They expect a fairly well written report. They expect it to have been done ethically and should have no or very few mistakes. And the examiners also know that this is not PhD kind of work. It's not earth shattering work. So the examiners, they know the limitations of a MD or an MS thesis in general. So they're not expecting a great amount. But if that also is not addressed, then you have a problem. So to address the topics which I was given, so what are the techniques? I will say use technology. We cannot say I don't believe in technology. I am a old fashioned guy. This won't work. You have to use technology. Whatever software program you want to use. Now I think everyone uses MS Word, or I frequently use Grammarly, not frequently, continuously use Grammarly. It makes life so much simpler for me, because for me also English is a second language. You can use Mendeley or Zotero for your all your references, and you need to save your work either on the cloud or somewhere where it is safe. You also need to use statistical software which you will understand. People are very proud to say I used SPSS, but majority of people are not aware how SPSS interprets your data. So I'm sure it will be in your mind. So what about use of AI? Of course, people are using AI rampantly. If your university guidelines permit it, go ahead and use. But generally, for journals are very clear. If you have used AI, that has to be mentioned in the methodology that you used it for whether your search criteria, the prompts have to be described, and if you have used for whichever parts of the manuscript you have used AI, you have to mention it. So that is very important. So find out from your university whether they allow you to use chat gpt or one of these things to write the introduction or something like that, because if they don't, and if your examiners find out, your thesis may get rejected based on use of AI. So please make sure the rules are very clear on that. So you need to know the rules. As I said, get a copy, go through it carefully, and all these things, reference, certificates, everything, you should know before you start writing, so that you start writing in the correct way right from the beginning. So that's one tip I would like to give you. The second tip is plan with the last date in mind. So don't go rushing in, so that you need adequate time. Guides also take time to review. As I grow older, I take a longer time to review articles. So you need to give your guides adequate time to review your thesis. So residents, please give them sufficient time to review it carefully, so that you won't be left with a poor quality thesis, and you need to submit before the last date. So start writing early. This again I have already told you, so I'm not going to go through this, but I will go through this last thing. As you collect data, ensure all data points are filled. This is very important, a very important tip, because when you are going to analyze your data, this will hold you in good stead. So what's the triumph? That's the last word on my title. The triumph is when you present your work in conferences. And if there is a prize session, as a postgraduate, you should participate. And if you win a prize, that will be really very good for you as well as the institution. So you need to publish your work, at least send for publication before you appear for the exam, and then publication process can take its own time. So if in order to have your paper accepted, you have to go through all this. I'm sure you would have gone through this cartoon very much. So similarly, for a thesis to have a really good ending, like good publication or prize winning at a conference, there are a lot of hurdles which a postgraduate and the guide has to go through. But I'm sure that with a little bit of help, with a little bit of hard work, and a little bit of not putting off things till the last date, things will be on the track. Thank you very much for a very patient hearing. I'll be happy to answer questions.
Thank you very much, ma'am, for that wonderful deliberation. Before I give my comments, I invite questions from our learned postgraduates. You have anything to ask? How to write a thesis? In fact, this is one very important for any postgraduate who is in an academic institution. So I think, ma'am, you have made things so clear to them that they don't want to ask any questions.
That's okay. I was worried about the time also.
No,
So I
it's
think
fine, ma'am. The thing is, I am actually best suited in this audience. I have seen medical colleges and how thesis is given importance, in what way it is given, which is given the least of importance. I have seen AIIMS also from a very close quarter, how much importance is given to a thesis writing, and how dedicated faculties are in guiding students for the thesis. And the last, the triumphs that you talked of. Probably postgraduates are sometimes not given that tip to the students, that if you do this kind of labor, it is going to fructify at the end, and you will only relish and enjoy that journey. Probably that is also needed to be told. So after taking over, I have taken a small effort in actually educating the faculties in all medical colleges of the state, and the first program went up very well for the faculty development. The next I am in line is the TOT program for the faculties. 30 faculties from 7 postgraduate institutions will be called. They'll be trained in research methodology and all about all the nitty-gritties. And they'll be sent back to the colleges who will be training the newly joining postgraduates as well as the faculties, because it has to start from the top. The faculties, as you told, what a guide actually need to know. Most of us actually, we do not give that importance what actually the postgraduate need to do. Once the faculty knows that I need to do this, then probably things will flow in a much better way. So it was a wonderful session, as was in my mind that this is one session will catch the attention of postgraduates, and you'll be happy to know whatever the audience you see in the audience in this auditorium, more than 10 times are live streaming and they're watching you, and it is recorded, ma'am, and I will put it across all medical colleges, postgraduate medical colleges, for the postgraduates actually to get the tip and the guides to be trained. Thank you very much for
Thank you.
accepting my request, and thank you very much for
Thank you, sir.
giving
Thank
your
you.
time. Thank you, and once again, I, on
Thank you,
behalf
sir.
of the organizing committee, thank you. Thank you, ma'am.
Thank you, sir.
Coming up next, we have our award PG case presentation. I would ensure you that your next few
our side or from your side?
So from our first speaker for the award PG case presentation session, is a case of thyroid swelling, Dr. Swayam Siddha Swai from SAP Medical College, Cuttack.
Good morning, everyone. Respected chairpersons, esteemed faculties, and delegates. I'm Dr. Swayam Sudha Swai, a postgraduate second year from SB Medical College. I'm here to present a case on thyroid swelling. A 46-year-old gentleman, a Hindu by religion from Bhubaneswar, or tailor by profession, presented to the OPD with the chief complaint of a swelling in front of the neck for the last 3 years. He was apparently alright 3 years back. To start with, his family members noticed a swelling in front and lower left side of the neck, which was insidious in onset, initially small in size to start and gradually progressive to attain the current size, which was approximately 5 into 4 centimeters. The swelling is not associated with pain over the swelling, sudden increase in size, fever, change in voice, or difficulty in breathing, or difficulty in swallowing. No, there was no history suggestive of hyper or hypothyroidism. There was no history of cough, breathlessness, or back pain. No other swellings in the neck region or body. There was no visual abnormality. There was no history of any neck swelling in the past, and no past history of irradiation to head and neck region with or any surgeries in the neck region. He is not a known case of hypertension, type 2 diabetes mellitus, coronary artery disease, pulmonary tuberculosis, asthma, or epilepsy. There was no history of drug intake for any chronic illness. There was no history of any thyroid swelling in the family, no history suggestive of first degree relative affected with thyroid, parathyroid, or adrenal malignancy. He is married since 30 years and is blessed with 2 children. He belongs to a low socioeconomic status. He takes mixed Indian diet with iodized salt. There is no history of excess intake of any goitrogens. He is not addicted to tobacco or alcohol. His sleep pattern is normal with normal bowel bladder habit. He is not allergic to any drug or food. On summarizing my history, a 46-year-old male from Bhubaneswar presented with a slow-growing painless swelling in front and lower left side of the neck since 3 years, with no evidence of any pressure symptoms or local invasion, and no features suggestive of hyper or hypothyroidism. I've examined the patient in a well-lit room with informed consent and proper exposure. He was conscious, well-oriented, and cooperative, with an average body weight and well-nourished. His BMI was 24.2 kg per meter square. His Karnofsky performance score was 90. He had a normal facial expression and was well hydrated. His vitals were he had a pulse rate of 78 beats per minute in right radial artery with regular rhythm and normal volume with no radioradial or radiofemoral delay. His blood pressure was 130 over 80 millimeters of mercury in right arm supine position. His respiratory rate was 18 per minute thoraco-abdominal. His temperature was 98.8 degree Fahrenheit. He had no pallor, no icterus or cyanosis, clubbing, or generalized lymphadenopathy or bilateral pedality. He had no eye signs related to thyrotoxicosis. His skin, hair, and nails were normal. He had no engorged veins on neck or chest. His upper limbs had no tremor. Skull and spine were normal. On local examination, I have examined the patient in sitting position from front and back. A single ovoid swelling of size approximately 5 into 4 centimeter present at the lower anterior and left side of the thyroid region. Which moves with deglutition, and the inferior border was well appreciated. As you can see, it was extending superiorly up to the upper border of the thyroid cartilage, inferiorly up to the above the suprasternal notch, medially crossing the midline, laterally up to the anterior border of the lower third of the sternocleidomastoid muscle. It had a well-defined margin, smooth surface, and normal oval-like skin with no scar marks or visible pulsations. Trachea appears central. No other swelling noted in the same region or both sides of the neck. This is the video. This is the video showing movement with deglutition. On palpation, there was no local rise of temperature or tenderness over the swelling. A single swelling of size 5 into 4 centimeter in lower, anterior, and left side of the neck, with extensions confirmed as on inspection. It had a smooth surface, regular border, was firm in consistency, with no fixity to skin and platysma, and mobile in relation to the deeper structures. The inferior border of the swelling was well appreciated. Bilateral carotid pulsations were well felt in normal position with respect to the swelling. Trachea was central in position, with no cervical lymph nodes palpated on both sides. There was no palpable thrill. These are the methods of examination. On auscultation, there was no audible bruit heard over the swelling. On systemic examination, first and second heart sound were heard normal with no murmur. There was a bilateral normal vesicular breath sounds with no added sounds. Per abdomen was soft, non-tender, no organomegaly, and bowel sounds were normal. He had normal higher mental function with intact motor and sensory functions. His spine and proximal group of muscles were found to be normal. On summarizing my case, a 46-year-old gentleman presented with a swelling in the lower anterior and left side of the neck in the thyroid region for 3 years, which was insidious in onset, gradually progressive, with no pressure symptoms or signs of hyper or hypothyroidism or any signs of distant metastasis. On examination with stable vitals and normal general physical examination, a single ovoid swelling of 5 into 4 centimeter involving the left lobe and isthmus of the thyroid with well-defined margin, smooth surface, firm consistency, normal overlying skin that moves with deglutition, mobile with respect to deeper structures, with no retrosternal extension, and carotid pulsations palpable, and with no cervical lymphadenopathy. My provisional diagnosis is a solitary thyroid nodule of left lobe, possibly due to a benign etiology and clinically euthyroid state without any retrosternal extensions.
What investigation will do for confirmation?
Sir, we do a triple assessment for the thyroid swelling, which includes history and clinical examination, along with high-resolution ultrasound, and along with that, the biochemical test, including the thyroid function test. And based on the findings of ultrasound and thyroid function test, we proceed on to cytology.
You told the swelling moves with deglutition.
Yes, sir.
What about the protrusion of the tongue and its relation to its movement?
Sir, usually the movement with tongue protrusion is seen for upper midline swellings. But since it is a lower swelling on the lateral side,
So movement with protrusion is usually not done in examination.
Okay. Now, what are the eye signs? As you told in thyrotoxicosis, what are the eye signs?
So eye signs are related to the primary thyrotoxicosis. For example, von Graff's sign, Zoproy's sign, Mobius sign, and Stelwach's sign, and Dunlop sign.
All these were absent in your case.
Yes, sir.
Can you examine to say that it is not related to platysma? You told skin and platysma.
Yes, sir.
What test told you it is related to platysma?
Sir, we do the skin pinching test. The skin was pinchable from the swelling.
Agreed.
Yes, sir.
What about platysma? Why did you specifically mention platysma?
Sir, platysma is the muscle which helps in facial expression. When we do extension of the neck, it was movable after extending the neck.
I couldn't follow. When you extended the neck,
Which type of muscle?
Subcutaneous muscle.
So, how will you test for platysma?
Sir, along with skin pinchable test, it is actually attested, sir.
how could you know clinically it is not a retrosternal swelling?
So clinically, on examination, the inferior border of the swelling was well appreciated, from which I could know that it had no retrosternal extensions.
Any other examination?
But for that, we have to do a Pemberton's test for in the patient.
And inspection, palpation, percussion?
Sir, usually if the lower border of the swelling is visible, then we need not proceed on to percussion.
If you percuss, what will happen in retrosternal goiter?
Sir, the percussion will be dull. It will be dull on percussion if there is a retrosternal extension.
Now it is to the house. Then we can continue. It's okay. Investigation. So how do you proceed? As Dr. Mahanti told, you did FNSC.
Yes, sir. I'll proceed on with the triple assessment for this test, which includes the history and clinical examination.
That you finished.
Along with high resolution.
Clinical is finished. What more you want to?
I'll proceed with ultrasound of the neck and thyroid function test. And based on that, I will proceed on to cytology.
First, you will do ultrasonography. What do you expect in this case in ultrasonography?
Yes, sir. For my patient, since my provisional diagnosis is a benign etiology, I would expect to get a pure anechoic cyst, or I can get a colloid nodule in this case.
What was the percussion finding over the swelling?
Sir, the percussion is not done here because since it is a mobile swelling, we do not do percussion over thyroid swellings.
Why? It's a swelling.
Yes,
you examine the swelling.
Yes.
Inspection, palpation, percussion, auscultation. What are the percussion finding over the swelling? Is it a solid?
Sir, percussion is usually not done for a thyroid swelling since it is not fixed. Since it is mobile, sir, usually the percussion is not done on a thyroid swelling.
So no percussion in a mobile swelling.
No, sir.
Okay. So, do you think it is a solid or a cystic swelling?
Sir, I feel it is a solid swelling.
So, what do you expect in ultrasonography?
Sir, in ultrasonography, I expect I expect the low risk features of malignancy like colloid nodule with no microcalcifications, with no.
Ultrasound can show you it is a colored goiter.
No, sir. With.
What is the role of ultrasonography in a solitary thyroid swelling?
Yes, sir. It will show the entire thyroid gland. First, we can see the entire thyroid gland, its size, location, as specific for the nodule.
Also. It can change your diagnosis because you are telling it is a solitary thyroid nodule. But when the patient will undergo ultrasound, it may come as multinodular.
Sir,
Is
we
it
will
possible or not?
Yes, sir. We will see the size, location, and characteristics of the nodule, and we can see the cervical lymph nodes in the ultrasound. Yes, we will see the size, location, and the characteristics of the nodule.
Is the cystic swelling or a soft swelling? Can it be differentiated
By ultrasound or not?
Yes, sir.
And when you fail in clinically, it looks like a solid swelling.
From the consistency, we can know the consistency whether it is a cystic or firm swelling.
In ultrasonography, you got a cystic swelling.
Yes.
Clinically, it was a solid swelling. Please tell me what is the correlation?
Sir, it can be a tense cystic swelling.
Yes, what are the conditions when a cyst will be tense? Thyroid.
Is it possible to, in a thyroid swelling, is it possible clinically to know whether it is cystic or solid?
Clinically, it is not exactly possible, sir.
Why?
Sir, because there is a thing called thyroid paradox. Because in thyroid, usually when the cystic swelling is very tense, it feels as if it is hard, and in soft tumor cases, if there is necrosis, then it can feel as soft. That is known as thyroid paradox. So we cannot be confirmed. We cannot be confirmed that whether it is exactly a soft or cystic swelling. So a solitary thyroid nodule is a discrete swelling when the rest of the gland is impalpable, and a dominant swelling is known as if it is a discrete swelling in an otherwise clinically palpable gland.
So, what other investigation will do for this patient?
How to proceed? You did a FNS.
Then?
You did ultrasonography.
Yes, sir. Then I'll proceed with cytology of the swelling. Yes, sir.
For tissue diagnosis.
Yes, sir.
Cytology does tissue diagnosis.
Cytology for cell diagnosis. Cytology for cells. It is actually FNAB, that is fine needle aspiration biopsy we take nowadays, which can tell about the tissue diagnosis.
So FNAB is better than FNAC.
Yes, sir.
Then?
Sir, based on cytology findings, it is categorized into Bethesda classification systems, and based on that, I will proceed on to for a conservative management or for a surgery.
Suppose it comes colored goiter.
Yes, sir.
Whether you will operate or not operate.
Sir, for my patient, since the swelling, the size of the swelling is greater than or equal to 4 centimeter, I would go for a left hemithyroidectomy.
Suppose comes hyperplastic goiter.
Sir, if there are toxic features, then I will first I'll try to bring the patient to euthyroid state, and then I will proceed on to surgery.
No, here there is no features of toxicity.
No, sir, there is no toxicity. If there is
so I am asking whether hyperplastic goiter is reversible or colored goiter is reversible. Which one is reversible?
Sir, hyperplastic goiter is reversible, but colloid goiter is not reversible.
When colored goiter occurs, means it will never regress.
Yes.
Then what you will do?
Sir, my first differential diagnosis is a colloid nodule. If it comes out to be a colloid nodule of greater than 4 centimeter, I'd go for left hemithyroidectomy of the patient.
Clinical examination have told it has involved the isthmus of the thyroid.
Yes, sir. On examination, it was crossing the midline, sir. Yes.
Okay. Now your treatment is hemithyroidectomy.
Yes, sir.
If it comes out to be a solitary thyroid nodule.
Yes, sir.
In ultrasonography, it comes out to be a multinodular goiter. What is your line of management?
Sir, Sir, multinodular goiter, I will see for whether.
Clinically, it is a solitary thyroid nodule to you.
Yes,
Now we did a ultrasonography, it came out to be a multinodular goiter.
Yes, sir.
Will your treatment plan change?
Sir, I will subject the patient to a left hemithyroidectomy, and then if there is provision, then I'll send for frozen section biopsy, and based on that, I will proceed.
Frozen section biopsy for what?
So to see if there is any malignancy,
Any?
any malignant features.
No, you did FNAC, FNAB, you confirmed it's a benign tumor. Clinically, it was involving the thyroid gland, as also left lobe and also isthmus.
Yes, sir.
And ultrasonography told it's a multinodular goiter. What is your line of management?
Sir, I will go for a
Still hemithyroidectomy or anything else? It came out to be a multinodular goiter.
Sir, if the multinodularity, it is involving the left lobe and isthmus and the contralateral lobe also. If it is multifocal, then I'll go for a total or near total thyroidectomy.
Multifocal in a benign tumor. What do you mean by multifocal in a benign tumor?
Sir, if it involves both the lobes and isthmus of the thyroid gland.
Okay. Thank you.
Thank you.
Oh,
Completely examine the candidate, then audience may ask some questions.
now you can ask. Yeah, yeah. No more question.
Okay, I'll ask one question. You said it's a case of solitary thyroid nodule involving the left lobe. The entire left lobe, if it is involved, do you say it's a solitary thyroid nodule? If the entire whole left lobe is involved, do you want to change your terminology?
No, sir. If there is a discrete swelling when the rest of the gland is impalpable, I would say it as a solitary thyroid nodule.
No, the whole gland is involved and the whole gland is a nodule. Do you say a solitary thyroid nodule or something else? You said the difference between a discrete nodule and solitary thyroid, dominant nodule and solitary thyroid nodule, right?
Yes, sir.
So if the whole gland is involved, would you like to change your terminology from solitary thyroid nodule to a nodular goiter of the left lobe?
Yes, sir. It will be now known as a nodular goiter of the left.
Both are roughly used as the same terminology nowadays actually. That's okay. Next. You said percussion has no role on thyroid swelling.
So percussion is not done over the thyroid swelling.
Okay.
Per se.
Tell me one situation where you need to go for percussion and get some findings which may add on something to your diagnosis.
Sir, if it has a retrosternal extension, we will do percussion over the manubrium structure.
Yes. So that is the role that you would have answered to your examiners. The examiner is again and again asking what is the role of percussion. You never said that. If it is a retrosternal extension, you go for a percussion and what do you get there?
We'll get a dull note over the.
If you get a dull node over the manubrium stone, it indicates
There is a retrosternal.
there is a retrosternal. Very good. Now tell me what is the extent of enlargement of a thyroid gland?
Sir, it extends in the thyroid region itself.
What do you mean by a thyroid region?
The thyroid region extends from the middle of the thyroid cartilage
Yes.
to suprasternal notch,
Yes.
and laterally between the bilateral carotid sheath, and medially.
Can you clinically make out the carotid sheath?
No, sir.
So what is the other anatomical landmark of the lateral
Anterior-
extent of the thyroid?
Anterior border of the sternocleidomastoid.
Yes, the medial border of the sternocleidomastoid on either side. Right? Okay. What are the causes of pain in a case of solitary thyroid nodule?
Sir, if there is a hemorrhage into the swelling,
Yes.
or if there is inflammation in the swelling in
Yes.
thyroiditis, or in cases of late stages of malignancy also there is pain in the swelling.
Okay. What about perinuclear invasion in a malignant thyroid swelling? Will it cause pain? Yes.
Yes, sir.
So, what are the situations where you think probably this thyroid swelling is a malignant swelling? A previously diagnosed benign thyroid nodule has turned into malignancy. What are the features?
Sir, if there is a rapid change in size,
Yes.
or if the nodule becomes hard,
Yes.
fixed, immobile, or if others, or if there is other features of malignancy include male sex, And if there is any history of irradiation to the neck or history, positive family history, you can suspect. Or if there is difficulty in swallowing or difficulty in breathing, also we can say it
You
as
can
a
suspect probably there is malignancy. Okay. You said in your case, because it's a solitary thyroid nodule of 4 centimeter size involving one lobe, you will go ahead with a hemithyroidectomy. So now after doing hemithyroidectomy, suppose it comes out to be a case of papillary carcinoma thyroid, what you do?
Sir, I would go for a total thyroidectomy of the neck.
What do you mean by completion total thyroidectomy?
Sir, I would go and I would do the total thyroidectomy of the neck as soon as possible.
And what next?
Sir, then I will, after total thyroidectomy, I'll subject the patient for hormone replacement therapy, and I will test the remnant tissue through radioactive iodine test.
What is that known as? Radioiodine?
Radioiodine thyroid scan, radioiodine scan.
Okay. Then?
Based on that, if there is a remnant tissue, then I will subject the patient for therapeutic remnant ablation with radioactive iodine uptake.
Which isotope you use for radioiodine ablation?
For ablation, we use iodine 131.
How much dose you have to give?
Sir, we have to give 50 millicurie of 50 to 100 millicurie of.
Depending on the size of the remnant and body weight of the patient, we can even go up to 100 millicurie of thyroid.
Yes.
Okay, that's all from my side, sir. Thank you.
Thank you, sir.
In examination, hello, please. Yes, question, please. In examination, you have not mentioned about the abdominal examination. What is the importance of liver spleen examination?
In general examination, sir, I have mentioned.
What is the importance of liver spleen enlargement in case of thyroid swelling?
Sir, in thyroid swelling, if there is a suspicion for MTC medullary thyroid carcinoma, then we do a per abdomen examination, or if there is a liver metastasis, for all these things, we do a abdominal examination.
What else?
Sir, there are symptoms related to the primary thyrotoxicosis in GI systems. For that also we do.
What else? Okay. Another examination, you have missed the Cockers test.
Yes. Cockers test, sir, usually it is done if we suspect that there is compression over the trachea. And nowadays it is obsolete.
But you are sure clinically it is not compressed?
Yes, sir.
But you have to test it.
No, sir. Cockers test is a provocative test, actually. It is a provocative test and it will produce stridor. And nowadays it is obsolete. It is not done.
Suppose it is considered as a carcinoma, malignancy.
Yes.
So, by radiation, how can you cure it? What is the dose of radiation?
Through radioactive iodine ablation, we use iodine 131. 50 to 100 millicurie we use for therapeutic ablation.
Okay.
Thank you, sir.
I'd like to call over the next speaker, Dr. Monalisa Sethi, for a case of parotid swelling from KCG Medical College.
Good morning, all the respected dignitaries and one and all present here. I am Dr. Monalisa Sethi from MKCG MCH presenting my case. The patient, Mrs. Swapnarani Pradhan, wife of Mr. Santosh Pradhan, a 38-year-old female, a homemaker by occupation, comes from Sitalapalli, Gopalpur, Ganjam, Odisha. She came with the chief complaint of a swelling in the right side of the face and upper neck that is slowly increasing in size over these years. History of presenting illness. The patient was apparently alright before 4 years. Then she noticed a swelling at the right side of face and right parotid region just below the ear lobule. The swelling was insidious in onset and it was approximately of 2 into 1 centimeter in size, and it gradually increased over these years to attain the current size, as we can appreciate in this picture. It was not associated with any pain in relation to intake of food or even during rest. It was not associated with any rapid increase in sudden increase in size, and it was not associated with evening rise of temperature or any history of upper respiratory tract infection or any history of any loss of weight or loss of appetite. There were no history of any other swelling in the neck or elsewhere in the body, and the skin changes were not present over the swelling due the course of the time, and there were no history of any discharge from outside or from within the oral cavity. There were no history as such for dryness of mouth and eyes, and there were no history suggestive of facial palsy as well. There were no history of pain in the ear or discharge from the ear. Moving on to past history, there were no previous history of irradiation in childhood or no previous history of no previous surgeries. She was not exposed to any known mumps case, or there were no documentation of any mumps case in her family. And she is not on medication for any chronic diseases like type 2 diabetes mellitus or hypertension, asthma, epilepsy, tuberculosis. Even she is not on medication for any systemic illnesses like Sjogren syndrome, sarcoidosis, and SLE, the systemic lupus erythematosus. Personal history: patient belongs to low socioeconomic status, and she is married and blessed with one child. She takes mixed Indian diet pertaining to her locality, and she is not a smoker, not an alcoholic, and she does not use tobacco in any form. She has normal bowel bladder habits, and sleep and appetite routine are also normal. Family history: there is no history of similar illness in the family, and there is no history of any cancer related deaths among her first degree relatives or even in the second degree relatives. Moving on to the examination part, after taking informed consent, the patient was examined in a well lit room following proper exposure. The patient is conscious, oriented, she is well oriented to time, place, and person. She is well built and well nourished and properly hydrated, optimally hydrated, and BMI is 24.7 kilogram per meter square. BP was 124 over 80 millimeter per mercury in right arm sitting position. Pulse rate was 86 beats per minute. Regular rhythm, normal volume, and normal character with no radio-radial or no radio-femoral delay. Oxygen saturation was 100% in room air. She was not pale, not cyanosed. There were no clubbing, and she was not icteric as well. There were no generalized lymphadenopathy or no bilateral pedal edema, and there were no palpable organomegaly. Coming to the examination proper, inspection. On inspection, it's a single ovoid shaped swelling, approximately of size 6 cross 5 centimeter. It situated at in front of the tragus, approximately 1 centimeter in front of the tragus, till the angle of the mandible below, and it obliterates the retromandibular groove as well. The swelling becomes prominent after clenching of the teeth, and the surface of the swelling appears smooth. The margins on inspection were indistinct, and the skin over the swelling appears normal. There were no signs of any scar mark, there were no visible pulsation, there were no venous engorgement, and there were no pigmentation, signs of pigmentation as well. There were no discharge from the swelling. Contralateral parotid region appeared to be normal, and oral cavity also appears to be normal. There were no other swelling noted in the scalp, face, or neck. There were no wound in the scalp or face. Coming to facial nerve functions, bilateral nasolabial folds appear to be normal, and there were no asymmetry noted when the patient was asked to raise her eyebrows, close her eyelids, puffing out the cheek, and even on grimacing or smiling, as we can see from the picture. Palpation. There were no local rise of temperature, the swelling was non-tender, and the inspectory findings that were elicited regarding the size, extent, and the site were confirmed. It was actually a spherical shaped swelling with well-defined margins, and the surface was smooth with firm consistency, and it was not fluctuant, it was not transilluminant, and it was not compressible nor reducible. It's free from the overlying skin and the underlying muscles, and it was freely mobile over the clenched teeth, and there were no restrictions as such noted while the patient was moving her jaw. Contralateral parotid was normal, and there were no palpable cervical lymphadenopathy. On oral cavity examination, the tonsil and the tonsillar fossa appeared normal and uvula is centrally placed. There were no discharge present inside the mouth. Even on expressing the parotid from outside, there were no discharge came out. There is no swelling or growth or ulcer present inside the oral cavity. On bimanual examination of the gland, the deep lobe of the parotid gland was found not to be, the enlargement of the deep lobe was not found. Facial nerve examination yielded normal tone of the facial muscles on both the sides. On percussion, dull note was heard over the swelling, and on auscultation, there were no bruit heard over the swelling. Systemic examination, cardiovascular system examination yielded normal first and second heart sounds with no murmur. Respiratory system yielded normal vesicular breath sounds and there were no added sounds. Per abdomen is soft, non-tender. Normal vowel sounds were heard and there were no palpable organomegaly. In central nervous system, there were no focal neurological deficit noted. On summary, a 38-year-old female patient presented with a painless swelling in the right side of the face and upper neck below the ear lobule for 4 years, gradually increasing in size over these years, and no history of suggestive of facial nerve palsy, no history of sudden increase in size, no history of any local inflammation, or no history suggestive of tuberculosis. There were no other swelling noted in the face or elsewhere in the body or even in neck. On examination, there is a well-defined spherical form and non-tender swelling of 6 cross 5 centimeter size in right parotid region with smooth surface free from skin and underlying muscles, no enlargement of deep lobe, no signs of facial palsy. There is no palpable cervical lymphadenopathy as well. So my provisional diagnosis is right-sided benign parotid tumor, most probably a pleomorphic adenoma.
Why are you telling this is a parotid swelling?
Sir, first of all, because of its peculiar location, sir, it is present below the zygoma and it extended up to the angle of mandible. It also obliterates the retromandibular fossa while lifting up the earlobes. Hence, I think it's a parotid swelling, sir.
The deep part is affected or not?
Sir, the deep part was not affected.
What examination you have done?
Sir, the deep lobe can be palpated with bimanual palpation, sir. Sometimes when the deep lobe is enlarged beyond proportion, then the tonsillar fossa is pushed medially. But in this case, there were no such finding present, sir.
Can you show me the picture? The first picture. Yes. What is the color of the skin over the swelling?
Sir, it's slightly flushed, sir. But
What is that slightly flushed? In which condition there will be slightly flushed skin?
Sir, in case of parotitis or any inflammation, there is slightly flushed skin, sir.
So is it a case of parotitis?
There were no tenderness or...
That is true.
That is actually her natural skin color, sir.
Actual skin color.
Yes.
Okay.
It was not tender or no signs of inflammation was there.
Okay, okay.
Over the neck and the parotid.
You will be given a MCQ. The color of the skin over the swelling is normal, slightly flushed, red. What will you tick? So, in your description, it might be due to your pressure during examination. There may be some congestion, right? But as it is a picture and you demonstrated the picture, I was tempted to ask you, right? Now, why did you examine for discharge from the ear?
Sir, in case of any malignancy in the nasopharyngeal carcinoma or even in the external carcinoma involving the external auditory meatus, there would be discharge from the ear and there might be enlargement of the preauricular nodes which might be mistaken for a parotid swelling, sir. That's why.
Okay. And also no similar illness in the family. Which disease is related to this parotid swelling in family?
So the carcinoma might be running families.
Carcinoma parotid is genetic, runs in family.
Not all the.
Okay, okay, okay. And you told in general examination there is no palpable organomegaly. What does it mean in general examination? There is a protocol, general examination, local examination. In which segment you examined no organomegaly? General examination.
Per abdomen or any swelling elsewhere in the body also is examined.
So you examined the abdomen in general examination to find out a organomegaly. You mentioned it. How could you examine the tone of the facial muscle?
Sir, the patient was asked to, according to the action of the different facial muscles the facial nerve supplies, the patient was asked to perform all those actions, and the resistance was applied to see whether the contraction is adequate in opposing to the resistance. Like the patient was asked to puff out the cheek, and pressure was applied against the cheek, and if the tone remained the same or normal, is elicited normal. Even in while eliciting the action of orbicularis oculi, the patient is asked to close her eyelids and forcefully close her eyelids, and then when pressure is applied and the patient still the pressure is applied to open the eyelids, and if the eyelid remains shut, it signifies normal tones.
Clinically, you think it is a case of mixed parotid tumor or pleomorphic adenoma, right?
Yes.
What other differential diagnosis comes to your mind? She is aged?
She is 38 years old.
38 years. So what other things comes to your mind?
Sir, it could be a Watkins tumor as well, sir. And
What is that?
Sir, benign parotid.
What did you tell? Which tumor?
Watkins tumor. Sir.
Spelling?
Yes, sir. It's exclusively occurs in parotid, sir. Warthin, sir.
Warthin's tumor. How it is different from this parotid swelling?
Sir,
Why it comes as a differential diagnosis?
Sir, Warthin's tumor is exclusively related to parotid gland only. But here it's not a Warthin tumor because it's only localized to the, mostly it's localized to the lower part of the lower pole of the parotid, and it's present bilaterally. Whereas it's a unilateral swelling, and
it presents bilaterally.
It has bilateral incidence as well.
No, it is confined to lower lobe usually. Lower part of the lower lobe, what is that?
Tail of the parotid.
What is tail of the parotid? Anyway, now we are, anything comes to your mind except Warthin's tumor?
Sir, it could be a tuberculous lymph node as well.
Tuberculosis, right?
Yes. Auricular.
Anything else?
It could be a low-grade mucoepidermoid carcinoma given the young age.
Mucoepidermal carcinoma.
Young age and low-grade mucoepidermoid carcinoma.
Clinically, does it fit to your clinical diagnosis? Mucoepidermal carcinoma.
No, sir. That's why it's after tuberculosis. If I'm suspecting for any other differential diagnosis, it would be.
Okay. Anything else? You told a lymph node.
Yes.
You told a tuberculosis. You told a parotid tumor, except this Warthin's tumor, and a mucoepidermal carcinoma. Anything else in that region?
It could be a dermoid also, auricular dermoid, depending on the presenting age of the presentations.
Dermoid cyst. What goes against dermoid cyst in this case?
Sir, it's not fluctuant. It's the consistency is not cystic, and it's not fluctuant. Sir. And the progression is over years, which is not usually found in diagnosis.
What do you usually find a dermoid tumor?
There would be fluctuant and cystic.
That is a cyst, fluctuant or a fluid containing. What are the common location of a dermoid cyst?
It's present on the site of the embryonic fusions, mostly on the foreheads or in preauricular, postauricular region, and even implantation, even other dermoids like thyroglossal cysts.
সেটা কাই পাঠের বই ছিল। Anyway, so anything else? No.
It could be a sebaceous cyst or metastatic lymph nodes.
Metastatic lymph node. You told lymph node. Maybe benign enlargement or a inflammatory origin or some metastatic, right? So to differentiate all these and to pinpoint your diagnosis, what is the most diagnostic investigation?
Sir, FNSC could be done as a primary investigation, and then we can go for CT scan.
We will go for?
CT scans.
Before that, before FNSC, before CT, how many common investigation we do in our setup? A swelling,
USG,
ultrasonography, right? And FNSC.
Yes.
What do you expect in FNSC?
Sir, it would show whether the swelling is benign or malignant in nature, sir. The cytology. So we can proceed according to that using a criteria based on epilepsy.
But you think it is a pleomorphic adenoma.
Yes.
What do you expect in FNSC finding?
Sir, in cytology there would be a mixed group of cells.
What is that big group of cells?
There would be epithelial and myoepithelial cells along with cartilaginous and spindle, smooth muscle spindle cells, and there would be hyaline cells also. So,
Hyaline, cartilage, epithelial cells. You told spindle, neural element is there.
Smooth muscle. The myoepithelial cells appear as spindle-shaped cells. The smooth muscle.
Spindle-shaped cells. Why it is called pleomorphic?
Because of the array of mixed population of cells, it's called pleomorphic.
Okay. Now your diagnosis is now clear, established. It's a pleomorphic adenoma, right?
Yes.
What is your plan of management? What for she has come? Swelling. She has come for a swelling.
Yes.
No complaint. Any other complaint?
No.
So what? How to proceed?
Sir, then I would see by performing a CT scan whether there is any deep lobe involvement or any involvement of
CT scan or any other
MRI also.
MRI.
Perineural invasion would be better seen in MRI. So after that, if deep lobe is not involved, also radiologically I would go for superficial paratectomy.
So plan surgery.
Yes.
Facial nerve is intact.
Yes, sir.
And there is a swelling which is not fixed, mobile, as you told,
Yes.
clenching the teeth and also jaw.
Yes, sir.
It's a mobile structure. So what is that superficial paratectomy?
Sir, it removes the tumor along with the whole of the superficial lobe while preserving the facial nerve and the deep lobe, sir.
What is the superficial lobe?
It's the lobe that lies superficial to the fasciovenous plane of Patty's.
What is that fasciovenous plane?
While the facial nerve emerges from the stylomastoid foramen, upon entering the parotid gland, it traverses through the gland with retromandibular vein. So along with this vein and facial nerve, they comprise of this fasciovenous plane of Patty's.
Which one is superficial, which is deep?
Sir, the facial nerve is superficial and retromandibular vein runs deep. Sir.
How retromandibular vein is formed?
Sir, it's formed by the combination of maxillary vein and superficial temporal vein. Sir.
Then what is the course of this vein?
Then it forms into a retromandibular vein, and it runs through the gland, and then below it continues as external jugular vein. Sir.
External jugular vein. How external jugular vein is formed?
From the retromandibular vein and
retromandibular divides into anterior and posterior.
Yes.
How external jugular vein is formed?
From the retromandibular vein and
which part, anterior or posterior?
Sir, anterior. Sir.
Why these are necessary? These structures are necessary during a parotid surgery.
Sir, it helps us to identify the facial nerve and thus minimize the chances of injury while undergoing the surgery.
We hope you have assisted a case of parotid surgery in your college. How to identify theoretically? How to identify this is facial nerve?
Sir, there are 3 pointers to identify, sir. One is tragal pointer or Conley's pointer, which is lies 1 centimeter inferior and deep to the tragus. And there is, by identifying the posterior belly of digastric muscle, we can identify because it lies just superficial to that. And on the tympanomastoid suture, it lies inferior to that. So while we are dissecting in this region, once the trunk is visualized, we can go centripetally to dissect out the nerve branches.
This is one approach from the trunk. Any other approach?
Sir,
You
there
failed
is-
to identify the nerve during surgery. Any other way?
Sir, the electromyography could be done.
That is not there in your college.
Then we can go retro.
OT table, you are searching for the trunk of the facial nerve, you are not able to. Any other way to approach that faciovenous plane?
Sir, one of the main branches of the facial nerve could be traced back to find out its
Like
Sir, buccal branch, sir, it's the most thicker of all the branches. So
Good.
the retrospective dissection could be done to find out the branch.
so what are the branches you must preserve or some branch you sacrifice?
Sir, 3 branches we must preserve.
What are they?
One is the branch to orbicularis oculi, and then the branch to orbicularis oris, and the branch to buccinator must be preserved at any cost. But the preservation of all branches should be tried.
How to deal with the parotid duct?
Sir.
Parotid duct.
Sir, the parotid duct runs anteriorly from the gland. Then it runs along the masseter on the surface of masseter. Then it pierces the buccinator muscle to open into the vestibule of the mouth, opposite to the opposite to the crown of the second upper molar.
How to deal with parotid duct?
Upon visualizing the parotid duct close to the buccinator muscle, it is cut and ligated, and then the gland is dissected, gently dissected up. Sir.
Cut and ligate. There is a gland, there is a duct.
Yes.
How to deal with that duct?
The duct is ligated on both the ends so that no open ends remain to lead to further complications.
Both ends means?
The end that lies in the buccinator and the end that that is dissected out with the specimens.
Any other nerve you will come across?
Sir, while dissecting superficially, we will come across greater auricular nerves.
Whether to preserve it or
Sir, we
sacrifice
can
it?
sacrifice it in case we need any, there is any...
How it divides? Greater auricular nerve?
Yes, sir. It goes up to the earlobe and then it divides into the...
Into anterior and posterior.
It goes anterior. Sir.
Like two branches, anterior and posterior. We can sacrifice it or we have to
We
keep
can
it?
sacrifice, the anterior division could be sacrificed.
Posterior division should remain.
It should remain intact.
For what reason?
Because the anterior division might become a substrate for nerve grafting when there is any risk of facial nerve injury. So while
Tip of the ear lobule.
it is also supplied by the posterior branch, and if we sacrifice it, then there would be anesthesia in the earlobes.
Tip of the ear lobule anesthesia is manageable or acceptable or not in a lady?
Earrings and all for aesthetic purposes, it shouldn't be acceptable.
Then what complications you can come across during superficial parotidotomy?
Sir, there could be, first of all, there could be hemorrhage, sir, while doing the surgery. And there could be facial nerve palsy and not during surgery. During surgery, there would be hematoma, and if there is any inadvertent injury to facial nerve, then transient facial nerve palsy could be there, which is also self-limiting in post-operative period. And there could be seroma formation because of the flap, raising of the flap. And there also could be gustatory sweating due to Fraze syndrome.
So, how to prevent Fraze syndrome during operation?
Sir, to prevent Fraze syndrome, we can keep sternocleidomastoid flap or temporal fascia flap so that there is no abnormal connection of parasympathetic nervous system to the sweat gland circles.
What is the role of posterior belly of digastric?
Posterior belly of digastric actually helps us to locate the trunk of the facial nerves.
Only.
And it also could be used to mobilize so as the flap space would be obliterated.
So that the facial nerve will not remain superficial and it will be less traumatized after operation. Okay.
How to manage a case of parotid fistula?
So the fistula should be drained. First of all, it should be drained, and any underlying abscess also should be drained. But to prevent it, again we can use sternocleidomastoid flap and.
Postoperatively, you drain a fistula.
So we
You have done a parotid surgery. You have done a parotid surgery. How will you suspect? Yes, it's a case of parotid fistula.
Sir, there is persistent discharge from the
From the
wound itself, where the duct is remain open to the outside environment.
serous.
Yes, sir.
How to manage that case?
Sir, it could be managed conservatively.
Like
Uh, 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 by watching over the output, how much output is there. If it's not subsiding through conservative management, then redo surgery could be done, sir.
any agent to decrease the secretion?
Anticholinergic drugs could be given and botulinum toxin injection also.
What is the surgery recommended for parotid fistula and when?
Sir, after 6 weeks, the surgery could be done while excising the fistulous tract, and the duct would be ligated and closed, sir. With
We are sorry. Thank you. Thank you. Hey, Baba, organizer, please switch off that light. It irritates our eyes.
Thank you. I would like to call the next speaker, Dr. Rajendra Kumar Sahu from Bhimshar Burla.
Good morning, respected chairperson, my dear friends and colleagues. Myself, Dr. Rajendra Kumar Sahu, going to present a case on right iliac fossa mass. A 57-year lady hailing from Bargot, homemaker by occupation, presented to our OPD with the chief complaint of generalized weakness for 6 months, loss of appetite for 3 months, weight loss for 3 months, and swelling in the right lower abdomen for 2 months. Patient was apparently all right 6 months back. To start with, she developed easy fatiguity at work for past 6 months, decreased in appetite, and unintentional weight loss for 3 months, which was apparent from loosening of her clothes. She noticed a swelling of approximately the size of a lemon in right lower abdomen while bathing 2 months back, which was insidious in onset, not noticed with any pain, gradually progressed to attain the present size over last 2 months. There was no history of vomiting, episode of sudden onset severe pain over right lower abdomen in recent past, constipation, diarrhea, black stool or blood in stool, yellowish discoloration of eyes or urine, swelling in any other part of abdomen, fever, cough or blunt teeth expectoration or blood in urine. There was no history of any similar illness in the past. Patient was not in a case of known case of type 2 diabetes mellitus, hypertension or any hemoglobinopathies, pulmonary tuberculosis or contact to any TB patient. There was no history of any surgical intervention in the past. Coming to personal history, She belongs to low socioeconomic status, takes mixed Indian diet, habituated to chewing tobacco since last 25 years, and bhang. Sleep cycle is normal. Appetite has been decreased. Bowel and bladder habits are normal. No history of alcohol intake. No history of any known allergy to any drugs or medications. Menstrual history, attended her menarche at the age of 12. Cycle is regular, 4 to 5 days, 28 days. Not associated with any pain or clot. Attended menopause 6 years back at the age of 51 years. No history of OCP use or hormone replacement therapy. Coming to obstetric history, married at the age of 16 years, blessed with 3 children, P3, L3, A0, all are normal vaginal delivery. Coming to family history, there was no history of similar illness in the family. There was no history of any chronic illness in the like type 2 DM, sickle cell disease, tuberculosis, hypertension in the family. No history of cancer or cancer-related death in family. Patient was examined in a well-illuminated room in presence of a female attendant. After obtaining due informed consent, the patient is conscious, alert, cooperative, well-oriented to time, place, and person, thin build, and her nutritional status was found to be poor. BMI was found to be 17.6 kg per meter square. ECOG score to Kornofsky score was found out to be 80. Pallor was present, icterus, cyanosis, clubbing, edema, or no feature suggestive of lymphadenopathy. Pulse is 86 beats per minute, regular normal volume, no radioradial or no radiofemoral delay. Arterial wall is just palpable, measured in right radial artery supine position. BP was found to be 110 over 70 millimeter of mercury in right arm supine position. Respiratory rate was 16 beats per minute with abdominothoracic type, temperature 98.5 degree Fahrenheit. Coming to GI system examination, oral cavity was teeth is stained with black, oral hygiene is average. Keeping in privacy of the patient, after due coverage, I have taken this photograph. As you can see, the right iliac fossa, there is a lump visible. It's moreover evident in the lateral aspect view. Skin is loose over the lower half of the abdomen, and patient is look cachexic. Inspection, a visible swelling of size approx 6 into 4 centimeter in right iliac fossa with umbilicus central in position, inverted. All quadrants are moving reciprocal with respiration. There is no pulsatile movements or no visible peristalsis seen. There is no scar, pigmentation, dilated tortuous vein, subcutaneous nodule. Skin over the lower abdomen is lax. No other visible swelling in the rest of the abdomen. Renal angle fullness is absent. Hernial orifices are found to be intact. External genital appearance to be normal. Left supraalveolar region, no fullness has been seen. Coming to palpation, no local rise of temperature, tenderness, abdomen is soft, and intra-abdominal, intraperitoneal mass in right iliac fossa of size 6 into 4 centimeter, non-tender, globular in shape, margin, and surface is irregular, hard in consistency, restricted mobility and in horizontal and vertical plane. Mass cannot be pushed into the pelvis. Liver is not enlarged, spleen is not palpable, bilateral kidneys are neither palpable nor palatable, no other lump palpable in any quadrant of the abdomen, hernial orifices are found to be intact, left supraclavicular fossa, no swelling is palpable. On percussion, there is a tympanic node present all over the abdomen except over the lump, which have been found to be impaired dullness. There is no evidence of free fluid in the abdomen. The liver dullness starts from the fifth intercostal space in the mid-clavicular plane, and liver span is found to be 12 centimeter. Auscultation, normal bowel sound can be heard, no bruit heard. On digital rectal examination, perianal region is found to be healthy, anal tone normal, no growth palpable intraluminally or extraluminally, finger stained with normal yellow color stool. Pervaginal examination was found to be normal. Coming to other systemic examination, on respiratory examination, bilateral vesicular breath sound heard, no added sound. Cardiovascular system, S1, S2 audible, no murmurs are heard. Central nervous system found to be intact. On musculoskeletal system examination, no fixed flexion deformity was found, no bony tenderness was also present. Coming to summarize my case, a 57-year-old thin-built, poorly nourished female presented with generalized weakness for 6 months, associated with significant weight loss and loss of appetite for 3 months, and lump in the right iliac fossa for 2 months, and patient is anemic. On abdominal examination, there is a 6 into 4 centimeter non-tender intra-abdominal intraperitoneal lump palpable in the right iliac fossa, globular in shape, having irregular margin and surface, hard in consistency with restricted mobility in a horizontal and vertical plane, impaired dullness on percussion, no other mass palpable in any other quadrant, no evidence of ascites or any organomegaly. Digital rectal examination was found to be within normal limits. Other systemic examinations are within normal limits. From this, my provisional diagnosis of carcinoma cecum without any evidence of metastasis or comorbidities has been made.
Carcinoma cecum without any evidence of metastasis or comorbidities.
And comorbidities.
Comorbidities.
So by comorbidities, I mean to refer the any chronic disorders like hypertension, tuberculosis, or any hemoglobinopathies that I have mentioned.
That we add any provisional diagnosis.
Just to extend the actually on the basis of provisional diagnosis, we will manage our case. If she is found to be hypertensive, for before taking into the operative procedure, we have to manage that. So that's why I have added the comorbidities.
Why did you ask for jaundice in this case?
Sir, to rule out any feature suggestive of liver metastasis or GB pathology, which can precipitate and present as yellowish discoloration, and also these patient and to rule out any obstructive features.
So, in case of right iliac fossa lump, when do you suspect a GB pathology?
On the sake of just to rule out, not on the my case point of view, not just to rule out, but to just rule out the abdominal pathology. That is, it is not a gallbladder mass.
Can gallbladder enlargement?
Distended gallbladder may come to right iliac fossa at some cases, but it is usually rare.
Why do you ask for oral contraceptive pill, hormone replacement therapy?
Sir, some studies suggest that hormone replacement therapy is found to be protective in case of carcinoma, colorectal carcinomas, and OCP and HRT, OCP use and HRT use also have association with pelvic over gyneco-ovarian malignancies. That I need to rule out as the location of the mass is in the right iliac fossa.
And respiration is reciprocal. What do you mean by reciprocal respiration?
Means all quadrants moving equally. Suppose this part of the upper half of the abdomen, it will move.
Reciprocal.
By reciprocal, I mean to say moving, all quadrants are equally moving with respiration.
What is impaired dullness?
Impaired dullness means
you percuss the lump and you wrote down impaired dullness. What do you mean by that?
Stony hard, long purpose.
Dullness.
Dullness.
Dull. What is impaired dullness? You examined first rectum, then vagina.
First PV, then PR.
But you showed in your slide. Right. Now, the provisional diagnosis is carcinoma rectum.
Cecum.
Sorry, carcinoma cecum. It's a right-sided lump.
Yes.
Why do you suspect carcinoma cecum?
Sir, elderly age group female presented with the chief complaint of generalized weakness for 6 months with features of anemia, apparent weight loss, and asthenia with the palpatory finding there is a long palpable which was hard in consistency, irregular surface, irregular margin, and not originating from pelvis. These features are suggestive. This pathology is of malignant etiology. That's why I think it's a carcinoma cecum.
Can it be anything else except carcinoma cecum?
Hyperplastic type of ileocecal tuberculosis.
Hyperplastic. How do you differentiate it clinically? How to differentiate hyperplastic tuberculosis cecum from a cecal carcinoma?
Sir, hyperplastic variety of ileocecal tuberculosis generally produce lump which will be irregular but form in consistency, irregular surface, irregular margin will be there, but there the consistency will be firm, not hard.
What is its location?
Pulled up due to pulled up cecum, this location will be slightly up, not classical in the right iliac fossa, but more over palpable over the lumbar region.
So, common differential diagnosis, a benign like appendicular lump or a tubercular pathology or a malignancy, common.
Yes.
How to differentiate in this age group? 6 months duration.
Yes.
loss of weight, loss of appetite, asthenia, all these are there. Malignancy and tuberculosis, clinically, how to differentiate?
So there is no constitutional symptoms are there. Night B symptoms such as fever, night sweats. Though there is anorexia, asthenia, anemia, significant weight loss is there, but these symptoms are absent. No history of contact with tuberculosis. So from this, my TB point of view, the diagnosis of TB is ruled out. And coming to malignancy point of view, there is a duration of long duration 6 months history with anemia, asthenia, anorexia, having lump which is hard inconsistency. So I reached out to this malignant one.
Why anemia common in right-sided malignancy?
Sir, right-sided colonic pathologies are generally ulcerative or fungating variety which tends to bleed, and cecum being the distended part, it usually doesn't obstruct. So there will be occult blood loss which will be got unnoticed by the patient. So their presentation will be late, and patient will generally present with anemic features. Moreover,
What is the source of bleeding?
That the ulcer site, ulcerative growth which will bleed.
Ulcerative site.
Ulcerative, fungating, or cauliflower-like growth might be there, which tends to bleed.
Okay. And tubercular ulcer, how does it different from malignant ulcer?
Generally, tubercular pathologies are tender, firm consistency. Along with that, there will be features of vomiting, abdominal distension will be there at some point, and features of obstruction in the abdominal TB will be more common rather than this. And colic abdomen.
What are the types of gut tuberculosis?
Gut. Ulcerative, hyperplastic, mixed, and structural variety.
Structural variety.
Ileal region generally structural tuberculosis.
Hyperplastic tuberculosis, obstructive. Ulcerative tuberculosis. How do they differ clinically?
Sir, ulcerative is more commonly the more primary to pulmonary tuberculosis they occur, more virulent. Most common site is terminal ileum. These patients are more emaciated and structural pathology, they tend to form more structure, whereas hyperplastic variety in immune competent patients and less virulent organisms, these features and this type of patient tend to present with features of obstruction, as this growth generally heals with cicatrization, and there will be features of pulled up cecum. These will be more evident in hyperplastic variety rather than the ulcerative one.
So before proceeding further and to satisfy you, what are the differential diagnoses, right?
The first one is the carcinoma cecum, followed by which the hyperplastic tuberculosis, hyperplastic ileocecal TB, followed by appendicular lump. Then I will go for tubo-ovarian mass as the patient is female. Then I will keep in mind the mesenteric lymphadenitis might be there, or retroperitoneal sarcoma, and mesenteric cyst might be there. These will come up, but these are rare ones.
Those persons who are suffering from ulcerative variety,
Yes,
to which department they come?
generally, these patients are present with gastroenterology department medicine. But that's the cause. That's why they present delayed presentation, and such anemic, asthenic, anorexic features will be.
So CMI high means which variety will come?
Sir, I can get it.
Those persons whose cell-mediated immunity is high, they will suffer from which variety of abdominal tuberculosis?
Hyperplastic.
So how will you proceed to?
As a part of clinical extension, I would like to perform first ultrasound, followed by which I will perform colonoscopy, guided biopsy. Then to stage my disease, I will perform CT abdomen and pelvis along with chest X-ray, and for operative procedures pre-op, I will do all the normohemograms and CA value, which will have importance in my surveillance period. Then I will take up my patient for operative procedures.
So you had a new word, normohemogram. What is that?
Sir, CBC, LFT, RFT, all the things, all the blood profiles I will do.
So you will do all these investigations, and then you will operate.
Yes.
What operation will you do?
Sir, for this patient, I will go for right hemicolectomy.
Before going to surgery or management, among all these investigation, which one will help you much
Sir,
for a diagnosis?
for the diagnostic point of colonoscopy guided biopsy.
What will you find in colonoscopy?
Sir, in colonoscopy, first I will find any proximal pathologies there. If any polyp is there, I will do the polypectomy.
What is that proximal pathology?
If
You
I
have
found a pathology over the carcinoma of the cecum region, I will go to for colonoscopy. I will go to the up to the terminal ileum. Cecal intubation will be there. So I will rule out any proximal pathology there. Concurrent lesion or synchronous lesion will be ruled out along with IBD. Any concomitant, simultaneous inflammatory bowel disease. If there, I will got to know about this. And
like.
Sir, ulcerative colitis or Crohn's disease.
Clinically, we do not have any evidence.
No
Altered bowel habit or bleeding per rectum, it's not there. But that can be established by colonoscopy. Anything else in colonoscopy?
And we can take the if there is more polyps are there, so we have high degree of suspicion over any genetic association, and if polyp is there, we can do polypectomy. So it will have both diagnostic and therapeutic value also.
So which polyp disease is associated with ileocecal mass?
Sir, most commonly adenomatous variety villous one are mostly associated with carcinoma cecum. Other malignant polyp, just like adenocarcinoma, they can have also feature suggestive carcinoma cecum.
So you saw a fungating lesion or with ulceration. What else you will get by this colonoscopy? You can take a chunk of tissue for biopsy.
Yes, a biopsy.
What do you expect in biopsy? Colonic malignancy.
In colonic malignancy, I will got to know about the histological subtypes along with genetic mutations. Along with that, any lymphovascular invasion was there also or not, and margin of resection, and these many things I will get, which will manage and helpful in my post-op management period. If I add any.
What are the structures you will remove?
In case of right hemicolectomy, I will remove terminal 10 centimeter of the ileum, cecum, appendix, ascending colon, transverse colon, approximately 2/3. That will be dependent upon after dividing the right branch of the middle colon. And along with that, complete mesorectal mesocolic excision with at least 12 number of lymph nodes must be harvested.
What are the nodes?
Sir, epicolic, paracolic, intermediate, and principal group of lymph nodes.
Central.
The vital structures you spare in right hemicolectomy.
Sir, I must look out for right-sided ureter, gonadal vessels, and during mobilization, I should watch out for the duodenum. Mostly third and fourth part, because that are the highly probable prone site for injury during this surgery. And along with that, excision and the ligation of the vascular structure should be done high and towards the origin.
So before entering into the abdomen, you decided how to proceed by investigation like CT scan.
We'll generally do depending on the procedures. If you are going open procedure, then there's
good. Right.
Open. In laparoscopy, I will go for diagnostic lab first, whether to look out for any metastatic zones are there or not. Otherwise, open procedure, look out for the abdomen condition, whether any ascites is there or distant metastasis or liver mets, nodule palpable. These things have to be ruled out. Then I will go for the operative one.
Emergency. Patient has come with acute obstruction.
Yes,
not this patient. Emergency acute obstruction, and you open the abdomen, right? And you find a lump which was not palpable clinically, or he did not present earlier. Now you are not able to be fixed lump. How to proceed?
So, this patient, probably this patient presented in acute condition means features of obstruction or anything would be there. So excision, right hemicolectomy I will do, followed by which
emergency, dead of the midnight, you are a beginner, You are not able to do right
to the
hemicolectomy. Yes?
Only the diversion procedure.
Like
Loop ileostomy I will do.
loop ileostomy.
Excise the part Hartmann's distal interfloscally diversion ileostomy कर loop ileostomy कर sir then I will proceed the patient in the follow period with colonoscopy. That should be done within 3 to 6 months. Then I will do CT in the post-op period to see any site of metastasis, followed by which I will add adjuvant chemotherapy.
In emergency, any more procedure except this ileostomy? Fixed lump. Diversion in the form of ileostomy.
End colostomy.
Ileostomy कहला ना एंड आइलो ट्रांसफर नहीं परिबनी
आइलो ट्रांसफर से अनास्टोमोसिस भी करि परिबे
के मना कला
ସେଥିପାଇଁ ହେମିକୋଲେକ୍ଟୋମି ତ କରିବି ନା
you are not able to do hemicolectomy fixed lump
ठीक है
huh? Now it is open to house John sir.
Sir, emergency midnight में I know colostomy not
advisable. Sir.
Sir, in emergency midnight, what condition you described him? Ileotransverse anastomosis should not be recommended or advised. It is better to take out a ileostomy lobe than to do a transfer anastomosis in the middle of the night with a compromising condition. That is my feeling.
Anyway, sir, in a compromising situation, as early as possible should come out. Ideal. It's okay. Yes.
Actually, as sir has described, it is a fixed lump, and he has come in the obstruction, and it is dead of the night, in middle of the night, and the surgeon is not so experienced. These are the conditions. In that case, ileostomy is the option. What he said is correct. But ileotransverse is also another option when it doesn't have a very bad prognosis also, and the patient will avoid a stomy. That's the most important factor with that. So
chances of anastomotic leak as a patient.
It's there. See, what you said, it's a correct thing. Ileostomy is okay, but ileotransverse, even we have done several cases, it doesn't leak because the colon is healthy and the ileum is not a case of obstructed colon like thing. So it doesn't leak so easily. Okay.
Sir, he is not used.
No, I am not telling about myself now. When I was like him, I am telling about that. Because when we were PGs lecturers, at that time stomies were not very common.
Very common, right.
And we were doing ileotransverse mostly, or it is a mobile lump. Even right hemicolectomy also we have done many cases. But left-sided growth is different issue. Right-sided is ileostomy is first option, and ileotransverse is also not a bad option.
Suppose the patient is a known case of ileocecal tuberculosis. So what will be your option of management?
Sir, first I will go for the medical management with the anti-tubercular drug for 2 months and 4 months period. Then, if the patient is presenting in features of obstruction or any emergency basis, I will go for on the basis of finding of the intra-abdominal pathology. If there is stricture, I will go for stricturoplasty within the short segment. Then I will go for also also dissect the the affected bowel segment. Or
suppose the patient presents with intestinal obstruction. It's a case of ileocecal tuberculosis. So what surgery you will perform?
Intestinal obstruction, ileocecal tuberculosis, I will go for the diversion procedure.
Suppose you are doing electively, why diversion?
Elective one.
Yeah.
So I will go for stricturoplasty along with
no stricturoplasty. Will you not remove the obstructed bowel?
Affected segment. I will do terminal 10 to 15 centimeter of the ileum along with the ascending colon, ascending and transverse colon, and iliotransverse anastomosis would be done there.
What is the difference of hemicolectomy between a malignancy and a tuberculosis?
In malignancy, we'll go for no turn ball, turn ball not touch technique. Vessel, we will ligate the vessel high and try to harvest maximum number of lymph nodes. Along with that,
Leave aside lymph node. Is it the level of resection? How much you resect in malignancy? How much you resect in tuberculosis?
in benign pathology, we'll go for the 1/3 of the transverse colon. But in the malignant one, we'll go to approx 2/3 one.
So it is a limited hemicolectomy.
Yes.
It's not a radical hemicolectomy, it is a limited hemicolectomy in tuberculosis, isn't it?
In the elective setting, if you have planned for a right hemicolectomy with iliotransverse anastomosis, intraoperatively you find there is extensive metastasis with ascites. How will your management change and how?
If the picture is suggestive of extensive metastasis, I have opened the abdomen. I will assess the extent of metastasis on the basis of if there is resectable liver nodules are there, or if there is gross ascites there. I will only diverse the resect the primary pathology and take up for chemotherapy, adjuvant chemotherapy, followed by which I will
Thank you.
take for another surgery in another setting.
Oh,
Thank you. Thank you. Thank you.
Now we go over to the last speaker of the session, Dr. Sabah Altaf Rupani from KIMS Bhubaneswar. She will present a case of gastric.
A very good morning to respected judges, professors, and all my dear colleagues. Thank you for this opportunity. I'm Dr. Sabah Rupani, a general surgery resident from Kalinga Institute of Medical Sciences, Bhubaneswar. My case is epigastric mass. My patient is a 58-year-old female, resident of Dhenkanal, Orissa, Hindu by religion, homemaker, belonging to lower socioeconomic status, who presented to us with chief complaints of pain in abdomen for the past 1.5 months and multiple episodes of vomiting for the past 20 days. My patient was apparently alright 1.5 months back when she developed pain in the upper part of the abdomen, which was insidious in onset, dull aching, intermittent, non-radiating, aggravated on food intake, and relieved on vomiting and medication. She also complains of vomiting for the past 20 days, which was insidious in onset, spontaneous, just few hours after the food intake, containing undigested food particles. It was non-projectile, non-bilious, and non-blood stained. She also complains of fullness after small meals, loss of appetite and generalized weakness for the past 1.5 months, and loss of weight. There is no history of heartburn or regurgitation, chronic medication, fever, jaundice, hematemesis or melena, altered bowel habits, new onset back pain, or hemoptysis. Coming to past history, my patient is not a known case of peptic ulcer disease. She has no known comorbidities like diabetes mellitus, hypertension, asthma, or tuberculosis. There are no history of previous abdominal surgeries or blood transfusion. Coming to personal history, my patient takes mixed Indian diet. She has normal bowel and bladder habits, normal sleep-wake cycle, and there is no history of addictions. Family history, there is no history of carcinoma stomach, carcinoma colon, or carcinoma breast in the family, no cancer-related deaths in the family, and no history of similar illnesses in the family. Obstetric history, my patient is a post-menopausal female. She attained menarche at the age of 12 years, menopause at 51 years of age. She is P3L3A0. All children are normal and healthy. Summarizing the history, my patient is a 58-year-old female belonging to lower socioeconomic status with chief complaints of pain in abdomen for 1.5 months, which aggravated on food intake and relieved on vomiting and medication. With this, she has vomiting for the past 20 days, which was few hours after the food intake. It was non-bilious, containing undigested food particles. She has loss of appetite, early satiety, fatigability, and weight loss. On general examination, the patient was examined in a well-lit room after taking informed consent. Patient is conscious, cooperative, well-oriented to time, place, and person. She is undernourished and poorly built. Her weight is 38.4 kg and height is 160 cm. BMI accounting for 15 kg per meter square. Her ECOG score is 2, Karnofsky is 80. Signs of dehydration are noted. Pallor is present. There is no icterus, cyanosis, clubbing, lymphadenopathy, or edema. My patient is vitally stable, temperature being afebrile 98 degree Fahrenheit, pulse is 86 beat per minute, normovolumic equal on both sides. Respiratory rate is 16 cycles per minute, thoraco-abdominal. Blood pressure is 100 by 70 millimeter of mercury in right upper arm in supine position. On per abdomen examinations was done in supine position. On inspection, the umbilicus is central and inverted. Abdomen is normal in shape. All the quadrants move equal with respiration. There is no visible peristalsis. Fullness is noted in the epigastric region. No previous surgical scars are seen. There are no sinuses, dilated veins, or visible pulsations. The hernial orifices are normal. The external genitalia is normal. On palpation, abdomen is soft, non-tender. There is no local rise of temperature. A solitary mass of size 7 into 5 cm was felt in the epigastric region, which was extending from the umbilicus to the left hypochondrium. The upper border of the mass was felt 3 cm below the xiphoid process, and lower border of mass was palpable 1 cm above the umbilicus. The mass is non-tender, hard in consistency, irregular borders, and nodular surface. It is non-pulsatile. I am able to insinuate my fingers between the mass and the subcostal margin. The mass moves with respiration. Its intrinsic mobility is present. The liver is not enlarged. Spleen is not palpable. Bilateral renal angles are normal. Hernial orifices are intact. External genitalia is normal. On percussion, there is normal resonance over the abdomen, but impaired resonance over the mass. There is no shifting dullness. On auscultation, succussion splash is positive. On auscultoscraping test, the greater curvature of the stomach is at the level of the umbilicus. There are no arterial bruit or venous hump. Bowel sounds are present. No supraclavicular lymph nodes were palpable. On digital rectal examination, the perianal skin looks normal. There are no skin tags, fissures, or fistulous opening. Anal sphincter tone is normal. There is no palpable mass. My gloved finger was stained with stools. All the other systemic examinations were within normal limit. Central nervous system had no focal neurological deficit. Cardiovascular system, S1, S2 heard, no murmurs were heard. In the respiratory system, the trachea is central, bilateral air entry is present, normal vesicular breath sounds are heard. The musculoskeletal system is within normal limit. Towards the end, I would like to summarize my case. 58-year-old female belonging to lower socioeconomic status with pain in abdomen for 1.5 months, which aggravated on food intake and relieved on vomiting and medication. Associated with vomiting for the past 20 days, few hours after food intake, non-bilious containing undigested food particle. She has loss of appetite, early satiety, fatigability, and weight loss. On general examination, my patient has pallor. On per abdomen examination, a mass of size 7 into 5 centimeters was felt in the epigastric region, extending up to the umbilicus and the left hypochondrium. It is non-tender with irregular borders, nodular surface, hard in consistency with impaired resonance over the mass on percussion. It moves with respiration, succussion splash is positive, and greater curvature of the stomach is felt at the level of umbilicus. With this, I would like to give a provisional diagnosis of epigastric mass due to carcinoma stomach with gastric outlet obstruction.
Non-official. She told history 1 to 3 and summarized history. Then went to examination. Is it the protocol in the surgery textbook, clinical surgery? Non-official. This is not going to hamper your marking.
So we usually summarize the history in short before moving to the general examination. That is why I summarized it.
Anyway, it's not there in the protocol, surgery textbook, right? You describe everything, then summarize, then provisional diagnosis, right? Forget this. Now, why did you take the history of blood transfusion in your case?
Sir, in my case, to check if there was any previous episodes of bleeding and the patient was transfused for blood, or because blood group A is more prone to carcinoma stomach, and this is the case of carcinoma stomach, I took transfusion history.
Previous?
Sir, in cases of patients with blood group A, they are more liable to have carcinoma stomach.
So, blood group examination you need.
No, and also if there was any past bleeding history. So, if there's a bleeding history and patient has anemia and patient must have taken blood transfusion, so to rule out that, I've taken the history of blood transfusions.
In your picture, show me the picture. Okay. You have taken the consent of the patient.
Yes.
You are examining in a safe environment.
Yes.
How much exposure should be there in abdominal examination?
Sir, it should be from the episternum to the mid-thigh, but I have just covered the genitals for privacy.
From the episternum.
Yeah, episternum or from the nipple to the mid-thigh. While examination, I did it only for the pictures, I covered the genital areas.
You told it is moving with respiration.
Yes.
How could you know it is intra-abdominal or intraperitoneal?
So to check whether it is intra-abdominal or intraperitoneal, I can do a leg rising test. On leg rising test, if the mass is not visible or going inside, like decreasing in size, it will be intra-abdominal. If the mass is same in size or increases in size, then it will be intra-abdominal.
Intra-abdominal.
So if it goes inside, if it decreases in size, then it is intra-abdominal.
It may be retroperitoneal or intraperitoneal.
To differentiate between retroperitoneal and intraperitoneal, I can do a knee elbow test.
What will happen in knee elbow?
In knee elbow test, if it is an intra-abdominal swelling, then it will protrude out, whereas if it is a retroperitoneal swelling, then it will go inside.
Is it intra-abdominal or intraperitoneal or retroperitoneal? You are differentiating.
Sorry, sir.
Intra-abdominal, intraperitoneal are the same.
No, sir.
We know parietal, we know intraperitoneal, extraperitoneal or retroperitoneal. This test helps you. But you told it is a case of intra-abdominal and intraperitoneal.
Sir, I said it is intra-abdominal mass.
Which test helped you to say it is intraperitoneal? There is a lump.
Yes, sir.
You excluded parietal. Then it may be intraperitoneal or retroperitoneal.
Yes.
Which test will help you? It is intraperitoneal.
Sir, if I do a knee elbow test to differentiate between retroperitoneal and intraperitoneal, I'll do a knee elbow test.
Anything else? It was moving with?
Respiration. The retroperitoneal will not move with respiration.
What are the structures which move with respiration?
So stomach, liver, spleen, transverse colon. All these structures would move with respiration, whereas the retroperitoneal structures, pancreas.
Which are related to diaphragm.
Yeah, all the yes.
Directly or indirectly?
Yes. Huh?
That can.
So it's a intraperitoneal swelling.
Yes.
And you are giving a provisional diagnosis of outlet obstruction. Where is the outlet of stomach?
Inside the stomach.
No. Outlet. In which region? I do not say quadrant. Which region? The location of outlet normally. And what is the extension of your growth or lump?
So my extension is from the epigastrium to the left hypochondrium.
So, is it in the epigastrium?
Yes.
Outlet.
You're seeing the so that will be towards the left hypochondrium. Sorry, that will be towards the right hypochondrium. The anterophylar region will be towards the right hypochondrium. Yes.
In percussion,
yes.
Abdomen percussion, usually what is the description? Is it resonant or tympanic?
Sir, it is resonant.
When we say it is resonant, usually lungs we say.
Yeah, normally the abdomen is tympanic, lumps are resonant. In my case, impaired resonance is there because it is stomach, it is filled with gastric fluid mostly, so the resonance is impaired.
So it is resonant.
No, impaired resonance, sir. Stomach will normally be resonant, sir, but because of the gastric fluid filled inside, because of the
I think you
distension,
told impaired dullness. Impaired resonance.
I said impaired resonance over the mass.
That means that area is filled up by a solid lump. What do you mean by impaired resonance? On in the epigastrium, over the lump.
So usually we get a resonant note on percussion, but there is impaired resonance because in the gastric, like in the stomach, it is filled with contents, that is fluid and gastric content. So because of this, my resonant note on percussion is being impaired. So that is what it means when I say it is impaired on.
So it is not a liver mass.
No, sir.
Why not?
Sir, I am able to insinuate my fingers in between the mass and the subcostal margin.
And the symptoms are not.
Also, with the history, in my history, starting from the history, the patient like I have findings like succussion splash. Then on ausculto percussion, I get a greater curvature of the stomach at the level of umbilicus. All these points suggest toward the carcinoma stomach pathology.
The mass is tender or non-tender?
So my mass is non-tender.
The patient has loss of appetite,
Yes,
anorexia.
the patient has loss of appetite, anorexia, and weight loss.
Oh, so why anorexia occurs in stomach cancer? Stomach.
Sir, in stomach cancer, because of multiple episodes of vomiting. So like in stomach cancer, there is non-distensibility of the stomach because due to carcinoma, the muscular layer gets infiltrated. So because of this, there will be multiple episodes of vomiting and early fullness after meals. This will result in anorexia.
Only local factors contribute to anorexia or any central factor associated with?
Sir, overall, because there will be decreased absorption, patient will be nutritionally ill, poorly built, and that is the reason. Patient will have easy fatigability and anorexia.
Usually in malignancy, you have told 1.5 month.
Yes, sir.
1.5 month, and here is a hugely dilated stomach.
Yes.
And the lower border the greater curvature is reaching the umbilicus.
Yes.
Is it possible with a benign obstruction or a malignant obstruction?
Sir, it is also possible with a benign obstruction, but this short history is not possible with benign obstruction.
Is there any
Yeah.
stomach gets dilated in a malignant obstruction within 1.5 month?
Sir, it can take 3 to 4 months, but my patient gave a history of only 1.5 months according to her, so I have mentioned that.
Usually in benign obstruction, dilatation is more.
Is more, yes.
Long duration, right? Short duration, maybe, but usually it's not a usual finding. And you have pictured these points by you. As per the location, the lower border is at the umbilicus.
Yes.
And is a huge lump covering the left epigastrium, right?
Epigastrium and the left hip.
And it gives rise to outlet obstruction.
Yes.
Non-bilious vomiting.
Non-bilious.
In which case, in benign cases or in malignant cases, huge dilation occurs?
Sir, in benign cases, sir. In case of chronic peptic ulcer diseases, huge dilatation will occur. In
What
case
is
of
the
malignancy,
what is the cause?
so because in case of malignancy, there can be infiltration of the muscular layer. Because of that, the distensibility of the stomach will be lost, and that is why the distension cannot be any further. In case of benign diseases, there is no infiltration, and therefore the stomach gets distended because of the obstruction.
In chronic peptic ulcer, there may not be dilatation unless otherwise there is stenosis.
Yes.
Unless it's not that chronic peptic ulcer will give rise to dilated stomach.
Yes.
Right? Now, after all this confusion, what are your differential diagnosis except carcinoma stomach?
So my differential diagnosis can be
Non-bilious vomiting.
yes, non-bilious vomiting. It can be carcinoma head of pancreas. It can be a transverse colon growth, or it can be a carcinoma of left lobe of the liver.
Carcinoma colon. Transverse colon. How to differentiate? It's a epigastric lump.
Yes, sir.
So how to differentiate a epigastric lump in the form of transverse colon and stomach?
Sir, in case of a transverse colon growth, So the intrinsic mobility will not be present.
Clinically,
And
how to differentiate?
so the gastric outlet obstruction will not be pronounced. There will be no no change of note in ausculto scraping. Succussion splash will not be felt.
Don't go to succussion flash directly. Inspection finding, that is not there in your case. It's true. Carcinoma stomach, outlet obstruction, transverse colon mass, presenting with obstruction. What will be your inspection finding? That is not there. Inspection finding.
Sir, on inspection, I'll get fullness in the epigastric region. On palpation,
What is
it will
the
be lower down in the epigastrium, not.
what is the direction of visible peristalsis? I told it is not there in your case. But
Yes, visible gastric peristalsis will be there only in carcinoma stomach. In case of
yes.
colonic obstructions, visible gastric peristalsis can be there.
What is the difference or are they same?
No, sir. In carcinoma stomach, it will be from left to right, whereas in case of colonic, it will be from right to left.
Inspection. Palpation.
Sir, on palpation, I will get a hard mass. It can be mobile with respiration, but intrinsic mobility is not seen, sir.
Intrinsic mobility. What is that?
Sir, if I hold the mass and move it side to side, then the mass will not move.
This is called intrinsic mobility.
Yes.
What are other differences? It's a mass from the stomach, it's a mass from the transverse colon. Clinical differentiation. Inspection gone. Palpation. What about the, should you say or I will say? Clinically. These are the common things asked in the examination. If you get epigastric lump. Anyway. What other differential diagnosis? You told it carcinoma transverse colon, carcinoma stomach, and pancreas.
Carcinoma head of pancreas.
Carcinoma head of the pancreas. How to differentiate?
Sir, in carcinoma head of pancreas, the mass will very rarely be palpable. Apart from that, if it is palpable, the mass will not move with respiration.
Still you are suspecting carcinoma pancreas. What for? In your case?
Sir, only because of the gastric outlet obstruction, I put it into differential diagnosis.
Carcinoma head of the pancreas give rise to gastric outlet obstruction.
It can.
You think in that way. In that case, it should be bilious or non-bilious.
Carcinoma head of the pancreas is giving rise to pyloric obstruction. Very common.
Not common, sir.
Anyway, we are now confused. How to confirm a diagnosis?
So to confirm my diagnosis, I will go with basic investigations.
Basic. What is basic?
I will start with all the basic blood investigations and upper GI endoscopy.
What pertinent finding in blood investigation?
Sir, in blood investigation, in my case, it is a carcinoma stomach, so I would first go with a complete blood count, including hemoglobin and TLC. With this, I would go with the serum electrolytes, that is serum sodium and potassium. I will go for liver function test, viral markers. I'll go for PT-INR, occult blood and stool, and also the tumor markers like CA19-9, CA125.
For diagnosis.
What is your target? She has anemia.
Yes.
She has an abdominal lump in the epigastrium. Features of outlet obstruction. What is your target in this blood investigation?
Sir,
Everything may be possible, but what is your target?
I would like to see if she has anemia, so I'll check for hemoglobin. Because there's a gastric outlet obstruction, serum electrolytes would be deranged. I would check for sodium potassium levels.
Wait, what is the serum electrolyte rearrangement in outlet obstruction?
In case of
Presenting with vomiting.
In case of gastric outlet obstruction with multiple episodes of vomiting, there will be hypokalemia, hyponatremia, hypochloremia, resulting in metabolic alkalosis.
What is paradoxical aciduria?
Sir, due to loss of HCl and hypochlorhydria and creation of alkaline medium, bicarbonate is lost by the kidneys. While bicarbonate is being lost, sodium is lost along with it. And because there is depletion of sodium in the body, the aldosterone mechanism gets activated. This will result in increased absorption of sodium. So instead of sodium, potassium and hydrogen ions will be pumped out in the urine with bicarbonate ions. So this hydrogen ion going in the urine will result in paradoxical aciduria.
Why it is called paradoxical?
So because there is the body has metabolic alkalosis, so there is no acid in the body to excrete like acid, but because of the paradoxicity, the hydrogen ions are being excreted, so it is called paradox.
So urine is acidic, body is alkaline,
Yes.
right?
Yes.
Now come to investigation for diagnosis.
In my case, investigation of diagnosis, as I said, first I will go with all the routine blood investigations. After that, I'll proceed with upper GI endoscopy to see the cause of the obstruction. If there is a ulcer or a growth in the same setting, a biopsy will be taken. After this, I'll also go with CECT, abdomen and pelvis. If on upper GI
Endoscopy.
yeah.
You entered into the stomach. What will you find in gastric outlet obstruction?
I will find a distended stomach with loss of rugosities and
Distended stomach.
Yes.
How can you find in endoscopy stomach is distended?
So when we put the endoscope, we can see the roomy stomach,
Acha. Next,
taking the scope from top to bottom.
top to bottom.
Loss of rugosities will be there, and because
Loss
of
of
the
rugosity.
yes.
Why it will be lost?
So because of the distensibility, stretching of the stomach, the rugosities might be lost.
Acha. Yeah.
Sorry, sir. Infiltration as well.
Acha. Next, what other things you will see in scopy?
In this case, what
So then in scopy, I will see if there is a suspected ulcer or a growth. If there is an ulcer, I will see the site, size and location of the growth and take the biopsy in the same setting.
Where from you will take the biopsy?
So from the same ulcer, I will take
Ulcer. Do you expect an
or a
ulcer?
mass.
There is a mass. True. Where from the mass? Mass is a 360-degree structure. Where from you will take the biopsy?
Sir, I will take 10 biopsies from all the quadrants, different quadrants of the mass.
15 quadrants.
All
Ten.
the quadrants, I will take total 10 biopsies from different quadrants of the mass.
Next, what else you will see in endoscopy? Should you enter into the duodenum?
Sir, now there is a gastric outlet obstruction. Through the scopy, I can
how
try
you ca-
negotiating the.
No, there is obstruction, outlet obstruction.
Sir, if my scope is not going beyond the antrum in the duodenum, then I can know that there is an obstruction.
Right, you send it for biopsy. Sorry, biopsy chunk of tissue, send it for histopathological study. What do you expect to come out in the report?
Sir, in this case, I expect it to be adenocarcinoma of the stomach.
Adenocarcinoma of the stomach and obstructing the gastric antrum or the outlet.
Yes.
Right? What is your plan of management? Before that, what other investigation you want to do?
Sir, I have already done the basic blood investigation. I
Right.
also do a CCT abdomen and pelvis and CCT chest.
Uh-huh. Why you are interested for CCT abdomen?
Sir, in CCT abdomen, I will see where my mass is, what is the size of the mass, if there is any surrounding infiltration of the mass, any nodal involvement. I can also check for any liver metastasis or ascites.
Any role of endo ultrasound?
Yes, sir, endo ultrasound, the role is there. It is usually in early gastric carcinoma. Through endo ultrasound, I can see the mass and the layers of the stomach that it is invading.
Early gastric carcinoma, role of endo ultrasound. What will you find in endo ultrasound to stamp it as early carcinoma?
Sir, in early gastric carcinoma and endo ultrasound, I will find a small lesion which is well differentiated, piercing maybe up to the mucosa and submucosa, not beyond that. Sir. That will be early gastric carcinoma.
Early gastric carcinoma.
What is the definition of early gastric cancer?
Early gastric carcinoma is the carcinoma infiltrating the mucosa and submucosa and not beyond that, irrespective of the nodal status.
Yes.
So that is diagnosed by endo ultrasound.
Yes.
Is it such a huge lump? Do you prefer to go for endo ultrasonography?
No, sir, not for, because I've already gone for upper GI endoscopy and biopsy, and it is a huge lump. Endo ultrasound will be used only later on if in case palliation is needed.
Your lump is extending from the outlet to the left hypochondrium.
Yes.
What is your plan of management?
Sir, I will first proceed with CECT, and according to the report, if there is a locally advanced, like it looks in my case, if that is the case, then in a locally advanced disease, I would first start with neoadjuvant chemotherapy, downstage the tumor, and then plan for a curative resection, sir.
Carcinoma stomach.
Yes.
What is the regimen for neoadjuvant chemotherapy in carcinoma stomach?
Sir, in carcinoma stomach, the current regimen is a plot 4 regimen which consists of 5-fluorouracil, leucovorin, oxaliplatin, and doc, docs.
You do not say, we do not know.
Sir, I know, sir. 1 second, sir.
Okay. How long?
So this is given in 8 cycles, sir. So according to the neoadjuvant, it is a operative chemotherapy. So I will give 4 cycles before the surgery
Yes.
in a span of 3 weeks, and then check if it is working, then plan for my surgery, and then again complete the entire remaining 4 cycles as adjuvant.
So what is the surgery you plan? Come to the point.
Sir, if I see
There is no liver metastasis, there is no ascites, nothing. Only confined to stomach and came out to be adenocarcinoma, and you have finished 4 cycles of neoadjuvant. Next.
Sir, if the tumor is downgraded and shrinked in size, then I can plan for a distal radical gastrectomy with B2 lymphadenectomy followed by
Thank you.
reconstruction. Thank you.
Thank you, judges, for the wonderful session.
Hand, because for few minutes. Thank you.
Abhijit Mohanty, Professor and HOD, General Surgery, AIIMS Raipur, and Dr. Narendranath Swai, sir, Professor and HOD, Department of General Surgery, SJMC Puri. Along with that, we will have a running lunch from 1 p.m. to 3 p.m., but the session will continue all along the same. I would like to call upon the stage the next speaker, that will be Dr. Raviteja Pulavarti, to present the case of a breast lump.
Good afternoon to one and all. Myself, Raviteja Pulvarti, PG resident from AIIMS and Some Hospital. I'm going to present a case on the breast lump. A 54-year lady, homemaker by occupation, resident of Sundargarh, present to the outpatient department with the chief complaint of lump in right breast since 2 months. On history of present illness, patient was apparently well 2 months back. To start with, she incidentally noticed a lump in right breast, approximately of size 2 by 2 centimeters, which was insidious in onset, initially small in size and gradually progressive in nature to attain the current size. Lump was not associated with pain. There is no history of fever, trauma to breast, nipple discharge or nipple retraction. There is no history of any skin changes, unintentional weight loss, loss of appetite. And it was not associated with any symptoms of bone pain, cough, breathlessness, hemoptysis, jaundice, headache, vomitings, and convulsions. There is no history of lump in contralateral breast. On past history, there is no history of similar lump in the same breast or opposite-sided breast, no history of tuberculosis, no history of hormone replacement therapy, no history of radiation exposure, not a known case of hypertension, diabetes, thyroid, and asthma. Patient consumes mixed diet. She's having normal bowel and bladder habits, normal sleep pattern. There's no history of addiction to smoking and alcohol. On family history, there's no history of breast cancer in any of the first degree relatives, no history of ovarian, colorectal, prostate, or any pancreatic related malignancies in family. On coming to menstrual and obstetric history, age of menarche was 14 years of age. She was having regular cycles of 3 to 4 days for every 28 to 30 days, not associated with pain and clots. Age at marriage was 18 years. She has given birth to 2 children, both were by normal vaginal delivery. First childbirth is at the age of 20 years. There is no history of abortion. Both children were breastfed up to a period of 1 year of age. She attained menopause 3 years ago. On general physical examination, patient is conscious, oriented, and cooperative. Her BMI was about 24.79. Blood pressure 124 by 80 millimeters of mercury in right arm in sitting position. Pulse 88 beats per minute and respiratory rate 18 breaths per minute. Temperature 98.2 Fahrenheit and Karnowski performance status score is about 90. There is no evidence of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. On local examination, after taking consent and along with the female attender, patient is asked to expose up to waist and examined in a well-lit room. And patient was examined in 3 different positions, sitting in sitting position by both the arms by the side of the body. In this position, both breasts appear to be symmetrical in position, shape, and size. No obvious lump is made out on inspection. Skin over the breast is normal. Scar mark of the biopsy site is visible over the lump. No evidence of dilated veins, dimpling, or puckering. No evidence of nodules, ulcers, or body orange appearance. Areola appears to be normal and symmetrical to opposite side. No evidence of nipple retraction or active discharge seen. Both nipples are at same level. Arms appears to be normal. There is no fullness seen in infraclavicular or supraclavicular region. When the patient is examined in the arms raised above the head, no prominent swelling seen. There is no retraction of nipple, no visible swelling in axilla, and inframammary region appears to be normal. Patient examined on leaning forward position, both breasts fall equally on both sides. On palpation, left breast appears to be normal and right breast, no local warmth is felt and non-tender. A single lump of size 4 by 3 centimeters felt at 5 to 6 o'clock position in the lower inner quadrant, approximately 4 centimeters from nipple areolar complex, which is of irregular in shape and surface, well-defined margins and hard in consistency. Lump is fixed to breast tissue and it moves with breast in both directions. Skin over the lump is pinchable. Lump is not fixed to underlying muscles and chest wall. There is no nipple discharge was seen on compression. On axillary examination, in right axilla, a single round swelling of size 2 by 1 centimeters, non-tender, firm in consistency, which was mobile in nature, palpable in central group. No other lymph nodes palpable in anterior, lateral, posterior, and apical group. Left axilla was normal, supraclavicular fossa is normal. Examination of arms, there is no evidence of edema or discoloration noted over skin. Both arms appear to be normal. On respiratory system examination, bilateral air entry present, normal vesicular breath sounds heard, and there is no evidence of altered sounds. Abdomen examination, there are no signs of abdominal distension, no evidence of free fluid, no organomegaly noted. Digital rectal examination and pervaginal examination was normal. On examination of spine, there is no restriction of movements and there is no evidence of paraspinal tenderness. Central nervous system examination revealed there is no evidence of focal neurological deficit. On summarizing the case, a 54-year postmenopausal woman, mother of 2 children, presented with painless progressive lump in right breast since 2 months, not associated with fever, trauma, discharge, back pain, cough, and abdominal fullness. On examination, there is a single hard 4 into 3 centimeters, non-tender, irregular shaped lump with well-defined borders felt in right lower inner quadrant, adherent to breast tissue, but not fixed to skin, chest wall, and pectoralis major, along with a single firm, rounded, palpable lymph node of size 2 by 1 centimeters in right axilla. Contralateral breast and axilla appears to be normal. With this history and examination, I conclude my provisional diagnosis as a 54-year-old postmenopausal lady with lump in right breast, most probably carcinoma breast, with clinical staging of CT2N1M0.
So coming to the history, so you have a 54-year-old lady who presented with a lump in her right breast.
Sir.
Just listening to this complaint, what are the possible differential diagnoses that comes to your mind? First slide.
So with a 54-year old age, it's most probably for malignancy, sir. And there could be any history of trauma.
No, you listen to the chief complaint.
Sir.
So what are the different pathologies that you will keep in mind? One is carcinoma, others?
Sir, one could be cyst of any simple cyst or breast cyst can be there, sir.
So in a 54-year lady, you will consider a differential diagnosis of breast cyst?
The diagnosis we can't consider, sir, but based on age.
Listen, so it is actually inverse pyramid. You listen to the chief complaint, you have 3 to 4 possibilities in your mind. You take a detailed history, it narrows down to 2 or 3. Then you make a general physical and proper examination. You further narrow it down. So by listening to this complaint only, what are the diseases that comes to your mind?
One is carcinoma breast, and other one will be Phyllodes tumor, sir.
Very good. Any other disease?
Tuberculosis of breast, sir, can be considered. And
how many tuberculosis of breast you have seen?
Sir, I have seen 2 cases, sir, with present as breast lump.
Okay. Any other thing?
So there could be an antibioma, sir, organized abscess can be there.
Antibioma.
And in some cases, granulomatous mastitis can be there, sir, idiopathic granulomatous mastitis.
Okay. So these are the 4 or 5 possibilities that comes to your mind. Next we'll come to your history problem. So go back to the previous. Okay, so this is a lump, 2 into 2 centimeter the patient said, insidious in onset and gradually progresses in nature. The lump was not associated with pain. That is your
yes.
So what will you think if the patient complains that there is pain associated with the lump?
Sir, if there is pain associated with lump, first I can think of any inflammatory, sir, any mastitis.
Look, as a postgraduate students, we expect you to say differential diagnosis.
Okay.
Differential diagnosis, just listen to, there are 2 components. One is an anatomy, second one is a pathology. So you cannot say any inflammatory disease of the breast.
Sorry.
Okay, so remember, whenever you present your case, think of an anatomy, think of a pathology. Now continue.
Sir, mastitis, sir.
What type of, you mentioned about granulomatous mastitis.
Sir.
That is a possibility. Any other possibility?
Sir, if there is any rapid increase in size or any necrotic development of necrosis in the lump, it could be presented with pain, sir. Rapid increase in size. In some cases like Phyllodes tumor, where
you have mentioned is generally progressive in nature, it's a gradual progressive.
Sir.
So, okay, you are right, that there is a rapid increase, there is a bleeding into a tumor, the patient will present with
pain.
Right?
Yes, sir.
Inflammatory conditions, ischemia, infiltration, increase in size. These are the 4 I's which leads to
pain, sir.
Pain. You go to the next slide. So why have you taken all these histories?
Sir,
what is the purpose?
Sir, I have taken the fever history to rule out any mastitis, sir.
The patient doesn't have pain.
It will be there, sir. Patient will have pain also, sir. Sir, in inflammatory breast carcinoma.
Okay. Very good. Inflammatory breast carcinoma. There has to be pain, signs of inflammation, as well as systemic manifestations of inflammation will be present. Okay. Then
there is no history of trauma to breast to rule out any traumatic fat necrosis, sir. And sometimes when there is trauma, due to repeated examination, patient can feel a lump in the breast, sir.
Okay, so we are concerned with nipple discharge. What are the different types of nipple discharge we normally encounter?
Sir, normal nipple discharge can be of serous type, bloody discharge, milky discharge can be there. Purulent discharge will be there, sir. These are the most common types.
In a malignancy, what type of discharge you expect?
Sir, in malignancy, mostly I will be seeing altered bloody discharge will be there, sir.
Bloody discharge,
bloody
or you
discharge.
can say ductal papilloma as well as malignancies, you expect a bloody discharge. You have taken a history of skin changes. What skin changes do you expect in this patient?
Sir, skin changes, mostly dimpling, puckering, tethering, any satellite nodules, ulcerations, pudgy orange appearance can be seen, sir.
So you have to ask specifically.
Sir.
You cannot say the skin changes. So you have to mention these things that gives an impression that you are thinking of a possibility of an invasive tumor. Okay, so you have to mention these things specifically.
What is the satellite nodule you mentioned just now?
Sir, satellite nodule is due to the deposits, metastatic deposits in the skin, sir, which is far from the primary, at least minimum within the radius of 2 to 3 centimeters, sir. Like that separate from the primary focus, sir.
Next, you have asked for history of bone pain, cough, hemoptysis, jaundice to rule out
Distant
metastasis.
metastasis.
Distant metastasis. Okay. So no history of contralateral lump breast. What is its importance? Why do you ask?
So because if any female patient having a previous lump in the left-sided breast, if it turned out to be malignancy, she is having more probability of developing malignancy in opposite side breast also, sir. And some malignancies like lobular carcinoma, they will bilateral in nature, sir. So there could be a previous lump in the opposite sided breast.
The lady could have a fibroadenoma.
Yes, fibroadenoma could be there, sir.
So how does that work? So you have to ask very specifically. There is a history of a lump in the opposite breast. That means this patient probably has consulted a doctor or a physician or a surgeon. So you have to stress on that history. If the lady says there is a lump in the contralateral breast, what is the exact type of diagnosis of that lump is made? You cannot make a vague sentence if a lump is present. Okay, we'll go to the next slide. So what is the importance of all those things?
Sir, the first one, no history of similar lump in same breast or opposite sided breast due to the same reason, sir.
You have asked for no history of any breast surgery.
Sir,
What breast surgery do you expect?
Sir, previously if patient have underwent any BCS, and there could be chances of recurrence, sir. If there is positive margin, there would be chances of recurrence, sir. And in case of any fibroadenoma, if it post excision in biopsy, if it may have developed as like they have given as Phyllodes tumor, there could be again recurrence, sir. So to rule out them.
What do you mean radiation exposure in your case?
Sir, radiation exposure has a relative risk of 6 to developing carcinoma breast, sir. So there is no role of radiation exposure in my patients.
Next slide. Next. Next slide.
Did you find any? So you mentioned BMI. So BMI you also have to mention kg per meter squares. Okay. And is it the BMI the patient is overnourished, properly nourished or malnourished? 24.79.
So she's well built and nourished, sir.
She is well built. How do you know what is that well built means? What do you mean by well built?
So it's basically on mid-arm circumference and.
No, that is to assess the nutritional status. But when you say built, it refers to the structural framework of the patient. And nutrition status you measured by this mid-arm circumference, fat fold circumference thickness as well as BMIs. These are for nutritional status. Okay, so
You mentioned there is no generalized lymphadenopathy.
Sure.
But there is a axillary lymph node you are describing.
Generalized lymphadenopathy for any other lymph nodes, sir, other than the
You
local.
should mention that thing. While examining, giving a breast examination in paper, breast lump, anything, you will tell that there is no other generalized lymphadenopathy except the axilla, which will be described in later.
what do you mean by generalized lymphadenopathy?
So generalized lymphadenopathy when there are greater than or 2 lymph nodes in 2 different places in the body, sir.
Two contiguous or non-contiguous? Non-contiguous areas. Let's say the patient has cervical as well as inguinal lymph nodes, then you say it is a generalized lymphadenopathy, not the adjacent groups of lymph nodes. Inspection.
Sir.
So did you find anything abnormal in this inspection?
No, sir, except biopsy scar, nothing was.
So you have not given a history that biopsy has been taken?
She didn't give any.
But how do you know that was a biopsy? On inspection, how do you know this is a biopsy which has been taken?
On the lump, there is a mark, sir, so thought it has.
So you can say there is a scar mark over the
scar marks.
We don't know. If the patient doesn't give a history, then how can we know from the inspection there has been a biopsy has been made? So you don't find anything abnormality in the
inspection?
Inspection, okay. Next. Inspection is normal.
Sir, inspection.
We'll go to palpation. In your palpation, you have palpated the lump. What is the impression? What lump you are palpating?
I palpated a hard lump, sir.
Okay, so hard means you are palpating a malignant lump.
Sir.
Okay, so now you hard irregular surface lump in the inner and lower quadrant.
But margins are well defined.
Sir, like well-defined margins were there, sir. I can differentiate the lump with the normal breast tissue, sir.
So how do you know the lump is fixed to the breast tissue?
So we'll hold the breast with one hand and we will hold the lump and we will try to move the lump, sir. If it is moving with the other breast quadrant, the breast tissue is like the lump is moving with the breast.
So you say lump is fixed to the breast tissue, moves with breast in both direction. That means lump is fixed or not fixed?
Like it's from the breast tissue, sir.
What is your interpretation on this line? Lump is fixed to breast tissue and moves with breast in both directions. Is it fixed or not fixed?
Fixed to breast tissue, sir.
It is fixed to the breast tissue. It moves with the breast,
Yes.
not irrespective of the breast.
No, sir.
Okay. Now you say lump is not fixed to the underlying muscle and chest wall. What do you mean by the underlying muscle?
Sir, underlying muscle can be pectoralis major, sir, but underlying chest wall means intercostal muscles and serratus.
Okay. So can a lump infiltrate into the chest wall without infiltrating the pectoralis major?
Yes, sir.
How?
So if the lump is in lateral lower outer quadrant, it can infiltrate the serratus.
We will come to your lump.
Sir, in this case, I don't think so. It should infiltrate pectoralis.
So if your lump is not fixed to the underlying pectoralis major, so it implies that it has not infiltrated into the chest wall. For the pectoralis major, you do this
Based,
test, holding the hips and contracting.
and relaxing.
Okay, so by that test only you can know that lump is fixed to the pectoralis major or not. Okay, so what are the directions in which we check for mobility in case of a pectoralis major fixity?
Sir, after
Asking the patient to contract her pectoralis major, then
I will check along the direction of the fibers, sir. Like along the direction of the pectoralis major fibers. If it is not fixed to pectoralis major, the lump will move, sir. If it's fixed along the direction, it won't move, sir.
so you usually check for two directions. Pectoralis major, the direction is like this. For a left one, you keep your hand on the right shoulder. So this is the direction of the pectoralis major. So they check along the direction as well as perpendicular to the direction of the pectoralis major. So it moves with the pectoralis major contracted, then it is not fixed to the pectoralis major. Okay. And you didn't find any nipple discharge. Okay. So the lump is not fixed, it is fixed to the breast tissue, 4 into 3 centimeter, hard, well defined in lower inner quadrant. And you find a mobile axillary lymph node. So this is So let's come to this axillary lymph node. Forget about the breast. So do you think this axillary lymph node is a metastatic node or it is a benign enlargement of the node?
Sir, it could be anything, sir, both benign and metastatic, sir. Like, it could be reactive lymph node also, sir.
Okay, so now then you have given your diagnosis as
Clinically palpable lymph node.
clinically palpable lymph node, but you are not sure this is a metastatic lymph node. So is there any way to confirm that this is actually a metastatic lymph node?
Sir, by clinically we can wait for some time by giving antibiotics or anything, sir. If it's
In this patient, you will give an antibiotic. Is breast malignancy an infective malignancy? That is particularly true for penile malignancies. Breast, you will give to this patient a course of antibiotic, then wait for again to examine the lymph node.
no, sir, I can go for radiological investigation.
What radiological investigation?
Ultrasound I can go, sir.
You do an ultrasound axilla to look for signs of malignancy in the lymph node. What are the ultrasound sonic signs of malignancy of a lymph node?
So normally the lymph nodes are oval in shape, sir. But in cases of malignancy, they will be rounded in shape.
Rounded.
And there will be loss of fatty hilum, sir. There will be pericortex thickening will be there. Sometimes neovascularization or neovascularization will be there, sir. multiple levels of lymph nodes, either matted or clumped lymph nodes we can see, sir, in some cases.
So very good. So rounded lymph nodes, loss of hilum, the usual reniform test shape is lost. So you can have a suspicion that probably there is presence of a malignant lymph node. At the same time, ultrasound will pick up the presence of other nodes which are subclinical, and it will help you in a guided FNSC of the lymph node if required. Okay. Okay. So next. Why did you check for examination of the arms?
Sir, if there are any multiple group of lymph nodes,
Your patient is a single group of lymph nodes, and that is a mobile lymph node, and you are not sure it is a metastatic lymph node. So you look for any obstruction, compression by the lymph nodes into the axillary vein, so the patient may have lymphedema, but which is not expected in your patient. Okay, and you have examined all your respiratory system, abdominal system, other systems are normal. So you have made a clinical diagnosis of T2N1 M0. Okay, so you don't consider diagnosis of Pillard's tumor in this patient?
Sir, actually, Pillard's tumor will be very rapidly growing, sir, and there will be bossulated appearance. In these cases, like in this case, I couldn't find those features, sir. But I will keep it as a differential to rule out, sir.
Because your lymph node is not confirming to a metastatic lymph node, you should always keep a possibility of Pillard's tumor in your differential diagnosis. Ultimately, we have to do a triple assessment to confirm whether it is dealing with a malignancy or a Pillard's tumor. So, in view of this triple assessment, so what will be your plan of imaging in this patient?
Radiological, sir.
What radiological investigation?
Sir, I will go for ultrasound of bilateral breast with axilla, sir.
So, is in a 54-year-old lady, ultrasound is preferred or a mammogram is preferred?
Actually, mammogram is preferred, sir.
So, why you will ask for a ultrasound?
Why I will go for ultrasound means it will tell me whether the node is whether the mass is whether it's cystic or solid component or any necrotic.
You are palpating a hard mass. How do you expect it to be cystic?
Necrotic component.
Necrosis will not make it hard.
X-ray mammogram will do, sir. It will be the
So
first
the
investigation.
system is that with an X-ray mammogram. So what are the different views of an X-ray mammogram?
Sir, X-ray mammogram will go for basically two views, sir. Mediolateral oblique view and craniocaudal view, sir.
So you will ask for a mammogram of the right breast only or both breasts?
Both breasts will take, sir.
What are the signs of malignancy in a mammogram? Is it a Birat? You know about the Birat scoring?
Yes, sir.
But tell me, what are the characteristic appearances of malignancy in a mammogram?
Sir, in a mammogram we can see multiple speckled calcifications we can see, sir, and speculated borders will be speculated margins we can see, sir, in the case of breast lump if it's malignancy, and there will be multiple dystrophic calcifications will be there, sir.
So what will be appearance? It will not be dystrophic calcification. What would be appearance? Microcalcifications will usually mostly
Pleomorphic
concern.
appearance.
Yes. Any other thing? Okay. So you'll do a mammogram. So after mammogram, then what will be your plan of? On the third part of the triple assessment.
Will we go for histopathological examination?
What histopathological test you will advise to this patient?
So for this patient, as I'm suspecting it as a malignancy, I will go for ultrasound guided true cut biopsy, sir.
In this patient, the palpable lump, why ultrasound guided true cut biopsy? Why not a simple straightforward true cut biopsy?
In simple biopsy, sometimes we can go more deep than the lump, sir. Or
No. That is usually done for, you can say, for thyroid. Here, there are thyroid, you have major vessels in place, and some of the nodules, the characteristics can pick up. But this is. But it is a palpable lump. Why do you need an ultrasound for this?
Ultrasound guided is most associated with more specificity, sir, than the normal true cut biopsy.
I don't know, sir. That ultrasound guided true cut biopsy should be done for an ultrasound breast lump.
Any response from the house?
If that lump is having variegated consistency, if you want to hit the solid areas, then you require a ultrasound guided true cut biopsy. That's what probably wants to say. Is the same thing you want to say?
Every breast lump has to be ultrasound. Lump you go straight for the all 4 maps should be done ultrasound guided.
Not necessarily. Not necessarily.
Right. See, clinically, the lump which looks solid, there could be some areas of necrosis. There could be some areas of hemorrhage. So to see exactly the solid lump, we need say ultrasound guided.
Should be done ultrasound guided. I am very sorry if I am wrong.
Yes, ultrasound.
Today ultrasound without FNAC should be done without the ultrasound. Everything should be done ultrasound guided biopsy.
Yes, sir, you're right.
This is the teaching. If I am wrong, I am very sorry.
If it is FNAC, ultrasound is a must because it is a needle. It may miss very vital places. But if it is a true cut biopsy in a hard lump, like a breast lump, you can straightforward go for a true cut biopsy.
So now the next speaker, Dr. Deepan M. Koshambi from High Tech Medical College. He will be speaking about obstructive jaundice.
Good afternoon, respected judges and dear audience. Myself, Dr. Deepan M. Koshambi, second year PG from High Tech Medical College and Hospital, Bhubaneswar. Sorry, sir. Myself, Deepan M. Koshambi, second year PG from High Tech Medical College and Hospital, Bhubaneswar. Today I am presenting. Today I am doing a case presentation on obstructive jaundice. A 40-year-old male presented who is residing at Badrak, farmer by the occupation, at the surgery OPD with the chief complaints of yellowish discoloration of urine since 6 months, and itching all over the body since 6 months back, black colored stool, intermittently passing black colored stool since 4 to 5 months, and pain in right upper abdomen since 6 to 7 days. History of the present illness: patient was apparently all right 6 months back. Then he observed the passing of the yellowish colorish discolored urine, which was sudden in onset and progressively became darker, which was associated with itching, beginning at the bilateral lower limb and progressively over to the whole body. For this, he took the initial treatment, primary treatment at the local hospital, where he was managed conservatively. Followed by he started passing intermittently black color stool, which was black tarry stool, which was sticking to the pan. Again, he took the conservative treatment at the local hospital. Followed by 6 to 7 days back, he had sudden onset of dull aching pain in the right upper quadrant of the abdomen, which was non-radiating, and there was no aggravating factors, but it was relieved by pain medications. So he also had a significant weight loss in last 6 months, approximately over 30 kgs. There was no history of vomiting, fever with chills or rigors, hematemesis, abdominal distension, and no history of breathlessness, headache, or seizure. Partially, no any such previous episodes before 6 months were present, and no history of any blood transfusion or surgeries. Family history, no such history present in family. Sir. Personal history: patient had reduced in his appetite. The sleep cycle was normal. Stool mostly pale colored, but intermittently black tarry stool present. No allergies, and alcohol consumption. He was a chronic alcohol consumption. He was a chronic alcoholic. Consumption of 150 to 180 ml per day since 15 to 20 years, and it was of local brand. General examination: patient was examined in properly illuminated room with consent. He was conscious and well oriented with time, place, and person. Vitals were within normal limit. His BMI was 19.4 and his ECOG score was 1. Patient was severely icteric and paler. No signs of cyanosis, lymphadenopathy, or pedal edema. There's a severely icteric eyes. Coming to the systemic examination for abdomen, on inspection, patient's torso was well exposed to, and he was examined in supine position. The shape of the abdomen and the skin was normal. The skin had a yellow tinge. All the four quadrants were moving equally with respiration, and respiration was abdominothoracic in nature. Umbilicus was central, over and inverted. No scars of previous injury or surgery present. Scratch marks were over the upper quadrant of bilateral upper quadrant of the abdomen were present. No visible veins or pulsations were found. On cuff impulse, bilateral inguinal orifices were normal. No sign of any ventral or lumbar hernia. On palpation, on touch, the skin temperature was normal. With superficial palpation, the hepatomegaly was found. No other organomegaly present. No tenderness or rigidity or guarding. On deep palpation, hepatomegaly with the lower border of liver was 6 cm below the right costal margin found, laterally till the anterior axillary line and medially till the symphysis sternum. The edges were smooth and round, and no nodularity found or no tenderness. Unable to put fingers between the right costal margin and the liver bed, and liver was moving downward with the inspiration and the respiration. All other regions of the abdomen were normal. No other organomegaly found. Umbilicus was normal. No other abnormality found. Fluid cell was negative. On percussion in right side, percussion started from the second intercostal space, which was resonant in nature. Moving downwards from 6 intercostal space, the dull sound was heard till it lasted 6 cm below the right costal margin, and all other quadrants tympanic sound was present, and shifting dullness was negative. On auscultation, normal bowel sounds were present, and no fluid was found. For rectal examination, I'll be on rectal examination, on inspection and hearing, no abnormality found. On proctoscopy, showed no hemorrhage. To summarize the case, a 40-year-old male patient presented with jaundice, pruritus, melena, and abdominal pain. He had significant weight loss in last 6 months and disease and decreased appetite with severe icterus and pallor. Scratch marks over the bilateral lower limb and abdomen. Hepatomegaly was present. So, to summarize, sir, I would like to say the provisional diagnosis of the obstructive jaundice most probably due to malignancy.
Obstructive jaundice?
Most probably due to some malignancy.
Some malignancy. I was just telling you, you have to give a diagnosis. You have to stand by your diagnosis.
Yes, periampullary carcinoma.
You can mention that thing, obstructive jaundice secondary to a periampullary carcinoma. Now justify your diagnosis based on your history. Why you think it is a periampullary carcinoma?
First of all, sir, patient doesn't have a long history of jaundice. It's a short history since 6 months with associated with.
So first you think this is a patient who is having obstructive jaundice because presence of itching is present. And there is a history of pale color stool. These are the characteristic features of an obstructive jaundice. Now, obstructive jaundice again due to stones or maybe due to malignancy. So why do you think this obstructive jaundice is due to malignancy, not due to stones?
First of all, sir, because it is painless.
So you say there is presence of dull-aching pain. What type of pain you are expecting?
Tenderness was absent, sir.
You mentioned there is dull pain over the right right hypocondylar.
I meant to say that tenderness was absent. There was no positive signs of Murphy's or anything. Plus, he had a history of.
How do you expect the presence of this pain in this patient? And you say it is non-radiating. Where does this pain is likely to radiate?
Sir, if it's cholangitis or cholecystitis, the pain might be, if it is due to stone, then it might be radiating to the right shoulder or towards the right.
So, okay, this is not due to stone. Then what is this cause of this pain?
Sir, because of the hepatomegaly, there might be
enlarged liver. There is stretching of the Glisson's capsule, and the patient is having dull-aching pain in the right upper abdomen. So, very good. So, your diagnosis is because of this enlarged liver and obstructive jaundice, and you think this is a patient.
No, sir, it's a loss of weight.
Loss of weight and appetite because of.
Yes, sir. He is also passing the pale color stool, intermittently black starry stool is also present, melena.
Okay, so normally what happens in a periampullary carcinoma, we expect the gallbladder as well as the liver to enlarge.
Yes, sir.
but here you find only the liver enlargement. So how will you justify your diagnosis?
Sir, to justify findings, I would like to go further to the evaluation, sir.
Like, can you think this patient is having a malignancy at the what you say Klatskin, or a malignancy when the common hepatic duct where the gallbladder is not enlarged, liver is enlarged?
Very likely a melena would be found in Klatskin tumors, sir, because sloughing of the mucosa of the periampullary is one of the causes which may cause melena, but the Klatskin tumor is very likely to cause melena, sir. So that is why the first, if I'll go, then I'll guess if it could be periampullary, followed by cholangiocarcinoma of hilar or distal. But first option is, well, first my provisional diagnosis would be periampullary. Second, I can go for I would.
So periampullary carcinoma includes 4 areas where malignancies occur. So if there is presence of melena, which are the areas which are likely to be involved in this patient?
Sir, the ampulla of Vater, then distal 1/3 of the stomach.
Stomach, distal 1/3?
Yes, the distal part of the stomach is also included.
In periampullary carcinoma, it is.
Yes, the distal part of the CPD,
yes,
Vater, head of the pancreas, and stomach, sir.
Or it is usually classically the duodenal malignancies.
So Vater includes the duodenum 3 centimeter around the duodenum and the Vater, sir.
But you will likely to keep the distal 1/3 of the stomach malignancy also in this patient.
The 4 parts in the periampullary carcinoma are listed as these 4.
Okay, so let's go to your investigation. So you have made your diagnosis. This is a periampullary carcinoma. You made up the diagnosis. Now, how will you investigate this patient?
Sir, I would like to start investigating with the biochemistry of the. I would like to start with the complete blood count.
What changes you will expect?
Yes, sir. Because of the melena and weight loss, I would expect there would be decrease in hemoglobin concentration. I would like to correct
What will be the changes in LFT?
After CBC, I'll go for the LFT, sir. If it's obstructive jaundice, the first thing I would like to see is the raise in alkaline phosphatase, GGT, and 5 nucleopeptidases.
So you do all those things. Is there a certain level beyond which it is the increase in this liver enzyme level is considered significant? Let's say ALP level is normal, you say it is up to 80, you mean. Now it is raised to 90. Do you consider this to be a significant elevation of ALP?
No, sir. It's around more than three folds. Sorry, sir.
So usually 3 times elevation gives a more confirmed value that actually this thing has been enlarged. So you will find a abnormal. LFT will be enlarged, serum bilirubin, direct bilirubin, all these things will be enlarged, elevated, and you. Okay. And what about the PT and serum albumin?
Sir, serum albumin, if it is 6 months old, so serum albumin will be decreased, sir, because albumin has a half-life of 21 days only, so there will be, it's a long history, so maybe serum albumin will be found less.
You have examined this patient jaundice. There is presence of only scleral icterus, or there is icterus involving the skin, palm, shoals?
Pruritus is already set in. Pruritus is already set in, sir. So skin is already yellow. He's a dark colored, so yellow teen skin was.
So can we have an idea about the level of bilirubin depending on the scleral icterus, icterus present on the skin?
If the icterus is present, it will minimum above 6, sir. Minimum above 6. If icterus is there, minimum about 2.5. Skin is there, mucosa is involved, and it's above 6. And if this is a long-standing, actually it must be more than 10, sir.
Okay, so any role of any tumor marker in this patient?
Yes, CA19-9.
You will advise on CA19-9 in this patient. Okay, so what about imaging in this patient?
Sir, as to confirm my diagnosis, I will go for
diagnosis will be confirmed on histopathology.
Yes, sir. Now to plan.
Will plan and what radiological investigation?
Sir, I will go for CT scan with.
Straight away, any role of ultrasound in this patient?
Sir, ultrasound won't be. It will just tell us about the if there is any mass, it is a subjective, first of all, test, sir. So it might be able to tell us about any mass or the status of the
You will
gallbladder.
advise or not?
Yes, sir.
Because after passing out, you will be a surgeon.
Yes, sir.
So will you advise or not?
Yes, sir. I'll definitely.
You will advise an ultrasound. For what purpose? What you want to see in an or detect in an ultrasound?
Sir, just in case to rule out any obstruction or the distal CPD or any gallbladder pathology or any pancreatic, what are the
So you have,
signs?
from your clinical diagnosis, you have two possibilities you mentioned: periampullary carcinoma and a Klatskin tumor. Can ultrasound help you in differentiating between these two?
Sir, it can help me telling double duck sign or anything which will help me to see whether I should go ahead with the this CT with the pancreatic protocol or not, sir. The double duck sign is positive,
If there is double duct sign is seen, then
then the obstructive jaundice has been is confirmatory plus whether the gallbladder is distended or not, because of the hepatomegaly I am not able to palpate the gallbladder, sir.
so you are interested in evaluating the gallbladder.
I would like to see.
Okay, so let's say you have done an ultrasound. Now, if we in a jaundice patient, there are two imaging that comes to our mind. One is an MRCP, second one is an CT scan. So how will you diagnose or decide whether you will advise a MRCP in this patient or a CT scan in this patient?
Sir, if the ultrasound mentions about the mass lesion, then I'll go for the CT scan. And if it advises, tells about any stricture or anything causing the dilation of the proximal CPD or that.
Obviously, jaundice patient, it will have dilatation of the proximal
But sir, if there
CPD.
is no mass lesion or anything, then I might go for MRCP. But if there is a mass lesion which is mentioned in the ultrasound, then I'll go for.
So there are two things. So one thing is a mass lesion. You say that this is periampullary carcinoma and there is mass. You will advise an CT scan. Let's say there is no mass.
Yes.
So you advise an MRCP. So what possibility? Thinking of what disease you will advise an MRCP? Why you want to do an MRCP if there is no mass? So you'll think of choledocholithiasis in this patient if ultrasound doesn't show any mass lesion.
Maybe, sir.
No.
I'm not getting the answer.
My simple question is that what next imaging you will do? So you say mass lesion, you will do CT scan. What is the purpose of doing CT scan in a mass?
Sir, to see the extent of the mass, the thing that is surrounding, is it encasing or embedding the vessels?
So you detect whether there is the mass is mostly for staging of the disease as well as to see whether the mass is resectable or not. So that will help in our plan of management. Okay, so you need certain information. On the opposite end, you said there is no mass, I will advise an MRCP. Why you will advise an MRCP? What do you think? What information is likely to get?
I must. No, I will definitely go for CT scan.
Okay. So in your patient, let's say you are dealing with a periampullary carcinoma. So you have advised a CT scan with pancreatic protocol for staging the disease. Now, you tell me what are the signs of unresectability of a periampullary carcinoma tumor, or particularly a carcinoma head of the pancreas. That is the most common periampullary carcinoma. So, what are the signs of unresectability? You will not venture into a surgical treatment.
So first of all, if there is an encasement of the supramesenteric artery or celiac artery or the common hepatic artery, then if there is a match to the liver or peritoneal match cannot be found in CT scan. Then the supramesenteric vein is also been encased more than 180 degrees being covered.
Are you aware of certain borderline pancreatic malignancies? There are two types: resectable pancreatic malignancies, borderline pancreatic malignancies, unresectable pancreatic malignancies. So, what are the signs that will say this is a borderline pancreatic malignancy, pancreatic tumor, which you can downstage with an NST, then plan and curative resection? So, what are the signs of borderline pancreatic malignancy?
Sir, as I said, if these arteries all the SMA and supremazing artery, celiac artery are abutting, less than 180 degree only coverage is there, and supremazing vein is also less than 180 degree. It's been affected. Then can plan for that is considered in the borderline resected. We can plan for the
So tell me certain definitive procedures as well as some palliative procedures. So if mass is resectable, you will perform a curative resection. Mass is unresectable, you will do some palliative procedures. So tell me some definitive procedures, palliative procedures for periampullary carcinoma or carcinoma head of the pancreas.
Sir, definitive procedure we have to go for the pancreatic or duodenectomy people's procedure, sir. And for the palliative procedure, for the bypass like gastrojejunostomy and that still if there is extensive growth and it's not possible.
Doing a triple bypass.
Yes, sir, triple bypass.
What is that? That is the palliative we are doing.
Gastrojejunostomy, jejunostomy, and
Look, palliation means palliation of a symptom. Okay, we're not doing a curative symptom. Now, what are the palliation of the symptom? Symptom in this patient is jaundice. Symptom in this patient is sometimes pain. Symptoms in this patient, the patient may develop an obstruction to the bowel. Okay, so or in a duodenal obstruction, this patient can suffer. So you will do a palliation of these symptoms. So now tell me how to palliate jaundice, how to palliate pain, how to palliate obstruction in this patient.
Sir, to palliate the obstruction, I'll do the gastrojejunostomy. To palliate the jaundice, I'll do the hepatico-jejunostomy and jejunostomy to prevent the regurgitation of the.
Hepatico-jejunostomy is not indicated in this patient. So again, there are palliation two methods. One is surgical method, another is endoscopic method. Are you aware of certain endoscopic methods of palliation?
Endoscopic method, there is PTBD, where you can do the drainage of the bile duct, biliary drainage, or you can go for the ERCP. But sir, if there is an obstruction, then ERCP will be difficult, sir, most likely.
From the house, anybody can ask any questions.
Because as sir said, there is an obstruction.
Obstruction where? Obstruction to the bowel or to the biliary tract?
Bowel obstruction. So the ERCP might be difficult to maneuver.
Where do you expect the obstruction to happen in the bowel? It is in the duodenum or the antrum or the outflow stomach, where? In a case of obstructive jaundice. Your case is a case of periampullary carcinoma, right? So you think ERCP is not feasible?
So if it's not feasible, then it will just be
PTBD is a procedure which is usually contemplated in a Klatskin tumor on a higher up obstruction. You never contemplate doing a PTBD in a periampullary tumor, right? PTBD is only contemplated when you have a higher up obstruction. ERCP cannot be comfortably done, then you can do PTBD. What is a periampullary tumor? What is a periampullary tumor? What do you understand by that?
Single or multiple sites. Tumor at the ampulla of water covering 3 centimeters around.
Does that mean a periampullary tumor? By definition, what is a periampullary tumor? Periampullary tumor is not a single entity. It covers the distal CBD, the ampulla, the duodenal carcinoma, and the carcinoma head of the pancreas. Because all these 4 tumors, clinically, radiologically, biochemically, they have similar maneuver to be done. Treatment is all one. right? So that is why this is grouped in as a periampullary. Don't take a concept that because from the beginning I have been marking, you are probably focusing only ampulla, ampulla, ampulla. So it is very obvious that your understanding has to be very clear what is a periampullary. Then what is the role of a GGT in the liver function test profile? What is GGT actually? It is not glucuronide. It is gamma glutamyl transferase. What is that?
Sir, it's an hepatocytic enzyme.
Mhm.
It is enzyme. It is secreted or it is elevated when there is a biliary canalicular obstruction or renal alcohol.
So how does it help a surgeon for diagnosing an obstructive jaundice, or it guides in any way a surgeon?
If it's raised along with the ALP, then it helps to diagnose whether it's an obstructive jaundice or diabetic or because of
You know what is about a enterohepatic circulation? What is that?
sir, when the bile exuded from the CVD enters in the duodenum, from ileum it is again goes back to the biliary canaliculus.
Mhm. So how it is significant?
So if there is an obstructive jaundice, then the bile is not secreted, not emptied into the duodenum, then that bile gets accumulated in the biliary canaliculus, from where it gets oozes out or gets out of the canaliculus and enters into the blood streams. So as a result, the jaundice of bilirubin is raised. Particularly bilirubin is high.
Who is bilirubin is important, conjugated or unconjugated? In an obstructive jaundice, conjugated. What about the unconjugated one? What are the components of bilirubin?
Bile salts, bile cholesterol.
What's the component of bile?
Bile composition.
What's the composition of bile? Majority amount of bile is composed of water. Okay. And done. Done. Thank you. Thank you very much, Dr. Deepak.
Next speaker, I would like to call Dr. B. Monica from AIIMS Bhubaneswar. She will be going to present about groin swelling.
Very good afternoon, faculties and delegates and my colleagues. Now I'll be presenting a case on groin hernia. My patient, Mr. X, aged 45 years, resident of Jajpur, Odisha, construction worker by occupation, presented to surgery OPD with chief complaints of swelling in his right groin for the past 11 months. History of presenting illness. My patient was apparently alright 11 months ago when he noticed the swelling in his right groin, which was insidious in onset in the groin to begin with and gradually increased in size to extend into the scrotum. It was initially reducible spontaneously on lying down, now reducible manually, but reappears on standing, walking, and straining. There's no history of pain or any attack of irreducibility or abdominal distension or vomiting. Patient gives history of increased frequency of micturition, inability to start and maintain the stream, and also history of poor stream and sense of incomplete evacuation of bladder for the past 6 months and is currently on medications for the same. There's no history of burning micturition or chronic cough or constipation. His occupation involves heavy weightlifting and there's no history of swelling elsewhere in the body. Past history, there are no known comorbidities. There is no history of any surgeries in the past. Personal and family history. My patient consumes mixed Indian diet with normal sleep pattern. Is a known smoker, smoking 1 pack per day for the past 20 years. Is not a known alcoholic. There's no history of allergies. There's no history of any collagen disorders in family. Summarizing my history, 45-year-old male, a construction worker by occupation, and a known smoker, presented with a reducible right inguinal scrotal swelling and features of lower urinary tract symptoms without any complications. On general examination, my patient is conscious, well oriented to time, place, and person. Vitals, heart rate of 89 beats per minute with regular rhythm and normal volume. Blood pressure of 134/78 mmHg and saturation of 100%. There is no pallor, icterus, clubbing, generalized lymphadenopathy. BMI of the patient was 23 with Karnofsky's performance score of 9. Loco-regional examination. I have examined my patient after taking consent and maintaining privacy in a well-lit room, exposing from nipple till mid-thigh in standing and lying down positions. On inspection, abdomen is not distended. There were no scar marks. 8 by 4 centimeter pyriform shaped swelling is seen in the right inguinal region, extending till the base of the scrotum. There was cuff impulse present. Skin over the swelling appears normal. There were no visible peristalsis. Penis is deviated towards left. Left side inguinal region appears to be normal, with left sided testis appears to be in the normal position. The swelling is not spontaneously reducible on lying down. On palpation, inspectory findings were corroborated. There was no tenderness or local rise of temperature. There was a 10 by 4 centimeter pyriform shaped swelling, which is palpable in the right inguinal scrotal region, above and medial to the pubic tubercle, extending till the base of the scrotum. Expansal cuff impulse was palpable. Swelling has elastic consistency, which is completely reducible manually and unable to get above the swelling. Right testis could not be palpated separately from the swelling. On deep ring occlusion test, impulse is felt at the tip of the finger on occluding the deep ring. Siemens 3-finger test impulse is felt at the index finger. Skin over the swelling is normal. There's no impulse on cuff over the left inguinal region and left testis is palpable. There were no Malgaignan's bulges seen. On DRE, anal tone is normal with grade 2 prostatomegaly palpable. Other systemic examinations are in normal levels. This is the deep ring occlusion test. Summarizing my case, a 45-year-old male construction worker and a smoker presented with reducible right inguinal scrotal swelling and features of lower urinary tract symptoms. On examination, there was 9 by 4 centimeter pyriform swelling in right inguinal region extending till the base of the scrotum with expansile cuff impulse, reducible manually and impulse felt at the deep ring on ring occlusion test. Provisional diagnosis is right indirect, uncomplicated, complete inguinal hernia, enterosis.
Okay, so as a postgraduate, you will get short case on this. Postgraduates are usually you don't get long cases on inguinal hernia. Okay. So now two things from your history that it is pretty obvious that you are dealing with a patient who is having a inguinal hernia, right-sided inguinal hernia from the history itself. You mentioned there is no swelling elsewhere in the body. That is a very vague sentence. What do you mean? This patient has a lipoma or a dermoid cyst on his forehead. Does it have any relationship with an hernia?
No, sir.
So what do you mean by no swelling elsewhere in the body?
Sir, I wanted to ask if he has got left side hernia also.
So you mentioned specifically. So whenever you present the history, you say what swelling you are looking for.
Yes, sir.
You have to ask whether there is any swelling overlying the other potential hernial sites. You should not ask only about left-sided hernia is present or not. The patient is having urinary problem. The patient may have raised intra-abdominal pressure. The patient may have an umbilical hernia. Okay. So second, there is no surgeries. Are all surgeries in the body concerned with development of a right-sided hernia?
Appendectomy.
So you have to mention that specifically. You cannot be vague in a postgraduate examination. And second thing, the patient is a known smoker. Known to whom? You say is a known smoker, known alcoholic. What do you mean by known? Known to whom? This is a wrong way of presenting cases. The patient is a chronic smoker for last 10 years. You give a history of 10 years. Second, what you do, I have seen the deep inguinal ring occlusion test. Your interpretation is completely wrong. I'm sorry, that is not the way the deep ring occlusion test is done. What is the concept of doing a deep ring occlusion test? Why at all we do a deep ring occlusion test?
Sir, to know whether it's a direct or indirect hernia.
So you get that you know direct or indirect just by having an impulse at the deep ring. You go back to that video. So can you explain what you are doing?
So I've palpated for anterior superiliac spine.
Yes.
And the pubic symphysis.
Yes.
I've noticed the mid-inguinal point.
Yes.
And half an inch above it, we have occluded the deep ring.
Yes.
And asked the patient to cuff.
Then, so this is what I mean to say, because if postgraduates are there, this is a partial doing of the test. What is the concept? You have to differentiate whether you are dealing a indirect inguinal hernia or a direct inguinal hernia. Your step up to what you have described is correct. You ask the patient to cuff. Now, with your finger on the deep ring, if a swelling appears, this is with a swelling appears near the superficial inguinal ring. That means you have occluded the deep ring till the swelling appears when the patient coughs. What does that mean? You are applying pressure over the deep inguinal ring. You ask the patient to cough. Now a swelling appears near the superficial inguinal ring. What does that mean?
It's a direct hernia.
Obvious. So appearance of a swelling when the patient coughs indicates that you are dealing with a direct inguinal hernia. Now in case of an indirect inguinal hernia, you will not get a swelling because you are occluding the deep inguinal ring. So next step is to you remove your pressure from the deep inguinal ring. Again ask the patient to cough. Now this swelling appears near superficial inguinal ring. You say an indirect inguinal hernia is present. You have demonstrated the presence of an hernia in both the cases. In the first case, with your finger occluding the deep ring, which suggests it is a direct inguinal hernia. In the second case, you demonstrated presence of a bulge with your pressure released from the deep inguinal ring. You demonstrated there is presence of an indirect inguinal hernia. So don't make that mistake in the exam. Okay. So, do you routinely practice Siemens technique? So, why do you mention Siemens technique? I don't know. We routinely don't practice Siemens technique. It is very uncomfortable. The patient putting 3 fingers in 3 areas. So, deep ring occlusion test is sufficient to differentiate whether we are dealing with a inguinal hernia or it is a direct or indirect inguinal hernia. How do you know this is an enterocyte?
So the consistency of the swelling, it was elastic, and the first part, it was difficult to reduce.
Any other findings? What findings you will get on inspection? What is on palpation? What is on auscultation? What is on percussion? In case of an enterocyte.
Sir, in case of an enterocyte, on palpation, we'll have...
on inspection, finding you likely to get?
Sir, if there is visible peristalsis, we'll be
very
able
good.
to notice.
You can see peristalsis on palpation. You get say it is a elastic feeling. What about percussion? You will get?
We'll get tympanic noise, like resonant.
Okay, resonant sound, and on auscultation you can
Bowel
get
sounds will be
bowel sounds. Okay. So now these are the you may or may not get, but these are the findings you should look for when you do a examination of the inguinal hernia. Now, what is your hernia? It is a complete or an incomplete inguinal hernia?
So, in my case, it's a complete inguinal hernia, sir, because right side testis is not
Okay.
altered.
So,
Separately from the swelling.
okay, your diagnosis is a right-sided complete inguinal hernia. Probably this patient is having a enterocyte. Okay, and it is an uncomplicated hernia, no evidence of a complication. But this,
What do you mean by complicated?
Sir,
What do you mean by complicated hernia?
so any complications that the patient might progress to, like being irreducible hernia or an obstructed hernia and a strangulated hernia.
What are the characteristic feature of the strangulated hernia?
Sir, in case of a strangulated hernia, patient will give history of pain in the inguinal region. There will be abdominal distension due to intestinal obstruction, and on examination, sir, there will be tenderness in the inguinal region. Abdomen will be distended, and there will be raised. There will be history of fever and raised counts.
It will give a sudden increase of size of the hernia in strangulated. And there is a pain, definitely there is pain, sudden increase in size, and it is not reduced. And there is sudden increase, that is the one of the most clear. And the expansile impulsion cupping, what about that?
Impulse on coughing will be absent.
Absent. So these are the characteristic pain. Sudden increase in size, expansile impulsion, because it is a obstructed part and suddenly it becomes strangulated. And patient is in excruciating pain. Okay.
now how will you manage this patient? This patient has two problems. One is, let me just ask you, what are the tests in an inguinal hernia you will do with the patient in standing position? What are the tests you will do with the patient in supine position?
So in standing position, we'll see for cuff impulse, and if it is only a bubonocele, we can also test for deep ring occlusion. But if it is a complete hernia or a funicular hernia, we will ask the patient to lie down and we'll check for the deep ring occlusion test.
The most important test that you elicit when with the patient in standing position is the getting over the swelling. Okay. In a hernia, you cannot get over a swelling. That test has to be done with the patient in standing position. Second test, you say it is either a visible or an palpable cuff impulse. These are the two tests which we do with a patient in standing position. All your deep ring occlusion test and other tests that can be done in the patient with supine position. Okay. Now let's say you have evaluated this patient. There are two problems. One is a urinary problem. You get a prostatomegaly. Second one is then right-sided uncomplicated hernia. Now, what will be your plan of management in this patient?
Sir, I'd like to get ultrasound of KUB to see the. First, we'll evaluate the patient for his features of LUTS with ultrasound of KUB to look for post-voidal residual urine, and based on that and the uroflowmetry findings, we can manage the patient medically, or we can go with surgical management based on his post-voidal residual.
What uroflowmetry findings will suggest that this patient is having bladder outlet obstruction due to prostatic enlargement?
So flow rate.
What will be the value of this flow rate, which suggests that there is severe obstruction to the bladder outflow?
So less than 12 ml.
Less than 12 millimeter. Any other thing that we want to see in case of an uroflowmetry? Less than 12, less than 10 usually we take. But what other things you will seek for uroflowmetry? Because when you order a test, you should be able to interpret the results. Okay, so now you have advised an uroflowmetry. You have advised you will also do an ultrasound also.
Yes, to look for the post-voidal residue.
So you will ask particularly for urinary symptoms. So let's say there is urinary symptoms such as there is severe LUTS, there is presence of 100 to 150 ml of post-voidal residual urine, and there is a flow rate which is around 8 ml per second. So what will be your plan vis-a-vis a patient who doesn't have features of severe bladder outlet obstruction on ultrasound?
So first I'll keep the patient on medical management and with behavioral therapy. And once patient symptoms are relieved, then I'll go with his hernioplasty, repair of his hernia.
So you mean to say you will first tackle the risk factor of developing hernia, which is in this patient is a enlarged prostate, due to which the patient invariably strains, which has led to development of the hernia. So you will tackle the patient urinary symptoms first, followed by an hernia repair.
I'll also counsel the patient regarding the warning signs of it being, because it's a complete hernia, chances of being irreducible, and if patient develops any history of abdominal distension and not passing stools and bleeders, I'll warn the patient.
Okay, so you warn the patient about the signs of features of complication. If the patient has those, he has to report immediately to the hospital. Okay. So accepted. Now, in this patient, what will be your plan of treatment? So let's say you have taken care of the LUTS part. Now, what about the hernia management? What thing you will advise to this patient? First and foremost, whether this patient will require surgery or not. If the patient requires surgery, what surgery?
So this patient definitely requires surgery because it's a complete hernia and there are chances of having complications. And I'll explain the patient about his condition and the options.
First thing that you have decided for surgery in this patient. Okay. So now what surgery?
So if it is me, I would go for open hernioplasty, but still I will explain the patient regarding the surgical options available and the complications.
So why you will prefer open hernia repair in this patient? Because nowadays every surgery is being performed laparoscopically. Why you will advise this patient to undergo a open hernioplasty?
So because I am not.
Let's say you are working in your department. You are working in the Department of General Surgery in AIIMS. What will you?
So then I'll give the options of open surgery and a lap surgery to the patient.
Okay, so
and plan with.
In a simple way, I want to ask you what are the benefits. You would counsel the patient, na?
Yes, sir.
You have to give him some, describe or discuss with him certain benefits of open surgery, certain demerits of open surgery, certain benefits of laparoscopic surgery, certain problems with laparoscopic surgery.
Yes, sir.
What are the advantages of doing open surgery in this patient? Quickly, you were probably seeing Delhi patients, hernia surgery. You counsel patient now. Why you will advise this patient? They will say, no, doctor, I want laparoscopic surgery. You have to tell him now. What are the benefits of open surgery?
So benefits of laparoscopic surgery will be the patient will have this pain and the scar.
My question is, what are the advantages? You say I will do an open surgery. Open surgeries are also being done. But what are the advantages of open surgery in this patient?
So later on, if he wants to, if he requires a surgery for prostate, his enlarged prostate.
Then open surgery is a contraindication, or laparoscopic surgery is a contraindication. Most of the prostate surgeries are now done. We perform TURP. It doesn't matter that you are planning for an choosing an abdominal route for prostatic surgery. Laparoscopic surgery, there are a number of benefits of you say minimum pain, early return to mobility, movement, wider mesh, less chance of recurrence. But what is the benefit of open surgery in this patient? If you don't say, then you by default we will plan every patient for laparoscopic surgery. Okay, last question. So let's say you have done an open surgery. What are the advices you will give to this patient at the time of discharge?
So to avoid heavy weight lifting, to avoid heavy weight lifting for at least 6 months, and I'll counsel the patient regarding pain, the chronic pain that he might have.
Your patient is also a chronic smoker.
To stop smoking. I'll counsel the patient to stop smoking.
Anything else?
It's only about avoid wet lifting and another thing she told. Quit smoking, nothing else. This is the routine advice we give when we discharge a patient following hernia. The question is open to any question from the house. They can ask questions. We are done.
Swelling in his scrotum, differences in the size of his testes, or orchitis.
At the time of discharge, you should anticipate what complications can occur from your surgeries. What are the complications that occur in immediate postoperative period? What are the complications can occur in a delayed phase during the postoperative period?
Immediate complications will be like hematoma or surgical site infection. And
what about the antibiotic prophylaxis in case of an open hernia surgery and in case of an laparoscopic hernia surgery in your patient?
so since it's a clean case, he doesn't require antibiotic prophylaxis.
Let's say
So
a patient.
one sort of antibiotic before giving incision would suffice.
Let's say the patient is a diabetic patient. Is the antibiotic prophylaxis remains same or it changes? You'll get a lot of patients having diabetes with her.
Change. So there can be mesh infection and mesh displacement.
Right.
Mesh contracture.
Okay. What is chronic inguinal pain following hernia surgery? What is the cause? How will you manage? 1 minute.
So the chronic inguinal pain is pain that occurs even after 3 months following surgery, which is due to the either entrapment of the ilioinguinal or hypogastric nerves into the mesh. And
Manage.
so first we will advise analgesics orally, NSAIDs, and we can go with the infiltration of local anesthesia in the areas that now.
45 minutes, then pain will appear with your local anesthesia. The nerve entrapment will not respond to.
If it is not responding, then we might have to go with neurectomy or mesh explantation.
Time is over.
On stage, we have our last contestant, Suvasurya Nayak from AIIMR.
Good afternoon, respected teachers and my dear colleagues. Myself, Dr. Bhubaneswar Nayak, PG second year from AIIMR and Capital Hospital, presenting a long case presentation on cervical lymphadenopathy. My patient name Mr. X, 56 year, Hindu male, farmer by occupation from Delang, Puri, presented with chief complaints of swelling in the left upper part of neck for last 6 months, weight loss for last 6 months. The patient was apparently well 6 months back. To start with, he noticed a swelling in the left upper part of the neck, which was insidious in onset. Initially, was of the size of a peanut, and there is progressive increase in size to attain the present size, and is not associated with pain or fever. He also complains of loss of appetite and weight loss for last 6 months. There is no history of alteration of voice, difficulty in breathing or swallowing. There is no history of chest pain, cough, or hemoptysis. There is no history of headache, loss of consciousness, vomiting, ear pain, and discharge from nose. There is no history of pain abdomen, abdominal distension, and yellowish discoloration of eyes and urine. Coming to past history, there is no history of similar type of illness in the past. There is no history of any surgery in the past. There is no history of any irradiation to neck in the past. There is no history of type 2 diabetic mellitus, hypertension, COPD, and tuberculosis. Coming to personal history, the patient is married and blessed with 2 children. He belongs to low socioeconomic status, consumes average mixed Indian diet. His bladder and bowel habits were normal, sleep is adequate. He was a smoker for last 15 years and smokes 5 to 8 BDs per day, and the patient is not addicted to alcohol. Coming to family history, there is no history of any type of similar illness in the family or fasting relative. None of the family members suffered from tuberculosis. The treatment history is nothing suggestive. Allergic history, there is no history of any allergy to food or drug. Coming to general survey, patient is examined in a well-lit room with prior informed consent. He is conscious, cooperative, and well-oriented to time, place, and person with Karnowski-Pochmann score of 90. His attitude, gait, and faces is normal. He is well-nourished and well-hydrated and moderately built. There is no pallor, icterus, cyanosis, clubbing, colonychia, or edema. There is presence of left upper cervical lymphadenopathy, no other lymph nodes elsewhere. Patient is afebrile, pulse rate was 78 per minute, no radial radiofemoral delay. Blood pressure was 122 upon 78 millimeter of mercury in right arm, upper arm supine position. Respiratory rate was 16 beats per minute. Coming to local examination on inspection, a swelling noted in the left upper part of the neck in the upper jugular area, 5 cm above the left clavicle. It is globular in shape, size approximately 4 into 4 cm, smooth surface with well-defined margin. Skin over the swelling appears to be normal. There is no engorged veins or visible pulsation over the swelling. There is no other swelling visible in the neck and supraclavicular region. As you can see in this picture, the swelling. On palpation, there is no local rise of temperature or tenderness over the swelling. A single palpable swelling on the left side of neck lying partly deep to the sternomastoid muscle at the level of upper border of thyroid cartilage, 4.5 cm above the clavicle. Size of 4 into 4 cm, globular shape, smooth surface, well-defined margin, and with hard consistency, fixed to left sternomastoid muscle and not fixed to overlying scale. There is no other swelling palpated in the neck. Bilateral carotid pulsations felt normally. Thyroid gland is not palpable. Trachea is central in position. On percussing, dull note heard over the swelling. On percussing over the manubrium stenoe, resonant note heard. On ausculting over the swelling, no bruit heard over the swelling. Coming to regional examination, examination of scalp, oral cavity, salivary glands, nasal cavity is within normal limits. Indirect laryngoscopy is within normal limits. Coming to systemic examination, respiratory system with normal vesicular breath sounds heard, no additional sounds present. Coming to gastrointestinal system, core abdomen is soft, non-tender, liver is not enlarged, spleen is not palpable, bilateral kidneys are neither ballotable nor bimanually palpable, no mass felt, no free fluid, no bowel sounds heard. Genitourinary system, external genitalia is normal, cardiovascular system, normal S1, S2 heard, no murmurs. Central nervous system, no focal neurological deficits present. Musculoskeletal system is within normal limits. Perianal inspection and DRE also is within normal limits. To summarize, a 56-year-old male presented with painless progressive swelling in the left upper jugular area of neck for last 6 months, associated with anorexia and weight loss for same duration. There is no history of fever, cough, chest pain, or hemoptysis, dyspnea, or dysphagia. On examination, there is a swelling in the left upper jugular area lying partly deep to the sternomastoid muscle at the level of upper border of thyroid cartilage. 4 into 4 cm size, smooth surface, well-defined margin, hard in consistency, fixed to sternomastoid and non-fixed to skin. No other swelling palpable in the locoregional area. Systemic examination is within normal limits. So my provisional diagnosis is left cervical lymphadenopathy, that is level 2, probably secondary to clinically unidentified malignancy with TN staging TX N3B.
Okay, so you think it is a metastatic lymphadenopathy to the left cervical area. So you mentioned it level 2. What do you mean by level 2?
It's upper jugular.
How do you define that area?
Sir, superiorly base of skull, inferiorly inferior part of hyoid bone, anteriorly anteriorly posteriorly, sir, posterior part of sternum.
So it is basically in between the, you say, the hyoid bone as well as the
Base of skull.
base of skull or angle of mandible. Okay. So why do you think this is a malignant lymphadenopathy? Why not a benign lymph node?
First, it is a elderly aged male with short duration of swelling. With swelling is hard in consistency. There is no pain over the swelling, and it is fixed to sternomastoid muscle.
Do you keep any other differential diagnosis apart from lymphadenopathy? It can be a primary malignancy of the neck. It may be arising from the muscles. So you will keep it. What are your differences? You say this is a provisional diagnosis. I want to know your differential diagnosis. What are other differential diagnoses?
It can be tuberculous lymphadenopathy, or it can be
No, but you think of your findings. You get it is a hard 4 into 4 centimeter mass which is fixed. Not overlying skin is free, non-tender, well-defined margin. So accordingly, you think of your differential diagnosis, not of any cervical lymphadenopathy. Tell.
It can be lymphoma, or it can be carotid body tumors.
Any other thing?
It can be adamantinum of mandibles.
Okay, so what is your what are the findings against the diagnosis of lymphoma in your patient? You mentioned it is a lympho. It can be a lymphoma.
So lymphoma, there is no in lymphoma swelling is discrete and rubbery in consistency with hepatomegaly and splenomegaly. There is no organomegaly present in this condition, and it is.
Can it be a sternomastoid tumor?
It cannot be, sir, because sternomastoid tumor there is no history of birth injury, or it is present in case of neonates. Its age is 56 years.
Because neck has a lot of tissues. You think of soft tissues. There are muscles, there are vessels, there are nerves. So malignancies can occur from all those structures.
Can be of schwannoma.
You think this is a schwannoma, but your diagnosis is a left. You think this is a malignant lymph node, malignant lymph node, secondary lymph node, and due to an unidentified malignancies. So, what are the areas you will look for malignancy in this area patient?
I will look for nasal cavity, then oral cavity.
So, we'll do a triple endoscopy.
Yeah, triple endoscopy with surveillance biopsy.
Okay. So, let's say in this patient, so you, what type of biopsy you will advise to this patient? It will be option is a FNAC, true cut biopsy, incisional biopsy, excisional biopsy.
I'll go for FNAC.
You will go for an FNAC. Why?
Because I'll know, sir, whether it is a squamous cell carcinoma or any adenocarcinoma.
So let's say it comes out to an squamous cell carcinoma. What are the areas you will look for?
I'll look for some nasal cavity, then oral cavity, then sir posterior part of the tongue. I'll look for piriform fossa, then I'll look for posteropharyngeal wall, then sir I'll look for supraglottic and subglottic larynx also.
Any other areas where a squamous cell malignancy can come? Okay, leave it. Those are adequate. If it comes out to be an adenocarcinoma?
Adenocarcinoma, sir, I'll look for parotid or thyroid, I can look for lower esophagus,
Lungs.
lungs and intra-abdomen.
Can you classify this lymph node as a so-called Virchow's node? Virchow's node.
Virchow's nodes are left supraclavicular. It is in the posterior triangle.
So this is not a typical Virchow's node. So what is the location of a Virchow's node?
Sir, it is present in the subclavian triangle, with the superior border being the inferior omohyoid muscle, lower border is clavicle. It is between the supraomohyoid and clavicles.
Okay, so in between, usually we palpate in between the two heads of the sternomastoid. Now, what is the role of imaging in this patient? You will do a triple endoscopy accepted. Is there any role of endoscopy imaging in this patient?
Yes, sir. If in triple endoscopy, I may not find any primary loop sites, but I can go for USG abdomen pelvis and CCT neck, thorax or CCT abdomen pelvis. If PET CT is available, I'll go for PET CT.
So, will you advise an ultrasound of the neck, or straight away you will go for a CT of the neck?
No, I'll advise ultrasound of the neck, sir.
Why?
Because I want to, sir, after my clinical examination, I want to know the lymph node shape, margin. I want to confirm it by investigation.
So ultrasound give you a lot of information. So sometimes there is a condition called lateral aberrant thyroid. You have to want to evaluate the thyroid also. You want to have the characteristics of this lump, presence of other lumps, which may be lymph nodes or other lymph nodes are present or not. So whether it is compressing on vital structure, left sided, we have esophagus there. Whether there is any compression or nearer to the esophagus. So all those things will give, ultrasound will give an idea about it. So that is the primary or initial screening imaging. So, depending on the biopsy, subsequently you go for an imaging study in this patient. Okay. So what are the common visceral malignancies that can give rise to left lymphadenopathy?
It may be CS stomach, carcinoma, sir. It may be a malignancy from the ovary, sir, or it may be malignancy from testes, sir, or bilateral kidney also. Maybe GI malignancy can give rise to left supraclavicular lesion.
Okay, so let's say you get an FNSC says there is presence of an adenocarcinoma, and you get an primary lesion in the stomach, let's say. So next, what will be your plan of management in this patient?
So first I will treat the primary tumor first.
How?
If it involves stomach, then I will go for imaging method first. By imaging, I will know where the primary tumor is.
So your let's say primary is in stomach. Now what will be your management?
I will go for endoscopic biopsy, sir. First, know the
It is confirmed. You get an endoscopic biopsy. It is confirmed that you are dealing with a stomach adenocarcinoma.
my treatment, my operative treatment of stomach will depend upon where it is located. Whether it is present in proximal stomach or
First and foremost, with a metastatic lymph node, do you want to operate on this patient?
if it is primary in
So you have a lymph node here. It suggests adenocarcinoma, and during investigation, you found to be there is a mass lesion in the, let's say, distal stomach, which on endoscopic biopsy comes out to be an adenocarcinoma. Now, do you want to operate on this patient?
it is sir M1 disease, M1 disease, I'll go for the radiation neoadjuvant chemotherapy.
No, what you will plan? All these things are available. Yes, you have surgery, you have radiation, what will be your neoadjuvant chemotherapy? What should be your plan or sequence of management?
I'll go for sir neoadjuvant chemotherapy along with radiation.
Radiation to?
Radiation to the both stomach area and neck.
So you give radiation to both stomach and neck. Following a neoadjuvant chemotherapy. So what neoadjuvant chemotherapy usually given in such patients?
Sir, cyclophosphamide, anti-radiation and pegfluoridation.
For stomach. So, are you aware of something called a magic protocol in gastric malignancy?
Not force.
What is magic protocol? Okay, issues. So let's say you get a patient in this left cervical lymphadenopathy, you get a nasopharyngeal carcinoma. What will be your plan of action?
Nasopharyngeal carcinomas, I'll go for the incision of the nasopharyngeal carcinoma along with the neck dissection.
So what are the different types of neck dissections?
Sir, radical neck dissection, modified radical neck dissection, selective neck dissection, and extended neck dissection.
So what are the different types of modified radical neck dissection?
There is type 1, type 2, type 3. In type 1, we preserve the spinal accessory nerve. In type 2, we preserve the spinal accessory nerve along with the internal tubular vein. In type 3, we preserve all three structures, spinal accessory nerve, internal tubular vein, and sternum
So
muscle.
what are the major complications of modified radical neck dissection?
Sir, measures are there is maybe flap necrosis, there may be vascular and nerve injury. Nerve means hypoglossal nerve, spinal accessory nerve, lingual nerve, or any vascular injury, sir.
What is the role of PET scan in this patient?
It can look for sir primary in other parts of the body, sir, whole body, sir. Only finding the primary, sir.
Means you initially in this patient you will do a triple endoscopy. If triple endoscopy is negative, then you will go for a PET scan or you will go to a CT of the abdomen, pelvis.
Sir, if PET CT is available in tertiary health center, then I'll go for PET CT directly. If it is not available, then I'll go CCT or CCT, sir. CCT neck, thorax.
If it is no primary detected, then what you will do?
If primary not detected, I will go for sir modified radical neck dissection type 2 along with bilateral tonsillectomy.
Any question from audience?
You are giving chemotherapy to be done or some other term you use? When you are giving a chemotherapy, it is already M1.
Yes, sir.
In M1, is there any term of neoadjuvant chemotherapy?
Radiation.
That's all.
And it with tuberculosis.
Yes, sir, it can be, but
Tuberculosis of cervical lymph node. What are the stages?
the stage, sir, first is there is only lymph node. Stage 1 is there is only lymph node enlargement. Stage 2 is there is periadenitis. It will cause matting. Then it will cause caseous necrosis. Stage 3 is caseous necrosis following cold abscess and following cholesterol abscess.
How you differentiate a solitary enlarged node like this one, 4 into 4, from a matted group of lymph node clinically?
Clinically, sir, if it is matted lymph node due to tuberculosis, then sir, consistency will be relatively firm. Otherwise, it is very hard. It is hard, sir. And it is, sir, there is no also constitutional symptoms of tuberculosis, sir. Fever, evening rise of temperature.
How will you manage tubercular lymph nodes?
Sir, I go
This
for
side.
antitubercular.
What are the indications for surgery in tuberculosis?
If ulcer is not healing.
Also, sinus,
Sinus, sinus.
multiple sinus. Okay.
No more question. Okay, thank you.
We're delighted to be a part of such dynamic discussions. Thank you, sir, for your valuable presence. Next, we'll be beginning with the PG thesis presentation. Research is seeing what everybody else has seen, but thinking what none has thought. The initial step of which begins with the thesis. Next on the stage will be our participants presenting PG thesis topics. I bid my warm welcome to the judges of our forthcoming session, Dr. Sushil Kumar Patnaik, Professor and HOD of Surgery, PGIMR and Capital Hospital, Bhubaneswar; Dr. Chittaranjan Sarangi, Professor and HOD of General Surgery, Dreams Institute of Medical and Sciences, Tangi, Cuttack; Dr. Shrikant Panda, Professor of Surgery, SGMCH, Puri. The first presentation will be by Dr. Sumit Ranjan Samil from SEB-MCH on a prospective observational study on optimizing management of sickle cell disease in patients undergoing elective surgery and determination of risk factors in patients developing complications.
Respected chairpersons, good afternoon all. Myself Dr. Sumit Ranjan Samal from SCB and all the greetings from SCB. My topic for thesis titled A Prospective Observational Study on Optimizing Management of Sickle Cell Disease in Patients Undergoing Elective Surgery and Determination of Risk Factors in Patients Developing Complications. In this topic to start with, I will tell the overview of the topic. It is introduction, aims and objectives, methods and methods, procedure and analysis, results, discussion and conclusion. Start with the topic proper. I would like to quote a famous quote which describes the agony of the sickle cell disease patient given by Larissa Rohani. Hell is living with chronic blood disease, sickle cell. One moment life is beautiful and all is well. Then excruciating pain renders you confused, helpless and unable. It's my reality and it's hard self, but nevertheless a reality on which I can't dwell. Sickle cell disease is the most common inherited disorder of the hemoglobin and it is a monogenic disorder. It is caused by the single nucleotide substitution of position 6 of beta globin leading to polymerization of resultant sickle cell variant, that is HBS variant. It is an autosomal recessive condition characterized by heterogeneity of clinical manifestations of sickle cell. Individuals with sickle cell are likely to refer for surgery due to high incidence of musculoskeletal such as avascular necrosis and intraabdominal complications during gallbladder necrosis. So perioperative risk optimization is a multidisciplinary approach involving surgeon, hematologist, anesthetist. Risk classification of the surgery, disease severity, medications, and baseline hemoglobin transfusion history of prior surgical complication are often documented. Perioperative risk assessment that includes determining the patient's functional status and cardiovascular risk. The preoperative transfusion requirements are also necessary. In the intraoperative and postoperative period, dehydration, hypotension, hypothermia, hypoxia, acidosis should be taken into consideration to prevent complications such as acute chest syndrome, sequestration, and vasoconstriction crisis. My aims and objectives are to study the perioperative risk stratification of sickle cell disease patients undergoing elective surgery, to study the intraoperative management of sickle cell and compare the outcomes of patients receiving preoperative blood transfusion in the postoperative period, to determine the postoperative complication in terms of vasoconstriction crisis, acute chest syndrome, and sickle cell hepatopathy. It is a prospective observational study done in Department of General Surgery from September 2022 to September 2024. My sample size is 50. Patients with known case of sickle cell disease undergoing elective surgery are included in the study. The patient selection inclusion criteria are men and women of any age group, patients scheduled for elective surgery, patients with known case of sickle cell, both heterozygous or homozygous, patients willing to participate in the study with written informed consent. Pregnancy, lactation, emergency surgery, and sickle cell with any other associated hematological disorder like thalassemia are excluded from the study. It is passed in the IEC of dated 8th of May 2023, had number 1368. There is no conflict. This is the data analysis. Patient assess for eligibility. Then the risk is stratified according to high risk, low risk, and medium risk. Then perioperative monitoring in terms of hydration, sepsis control, temperature monitoring, FDG analysis, oxygenation, and urine output. The mode of surgery, that is lab or open, and the type of anesthesia are also taken into account. Then in the post-operative monitoring, we monitor the urine output, operation time, urine output, pulse rate, saturation, temperature, FDG analysis, and outcomes were documented. Observation. Then there is 80% patients are trade, which 40 patients are trade, which accounts for 80%. In hemoglobin S level less than 66, that is 74 percentage, and hemoglobin level is less than 9 in 88% of patient, and more degree of oxygen saturation is more than 94 in 94% of patient. Preoperative analysis, FDG analysis normally 94 percentage, and preoperative BT is given in 4 patients, that accounts for 8%. Then there is a type of study. There is type of surgery. When cholecystectomy, 41 patients underwent cholecystectomy, appendectomy 3 patients, MRM 2 patients, hernioplasty 3, splenectomy 1. Mode of surgery is lab 42%, 42 patients, well 6, conversion 2. Operative time less than 2 hours in 44 patients, and all the patients underwent surgery in general anesthesia. Preoperative oxygen requirement is needed in 45 patients, that accounts 90%. Vaso-occlusive crisis developed in 4 patients, that accounts for 8%. Acute chest syndrome developed in 12%. That hemolytic crisis accounts for 6%. Sickle cell hepatopathy, 2 patients developed sickle cell hepatopathy, that accounts for 4%. And mortality were overall 4%. This is the HPLC value. In the HPLC value, more than 66%, 11% out of 30 developed complications. And when the preoperative oxygenation was less than 94, all the 3 patients were developed complications. If 4 patients received blood transfusion preoperatively, 3% developed complications. When the operative time was lengthened, 5 out of 6 patients developed complications. This is the risk factor determining mortality. When the HPLC is 75, hemoglobin was 6.8, the preoperative blood transfusion was given. The patient was, the type of surgery was splenectomy, open approach. Operative time was more than 2 hours. In that patient, acute chest syndrome, hemolysis, sickle cell hepatopathy was developed, which accounts for the mortality. And in second patient, when the HPLC level was 67, hemoglobin, preoperative hemoglobin 6.2, the difficult cholecystitis was encountered, in which lab is converted to open, and the operative time was 120 minutes, that is 2 hours. All the vaso-occlusive crisis, acute chest syndrome, and hemolysis were developed, that accounts for mortality. Discussion: 11 patients out of 13, that is 84.6%, who had HPLC level more than 66% developed complication, as compared to 2 out of 37. All patients receiving preoperative saturation less than 94% on developed complication, compared to 4.2% having preoperative saturation more than 94. 3 of 4 patients, that is 75%, who received preoperative for major surgery developed complication. 5 out of 6 patients requiring operative time more than 2 hours developed complication like acute crisis. To conclusion, preoperative optimization is necessary to prevent complications, determine the need of surgical practice, determine whether all the conservative measures have failed, maximum try for use of minimally invasive surgeries, avoid unnecessary blood transfusions, extended cross-matching to be done in patients requiring blood transfusions. Proper intraoperative monitoring and post-operative monitoring helps to mitigate the sickle cell crisis. Thank you.
Hello, thank you. First of all, you have told the title as a prospective observational study. Yes. What type of observational study?
It this is prospective observational study in terms of not a cohort study, it's a case control.
No, observational study. What are the types?
It's case control trial or cohort. Isn't it?
No. Are you taking any comparison?
Comparison, no, sir. Or with
That means it is purely descriptive. No case control, no cohort, no cross-sectional. You can tell cross-sectional solve there, but cross-sectional study it is not. So the study design must be properly done before starting your research. Right?
this particular observational study between one patient categorizing less than 66% is
Observational, again, observational may be of many types. So observational, descriptive, human to tell. Right? What about the IEC approval?
I says approved by sir in the international.
No, you have not mentioned.
Is mentioned. Institutional Ethical Committee via IC number.
I will give in that report of IEC approval.
That report is
Actually, you should base it. Whether it is your thesis or any other thesis, how can we know? Right? Then you have told HPLC more than 66%. How could you get that point of 66%? Have you gone for ROC for?
Sir, it is done by the transmission management this HPLC level high input chromatic level thing when HPLC level yes cell level in this patient more is complex. Sir, that is done.
Thank you.
Next one, Sindhuja Chakravarti.
Now we have Dr. Sindhuja Chakravarti from MKCG MCH presenting on laparoscopic inguinal hernia repair in children using intracorporeal sutures, a prospective study.
Good afternoon, respected judges and one and all present here. Today I am going to present my thesis, laparoscopic inguinal hernia repair in children using intracorporeal sutures, a prospective study. The incidence of inguinal hernia in children is between 0.8 to 4.4%. It is more common in male. Laparoscopic inguinal hernia repair has evolved since its inception in 1990s. The clear advantages are the short operative time for bilateral inguinal hernia repair and exploration and repair of contralateral hernia in the same sitting. The post-operative complication is found to be less. Intracorporeal suturing technique means the manipulation of the suture intra-abdominally, facilitating a precise and secure closure of the defect using purse string suture. The precision of the intracorporeal suturing allows for more robust repair, which prevents the recurrence. This process has many benefits, but this is technically challenging. The rationale of this study is to evaluate the effectiveness and safety of the laparoscopic inguinal hernia repair intracorporeally with excision of the sac and purse string closure of the internal ring in pediatric age group. The aim is to evaluate the clinical profile and outcome of this procedure. The objective is to examine the demography, the hernia characteristics and operative duration, intraoperative, post-operative complication, recurrence rate, to assess the duration of hospital stay and return to normal activities. Inclusion criteria: patient between 1 to 14 years of age, diagnosed clinically or by ultrasound to have uncomplicated inguinal hernia. Both male and female patients were included. Informed consent was taken from the guardians of the participants. Exclusion criteria: babies younger than 1 year of age, history of any previous surgery, undescended testis, unsuitability for surgery due to any medical or any other comorbidities, and refusal to participate. It is a prospective study of sample size 40 done in the Department of General Surgery along with the Department of Pediatric Surgery for a duration of 24 months, including a 6-month follow-up. Adequate pre-operative assessment was done and all cases done under general anesthesia. This is the operative surgical position of surgical team with the operating surgeon at the head end of the patient while the monitor at the foot end. This is the port position, one camera port 5 mm, two working port 3 mm, maintained at proper triangulation. Patient is kept at Trendelenburg position with side of hernia slightly raised. 5 mm camera port was inserted at umbilicus. Pneumoperitoneum created at a flow rate of 1 to 2 liter per minute. Peritoneal lining of the internal ring was marked with diathermy and incise. Cord structure identified and dissected with minimal handling. Sac was dissected and excised. Peritoneum was closed using purse string sutures, 30 round body polypropylene. Final inspection done. Ports were removed. Port closure was done. Patient was given post-operative analgesics and orally allowed 4 to 5 hours later. Regular follow-up was done. This is the purse string closure of the internal ring. The second picture shows the bilateral closure. This is a short video. The camera port is inserted. These are the two working ports. The side of the hernia identified. The peritoneum around the internal ring is scored with the diathermy. Small nick is given and carefully dissection is done. The sac is identified. It is dissected from the cord structure. The extra sac is excised. Now we are taking a purse string suture using a 30 round body polypropylene. The knot is tied. Internal ring is closed. This is the immediate post-operative photograph and this is the photograph on follow-up. Results, most of the population was male, 62.5%. Birth order, most of them were found to be first born, that is 25 out of 40. Term babies were 31 in number. Most of the hernias were left-sided, that is 42.5%. Our typical intraoperative finding was seen in only one case. Time duration for unilateral surgery was 39 minutes, bilateral surgery was 55 minutes. Post-operative complications, seroma was noted in 3 cases. Wound infection, hematoma, recurrence and chronic pain was not noted. Mean duration of hospital stay was 2.27 days and the duration to return to normal activity is found to be 6.7 days. Discussion. According to the demographic characteristics, it was more common in the male as compared to the female. This also is supported by other studies like the Chen YH et al. Study also states that it is more common in boys. The mean age of presentation is 6.35 years. Mean duration of presentation is 4.2 months. Most common in the firstborn, 62.5%. The gestational age distribution, 77.5% was found in term, but the data differs from the other data available, which highlights that it is more common in the preterm population. Left-sided hernia is common, which is in accordance to the data which we have. Our typical intraoperative finding was seen in one case where there was a cecum was the posterior wall. The duration of this surgery was 90 minutes, while the duration of bilateral surgery was 55 minutes average and 39 minutes for unilateral surgery. Chinnaswamy et al. A study with which we compared, that is 21 to 35 minutes for unilateral and 28 to 50 minutes for bilateral. Post-operative outcome was highly favorable. Seroma was only noted in 7.5% cases. Post-operative recurrence in other studies was around 4.1, which is higher as compared to our study. Duration of hospital stay in our case was 2.27 days. Average duration to return to normal activity is 6.7 days. This is in contrast to the studies available, which denotes that hernia is a daycare surgery. In our setting, despite adequate counseling, patient attendant insisted on a longer hospital stay. Limitations. It is a relative small sample size. Children less than 1 year are excluded. Children with comorbidities are excluded and follow-up period is only for 6 months. Purse string closure is laparoscopically technically challenging. Conclusion, it is an excellent, effective and safe in pediatric population. The absence of recurrence and post-operative complications are there. We need larger studies to confirm the cases, but this can be adopted in pediatric surgical practice. These are my references. This is the acceptance letter for the annals of minimal surgery, which the thesis article is accepted as an original article. Thank you.
Okay, nicely described. But you have told that you could have removed the sac or excised the sac.
Yes.
Could you be able to excise the whole sac in congenital?
We will not be able to excise the whole sac. We will dissect only 2 centimeter and then excise the 2 centimeter only a part of it.
Have you dealt with the remaining sac? Remaining portion of the sac?
Sir, we will keep it as it is.
Yes.
And we will close the internal.
With maintenance of hemostasis.
Yes, sir.
From the beginning, I beg excuse. I am not expert in laparoscopic surgery, that to hernia, pediatric age group. We know up to this age group, probably the treatment of hernia is only herniotomy. So what is the rationality of bursting suture laparoscopically? This is for my knowledge sake. I don't ask her to give mark here. What is the rationality of herniotomy over? Then why a bursting suture?
Sir, we are closing the internal ring, we are closing the peritoneum so that there is no recurrence. There is no chance of any recurrence later.
That should have been done also open surgery.
Yes.
So why extra suture is given in only simple herniotomy, the treatment for pediatric age group hernia? We have been taught. Yes. And this is for my knowledge sake.
It is a common perception that what you are telling absolutely right. In open surgery and herniotomy is only done, and laparoscopy what different he is doing. There is the same thing, na? Same thing. You just put a close the neck. That's it, and that is bad. You are doing it from outside. It is done from inside. That's it. Absolutely.
This happen only at the neck, open surgery.
You are also closing.
No, why bursting suture?
That posting is same. You are ligating. Is the posting? It's not same. It's something different. Absolutely.
Thank you.
The next presentation is by Dr. Lalit Mohan Dandi from Windsor on association between serum estradiol levels and men with groin hernia.
Myself, I am Dr. Lalit Mohan Dandi from Windsor, presenting on my research paper of association between the serum estradiol levels and men with groin hernia. As we all know, groin hernia are common surgical condition in males, which the indirect hernia consists more than 95%. The inguinal hernia consists of 95% and the femoral 5% with female predominance. And traditionally, we say that hernia is more attributed for the mechanical stress, anatomical vulnerabilities, and genetic factors. However, we will be here discussing about the hormonal factors, particularly estradiol levels, and how it will play in the development and management. So the probable mechanism discussed in the thesis is the hormone, but the androgen, estrogen, and progesterone, they do by type 1 collagen degradation, type 3 collagen alteration, MFPs and TIMPs imbalance, and altered collagen synthesis. All this will lead to the decreased tensile strength as well as weakening of the abdominal wall, which will further lead to the increase in hernia risk. Now coming to estrogen specific, what it does, it stimulates the lower, particularly the lower abdominal muscle fibroblast via estrogen receptor alpha, which then promotes fibrosis and myocyte replacement and collagen deposition, leading to muscle atrophy, further weakening the abdominal wall and increased hernia risk. My aim is to link this association between estradiol and groin hernia. My objective is to link serum estradiol level and the occurrence of male groin hernia, specific emphasis on the interplay of BMI on this association. Now, the study is a case control study done in the Department of Windsor with a sample size of 100 with cases 35 and control 65. The blood sample with due consent of the patient was sent along with the routine investigation, promptly transferred to the lab for immediate processing and preserve the sample integrity and the reliability of the results. I took the basic information, collected the basic information of the data from the patient, like the demographic data, including the age, the BMI of the patient, any comorbidities, serum estradiol level, and the AHS classification of groin hernia. Then the criteria which I took for cases and controls were the male patient aged more than 18 years with a confirmed groin hernia on intraoperative finding, patient with BMI less than 40 kg per meter square, and informed consent obtained prior to the participation. And for the controls, it was the age, aged more than 18 years and undergoing elective surgery unrelated to hernia repair with no clinical evidence of groin hernia, with a BMI less than 40 kg per meter square and informed consent obtained prior to the participation. The exclusion criteria for both the cases and controls are like uses of hormonal or steroid therapy within last 3 months with recent aromatase inhibitors, known diabetic or patient unable to provide informed consent due to cognitive or language barrier. Now this table analysis compares the basic demographic data between the cases and the controls, which shows there is no statistical difference between the mean age, whereas there were found to be higher mean BMI and mean estradiol levels. Now, by doing the unpaired T test for the BMI and the Mann-Whitney U test for the estradiol level, we found a significant difference. And we can see that the mean BMI was 2.27 kg per meter square, and for the control it was 22.84 with a p-value of 0.046, which was significant. And similarly for estradiol level, it came as the p-value to be 0.001, which was found to be significant. This table analyzed the estradiol levels and hernia association with a p-value of chi-square test was done and p-value came out to be 0.004, which suggests that estradiol level more than 50 picogram, the patient presence are prevalent of the patient with cases are more. This shows how BMI is attributing to the hernia risk, like the obesity was found to be more prevalent in cases, that is 28.5%, as compared to the control, that is 7.6%. Then I finally did the logistic regression test to quantify the risk associated with it, and I found out that the person having more than 50 picogram per ml of serum estradiol level were found to be at a risk of 4.2 times higher than the value normal, lower value. Now, bringing it all together, this study explored the hormonal diversion of groin hernia, specific emphasizing on estradiol, how it is weakening of connective tissue which may predispose man to groin hernia. There are some key findings here, like estradiol levels in male patient with groin hernia demonstrate significantly higher estradiol level, and we can use this stark difference as estradiol as an influential factor in connective tissue degradation and increased hernia susceptibility. We also enhanced our study by BMI as an interacting factor because the data suggested that elevated BMI may amplify the effect of estradiol on connective tissue, creating a compounded risk. We also quantified the risk impact, suggesting more than 50 picogram as 4.2 times higher risk. And like there have been several studies done before, let's see where our study aligns and where we have got new insights. So our study aligns, apart from Smith et al., our study aligns with the prior researches indicating a correlation between estradiol and hernia risk. But our study expands earlier work by integrating the role of BMI and how estradiol and metabolic factors, the dual role, interact to influence hernia risk and position of estradiol and BMI as interconnected contributors. So, what could be the possible complication or future reaction? Can estradiol be used as a novel biomarker? I think it can be explored as a biomarker or a risk assessment toolkit for hernia, particularly in high risk group, such as older males with high BMI. And by targeting the hormonal pathways and utilizing its potential for hormone modulation, we can mitigate the hernia risk. So, like every good research has its own intriguing limitations, and mine is no exception. So, my limitation of the study will be the lesser sample size, which is of limited population with a single institution. The temporal limitations of the study design being, I have just found out the association, but the positive relation has not yet been done here. So further studies could capture how estradiol levels fluctuate over time in individual at risk, helping to clarify whether hormonal shifts precede or follow hernia formation. The complexity of compounding variables like genetic and lifestyle factors, how they affect. And for the long-term insights, like tracking the estradiol levels, post-surgery may reveal links to hernia recurrence or surgical outcomes, aiding to the preventive strategies. These are my references. Thank you.
Thank you. In this study, You have taken 35 cases and 65 controls.
Yes.
Will there be selection bias?
Sir, because of the higher prevalences of the Thanya,
What is selection bias?
so selection bias is I will be particularly targeting a population for the study which I am doing. I will be just selecting the more population who are more likely. The higher this population I will be targeting, then it will be.
When you are taking comparisons, the comparison should also be not statistically different. It should be almost equal, right? So, in your case control study, you have not mentioned anything about odds ratio.
Yes, I have mentioned about the augmented odds ratio. You suggested 4.2 times how more than 50 people per ml is causing the 4.2 times higher.
Now, odds ratio, have you calculated? No.
Any question from the floor? Thank you.
Next, let's see the role of fundus first laparoscopic technique in difficult laparoscopic cholecystectomy, presented by Dr. Gaurav Bhupati by AIIMS.
A very good afternoon to my respected judges. I am Dr. Gaurav, presenting my thesis on comparison of the fundus first versus standard laparoscopic technique in difficult laparoscopic cholecystectomy. Difficult surgeries are always a challenge that a surgeon rises up to. A difficult laparoscopic cholecystectomy aims to address the heart of the procedure, which is the Kellogg's triangle, with bailout methods to prevent intraoperative and postoperative complications. The aim of our study is to complete difficult laparoscopic cholecystectomy with the use of both the fundus first approach and the standard approach, and to compare intraoperative factors, the safe outcome of surgery, and prevent postoperative complications despite the difficulty. For this, we undertook a prospective comparative study over a period of 2 years in the Department of General Surgery of KIMS with 200 patients with due ethical approval and consent. Adult patients undergoing elective laparoscopic cholecystectomy declared difficult on table were divided into two groups based on the operating surgeon's preference. The two groups were the fundus first group and the standard group. The patients who were unsuitable for laparoscopy due to their severe comorbid conditions, such as an altered body habitus, BMI greater than or equal to 25, ASA grade 3 or higher, uncontrolled coagulopathy, myeloproliferative and other hematologic diseases, and those with benign conditions apart from the gallstones opting for simultaneous surgery were excluded from my study. After this, the patient's detailed clinical profile, intraoperative findings, operative outcomes, and postoperative complications were noted, and the patients were called for a follow-up 6 weeks post-surgery. Tokyo Guidelines 2018 classifies intraoperative findings into 5 major groups. Each of these groups have individual scores assigned based on the difficulty, based on surgeon experiences. The higher scores mean more difficulty. So in group 1, these were cases managed by the fundus first technique, and an elective partial or B-type modification of the fundus first technique was required in about 12% of our cases, and group 2 were those managed with the standard approach from the Kellogg's triangle. This is an intraoperative image with the yellow area highlighting a score of 3 around the Kellogg's triangle area. In this case, a division of the gallbladder was done at the neck in case of the frozen Kellogg's triangle. This is an image showing another case with elective opening of the gallbladder neck in case of a chitinous posterior wall. In this case, we undertook a B-type modification of the reconstitutive procedure. And after the reconstitution in that case, an extracorporeal knot was placed. A statistical analysis which was done by SPSS version 21 showed results in mean plus standard deviation and categorical variables given in frequencies, analyzed by the student t-test and the chi-square test, and a p-value of less than 0.05 was applied for level of significance. Coming to the results, demographically, the mean age was noted to be around 45 to 49 years of age, and female preponderance was noted. In the intraoperative findings, in the inflammatory categories of the scores, there are higher scores in the fundus first group as compared to the standard group, whereas in the non-inflammatory intraoperative findings, similar findings were noted in both groups, with scores of 2 and 3 being prominent in the non-inflammatory category. Coming to the intraoperative findings, similar findings was noted in terms of intraoperative bleeding in both groups. Bile duct injury was absent in both groups, and bile leak was noted intraoperatively in 22% of standard cases as compared to no bile leak in the fundus first group. The mean operative time was about 91 minutes in the fundus first group and 143 minutes in the standard group. The operative outcome shows a vast difference, with completion being possible in around 88% of fundus first cases, with 12% requiring a partial B-type modification, with only 51% undergoing completion in the standard group as compared to a 49% subtotal resection. Post-operative bleeding and post-operative bile leak was not noted in both groups, and both groups were equally good on follow-up. So coming to the discussion, why did I choose this topic? Strasbourg in 2012 reported 8 cases in which fundus first technique showed extreme vasculobiliary injury. This required hepatectomy in 4 cases, and 1 case required a liver transplant and resulted in 4 deaths. Our study aims to highlight that fundus first technique can be undertaken with minimal vasculobiliary injury, which was absent in all cases of our fundus first group. We adhered to a Delphi consensus, which was recommended in the Tokyo guidelines, which states that on staying close to the inflamed gallbladder wall, injury can be minimized. Minimal bleeding was encountered in 23% of our cases intraoperatively, which was dealt with intraoperatively, leading to no postoperative bleeding. A study done by Adriana Toro in 2021 describes 4 types of subtotal resection in cholecystectomy. This study recommends the C-type modification, in which both the anterior and the posterior wall are taken away from the liver bed and the stump is closed. In our cases, however, the fundus first approach allowed D-type modification of the subtotal procedure in about 12% of the cases. Nassar came up with a scoring system for assessing intraoperative difficulty, of which he also describes in his study the conversion of laparoscopy to open surgery. However, in our study, none of the operating surgeons preferred to go for the open conversion. Another study that I would like to quote is the Swedish study, which takes into account 163,500 patients between the periods of 2006 to 2020. This study and our study found the similar results, that shorter operative time is the hallmark of the fundus first approach. Higher rates of completion is there as compared to the standard dissecting technique, and there is no vasculobiliary injury. So in conclusion, I would like to say the fundus first method should be adopted as a primary bailout strategy in difficult laparoscopic cholecystectomy, because it is able to deal with more complex situations, that is higher intraoperative scores, reduced complications, and lesser operative time. Thank you.
When was the study?
So the study was conducted between June 2022 and May 2024. Sir.
So recent.
Recent study.
But why did you use the statistical software SPSS 21?
Sir, SPSS 21 was the latest available.
Latest is 29.
We are using the 21 version. So they told me that was the latest.
Is it your thesis?
Yes, sir.
So the statistical analysis actually is not sufficient. Maybe the cause I don't know. The analysis is not sufficient. The interpretation, the discussion, the conclusion may be correct, but analysis is not correct. Should have used the statistical analysis as per the SPSS recent version, as well as the what is required in case control study.
Sir, I have to, in a case control study, mine was a prospective observation study, sir. In a case control study, I should have taken an odds ratio. But since mine was only a prospective observation study, I did not take an odds ratio.
Again, the fundamentally we are lacking the prospective observational study. What is observational study?
Sir,
If you are taking a comparative group
I am
or
taking
not,
two comparative groups, sir.
then what are the different types of comparative study?
Sir,
Comparative analytical study,
Case control studies,
observational,
cohort studies,
yes.
cross-sectional studies.
Hmm. What is the type in your case?
So mine is cohort based. It's actually case control. Based on the data that I have, it is case control. Because I have taken two groups. One group in which I have done the fundus first, and one group with the
Study design must be proper before starting of research. Thank you.
Next, we have Dr. Sagar Nayak from IMS, some hospital. Study of etiopathogenesis, modalities of management and prognostic outcome in patients with intracutaneous fistula.
Good afternoon, everyone. I am Dr. Saganek, presenting a case of etiopathogenesis, modality of management, and prognostic outcome in patient with enterocutaneous fistulas. An enterocutaneous fistula is fistulous tract between bowel lumen and the abdominal wall, and causing content of the lumen to spill out through the tract. Enterocutaneous fistula through the are rare and associated with higher morbidity and mortalities. My aim of study is to etiopathogenesis of fistula, modality of management in post-operative enterocutaneous fistula patients, and to find out how to prevent the mortality and morbidity related to enterocutaneous fistula death. Materials and method. The research was conducted as a prospective observational study in Department of General Surgery, AIIMS, and some hospital, Bhubaneswar. All cases of enterocutaneous fistula were AIIMS some hospital during the case of during May 2022 to May 2024. Were followed up from the day of recognition of the fistula until the date of the discharge. My inclusion criteria will be all the patient aged more than 14 years of age with active fistula were included, and age less than 14 not giving consent, healed fistulas, operated fistulas, and patient lost to follow up not are excluded in the criteria. Tools. The study uses array of different diagnostic tools like ultrasound, CT scan, and diagnostic peritoneal lavage. In all patients presented with EC fissulas. These tools aid to determine the presence and extent of the site of fissula. Surgical intervention. Surgical intervention required were documented and categorized based on the site of fissula and surgical technique employed. So the result will be most of the patient are between 30 to 40 years age group of male. About the operative procedure patient underwent appendicectomy, bowel resection, exploratory laparotomy, and primary closure of bowel. Out of that, bowel resection anastomosis was the majority of the cases for the 21 patients in both male and female patients. There is a distribution of pathology whom underwent bowel resection anastomosis, out of which mesenteric ischemia is the most common cause, followed by ileocecal tuberculosis and carcinoma colon. The exact cause of the mechanism will be most of the patients are presented with anastomotic leak in both male and female, where the inadvertent nephrectomy during adhesiolysis, leak of primary repair, and the post-appendicectomy are the rest of the cases. Regarding the site of the fistula formations, most ileum followed by the colon and are the most common site of fistula, which consists mostly 69% of the cases. Rest, the jejunum and the cecum will be the case. We have found only one patient with gastric fistula. Outcome of the fistula mostly depend on what are the outcomes, like conservative management, surgical management, and still persistent fistulas. So out of this, 19 patients were corrected by surgical management, 17% were managed by conservative management, and 9 patients, despite both the management, still persisted the fistulas. And out of this, emergency surgery was 93% of the cases. Statistical spontaneous closure, minimum 9 days takes to close the fistula spontaneously, or it takes about maximum 36 days, and time for surgery is minimum 12 days, maximum is 49 days. So regarding the TPN utilization, we have 8 patients has only received a TPN, 25 patients received both TPN and enteral nutrition, and only enteral nutrition will be given into 11 patients. And one patient which was gastric fistula succumbed to that, so didn't receive any type of nutrition. Total parenteral nutrition is only minimum day to start is 4, maximum 25 days. During his hospital stay, minimum 3 days hospital stay and maximum 65 days, which is only in case of surgical corrections. So fistula will be classified according to site, like content of the fistula, like low, moderate, and high. So we have maximum patient of high output fistula, which is 18, followed by moderate and followed by low output fistula. In association of fistula with comorbid condition, we have only found significant association with the tuberculosis, which has a positive p-value of 0.001, which signifies the positive correlation and suggestive of the significant comorbidity. There are the classification of fistula, and according to the other defect which or complication related to fistulas, sepsis is the most common, found in almost 100% of high and low output fistulas, followed by weight loss, followed by hyponatremia. And we have sepsis, hyponatremia, skin excoriation, and large defect, and renal failure has a positive correlation with a p-value less than 0.05. Most cases of fistula due to the anastomotic leak, followed by inadvertent enterotomy, leak from the pine repair, or post-appendicectomy, and major of the cases, which 93% were done in the emergency setting due to either mostly because of mesenteric ischemia or acute intestinal obstruction or hollow vessel perforation and gangrenous appendicitis. And emergency surgery usually has an increased risk of fistula formation. AIIMS was the most common site for which almost always due to anastomotic leak. Hypoalbuminemia has a positive p-value of 0.08. It indicates the vital importance in the albumin level. For first 10 days of the fistula formation is the critical, in which patient is in sepsis and several metabolic electrolyte abnormalities is there. And enteral nutrition must always be preferred over parenteral nutrition, as improve the gut flora and reduce the electrolyte imbalance. In conclusion, though mortality of enterotomy fistula is high, aggressive management of the patient with initial 2 weeks of treatment can give a good result, and we mostly follow the SNAP principle, like sepsis elimination, skin protection, nutrition support, anatomical assessment, and planned surgeries. In general, principle of care must include early recognition and stabilization of patient with control of sepsis and nutrition support, investigation of anatomic and etiological characteristics of each fistula to predict the likelihood of spontaneous closure and need for operative management, and definite surgery, surgical therapies in controlled setting. Definitely, surgical therapy should be carried out in the which condition, like mostly spontaneous closure not occurred even after 4 to 6 weeks of conservative therapy. Patient having complex and fistula anatomy and patient having distal bowel obstruction. Thank you.
So in all cases of complex fistulas, would you go for surgery?
No, sir. First, all patient will first try to manage conservatively because less operating.
How will you manage conservatively?
Like we follow the mostly SNAP principle. Will patient keep patient NPO. Will daily assess the electrolyte imbalance and will give nutritional support either enteral or parenteral, whatever depend upon the patient condition.
Only that much in complex fistulas.
So complex will first just stabilize.
There may be localized collections of abscesses inside.
Any localized collection should be drained as early as possible.
How will you drain? How will you drain?
Sir, if abscess has formed the like fistula formed the abscess, we need to drain the abscess under ultrasound guide or CT guide. If in the deeper space, on this position we can directly drain in the aspirate.
Yes. In your slides, the slides must have been improved only when you narrowed down your primary or secondary objectives, because the objectives are long, so the research is going broader, so that the slides are much more,
yes,
which is not up to standard. So that must have been improved.
Yes.
Right?
You have mentioned sepsis is the main cause of producing intracutaneous fistula. Have you studied any markers for infection?
So mostly we get transferrin serum albumin mostly.
Have you mentioned here in the slides?
No, sir, but no, sir, I forgot to mention. I should have mentioned it.
All these are established facts. What is the novelty of this your study, and what is the take-home message?
Sir, take-home message is take every patient of fistula seriously.
Seriously.
Don't neglect, like don't wait for the management. Like always try to manage patient conservatively first with serial monitoring. If patient is not improving or deteriorating, we can switch the modalities, and always try enteral nutrition. If patient is not able to tolerate enteral nutrition or any other condition, then we can shift to parenteral because it has an own complication.
These are all book written languages. What is the novelty of your study?
Sir?
What is the novelty of your study? Over. Thank you.
Next, we have Dr. Kushal Patani from High Tech on a prospective study to determine the effects of ulcer size, ulcer age, duration of diabetes, glycemic control, infection, lower limb, ischemia, and neuropathy on outcome of diabetic foot ulcer.
Prospective study to determine the effects of ulcer size, age, duration of diabetes, glycemic control, infection, lower limb ischemia, and neuropathy on outcome of diabetic foot ulcer. India will be the diabetic capital of the world within next few years. Etiopathogenesis is diabetic neuropathies, microangiopathies, poor control of diabetes, and bacterial infections. The reasons for diabetic foot are foot is the most vulnerable part and is a site for preference for neuropathy and ischemia. Overall incidence of diabetics in India is 1.2%. The deaths of each year due to complication between the age group of 40 to 60 years, affecting both sexes equally. There is a 25% lifetime risk for development of ulcer. 40% amputations are preventable with a proper team approach. Aims and objectives are to find out the spectrum of foot ulcers and the effect of various risk factors on outcome, and to identify the better modalities of treatment and morbidity. Materials and methods. Study area is a Department of General Surgery, High Tech Medical College, Bhubaneswar. Study population includes 18 to 65 years non-pregnant type 2 diabetes mellitus patients, and excluded with type 1 diabetes mellitus, secondary diabetes, and gestational diabetes mellitus patients. Study period is from 1st of September 2022 to 30th June 2024. Sample size is study population divided based on patients managed conservatively and requiring major minor amputations, approximately 30 from each group. Study design is a prospective comparative study. Study tools and techniques include proper history about the underlying risk factors and proper clinical examinations, routine investigations, debridement, culture from
deepest portion of the wound, tuning for monofilament or biothessiometry for neuropathy, ankle brachial plexus index for ischemia, color Doppler studies, nerve conduction velocities. Some requires major and minor amputations and follow to the OPD after 14th day, 1 month, 3 month and 6 month interval. Diabetes mellitus described in medical writings since 5th century BC. Avicenna was the first one to describe the diabetic gangrene. Pricey association described the association of ulceration and vascular diseases in diabetes. In 1920s, Elliot and Jocelyn began to investigate the new medical and surgical strategies to save feet and legs from amputation. In 1934, Jocelyn's paper described the team approach to diabetes care. Eponychium or along the lateral borders of the nail are not uncommon sites for the infections. Predisposing factors to pathologic changes in diabetic foot are metabolic factors, vascular changes, neuropathy and infection. Metabolic factors such as hyperglycemia are due to polyol pathway, glycation of proteins. Vascular changes includes occlusive changes, blood flow changes, microangiopathy and hematological changes. In neuropathy, functional tests done are nerve conduction, neurologic examination, quantitative nerve testing of muscle strength, threshold of vibratory, cooling or warming sensation, autonomic function. Risk factors are clear relation between diabetes duration and neuropathy. Males and tall individuals, elderly diabetics, excessive consumption of alcohol in diabetics, smoking, diabetics with lower limb ischemia caused by peripheral vascular disease. Infections, patients with diabetes mellitus are more prone to infection than normal individuals. Predisposing factors are vascular insufficiency, neuropathy, resistance to infection, neutrophil bactericidal defect, defect in formation of reactive oxygen metabolites, arterial insufficiency locally. Treatment includes initial broad spectrum IV antibiotics depends on bacterial sensitivity, aggressive nutrition support, complete rest for injured part, extensive debridement, adequate dependent drainage, and appropriate arterial reconstruction and well-chosen conservative amputation. Vaginous grading depends from 0 to 5, 0 with no ulcer and 5 with a gangrene of whole foot. Investigations to demonstrate the extent and severity of disease and process, and to screen the diabetic patient for peripheral vascular insufficiency, and to confirm and control the intercurrent diseases interfering with the healing process. Blood tests, culture and sensitivity and X-rays are done. Non-invasive evaluation are toe pressure, duplex scanning with ultrasound analysis, photoplethysmography, segmental pressure, waveform evaluation, and invasive techniques such as percutaneous femoral angiography, CT and MRI. Correction of vascular risk factors. Treatable factors are smoking, hypertension, hypercholesterolemia, hypoglycemia, and hypertriglyceridemia. Treatment of diabetic foot ulcer depends on primary and secondary approach. Primary includes evaluation, metabolic control, culture, antibiotic therapy, and debridement. Techniques of debridement are autolytic, sharp, and surgical debridement, chemical, enzymatic, mechanical, and biosurgical debridement. Types of wound dressing are interactive hydrocolloid, alginate, hydrogel, iodine, povidone iodine, and cadexomor iodine. Growth factors such as bioengineered skin substitutes, hyperbaric oxygen therapy, negative pressure wound therapy, do not soak feet, post-healing treatment, and special shoes. Amputation in diabetic foot, such as amputation of toes from terminal phalanx of great toe, proximal phalanx of great toe, base of great toe, disarticulation at metatarsophalangeal joint, disarticulations of lateral foretoes, amputation of all other toes. Amputation of foot, transmetatarsal, tarsometatarsal, midtarsal, Siamese, modified Siamese, below and above knee amputation. Evidence-based treatment protocols are strict glycemic control with insulin, thorough surgical debridement, systemic antibiotics, statins for hyperlipidemia, tarsal tunnel release, offloading, moist wound environment, and oxum dressing, patient education regarding foot care. These are the results and analysis related to my study. With age distribution, gender, laterality of ulcer is mostly seen in right side, and distribution of side, dorsum and grade 2 mostly involved. Grade 2 and 3 are common, grade 2 and grade 3 vaginous lesion are involved. Duration of ulcer is between 30 to 180 days, most commonly seen, with duration of diabetes 6 to 10 years, with HbA1c levels of 7 to 12. And type of culture sensitivity, mostly monomicrobial infection is most common, such as Staph aureus. Distribution of X-ray, Doppler and monofilament with VPT, and distribution of treatment according to outcomes. Distribution of types of the amputations, such as grade 2 is mostly amputated. Discussion. My study involved 75 patients with 51 plus minus 8 years mostly. No significant association with gender and amputation and neuropathic ulcer and amputation. No significant association between type of microorganisms and amputation. 21 with minor and 8 major amputations has been done. Summary includes diabetic food management is a teamwork with good glycemic control, and oxum dressing shows good results. With vacuum assisted closure may be applied to fasten healing.
To me, it appears this is not presentation but an essay. This should not be the slide qualities, etc. You have not gone through the significance of making a slide. Number two is out of so many criteria, which is the most important criteria regarding healing of a diabetic ulcer? From your study, which is the most important parameter for healing of diabetic ulcer?
So it depends on the grade of the ulcer and also with the
Question is specific. Which is the most important etiopathogenetic factor? You have got so many factors for contributing healing. Which is the most important?
So microangiopathy is
So therefore, you should have taken only one parameter as your primary objective for study. So all this because you have taken about 7 parameters. If you take so many parameters, the complexity of the study will increase, and you have to go for different analytic methods also. What are the different analytic methods to determine which one amongst these factors is contributing to healing? What are the different regression analysis?
HbA1c control.
No, you have taken so many factors. That is a problem. You could have taken only one, either neuropathy or microangiopathy or glycemic control, only one feature that will contribute to healing or affect healing. Then the thesis would have been better. Right? Thank you.
Attention jury, the next speaker, the next participant will be not Dr. Medhavi, it will be Dr. Gargi. Because of some reasons, he cannot present. Right, please continue.
Next, we have a presentation on the effect of non-closure of peritoneum versus closure of peritoneum on post-operative pain in patients undergoing open appendectomy, a double-blinded randomized control study by Dr. Gargi Maheshwari from AIIMS Bhubaneswar.
Good afternoon, everyone. I am presenting the effect of non-closure of peritoneum versus closure of peritoneum on post-operative pain in patients undergoing open appendectomy. It is a double-blinded RCT. Post-operative pain is one of the most common complications of any surgery. The more post-operative pain it is there, leads to more sympathetic stimulation and a delayed post-operative recovery. Lowering the post-operative pain is an important component of ERAS. We conducted a study where we compared the effect of peritoneum closure on post-operative pain along with non-closure in open appendectomy cases. The hypothesis says that leaving the peritoneum open causes less post-operative pain. Rationale: when peritoneum is left unsutured, the remesothelialization of the peritoneum will automatically happen over 48 to 72 hours with the complete healing over 5 days. While the reapproximation by suture material will cause an increased foreign body reaction, there will be tissue ischemia and necrosis, adhesion formation, and the stretching of peritoneum, which will lead to an increased postoperative pain. Methodology. The study setting was done with all the patients presenting with acute appendicitis to either general surgery OPD or emergency in AIIMS Bhubaneswar. The study type is a randomized controlled trial. Randomization was done by a random allocation software. It was a double-blinded study where the subject and the assessor of the pain was blinded. Intervention. The intervention arm was where the peritoneum was not closed. The follow-up period was of 1 month. The sample size was 98 with 49 patients in each group with a power of 80 and confidence interval of 95%. The population inclusion criteria were all the patients with acute appendicitis in the age group of 14 to 75 years of age. In exclusion criteria, we took the patients with pregnancy, patients withdrawing consent, patients less than 14 years or greater than 75 years, patients having appendicular perforation or appendicular lump, as in those cases either the procedure was abandoned or it was converted to exploratory laparotomy. Open appendectomy without McBurney's and Lance incision, patient wanting to proceed with laparoscopic appendectomy, having malignancy or psychiatry and malignant disorder, mental disorder. The intervention and control were as explained before. The outcome, primary outcome we measured was the post-operative pain as measured by the visual score. Secondary outcome, we measured surgical site infection, duration of hospital stay, duration of surgery, expenditure of surgery, and readmission to hospital within 1 month. Appendectomy was done by the standard procedure. Before the closure of the peritoneum, the peritoneum was closed in the cases allotted to the control arm. And following the muscle layer apposition, external oblique neurosis, aponeurosis was closed and skin closure was done in all cases. Post-operative analgesia was kept constant for both control and intervention arm. PCN and tramadol were given to the patient as per the mentioned doses. VAS score was mentioned in post-op period at 6-hourly interval for 21st 24 hours followed by a 12-hourly interval. The wound was examined from post-operative day 2 to 1 month to look for SSI. The duration of hospital stay was noted. Patients were followed up for 1 month for any complications and readmission. The chart is as follows. Total 95 patients were taken, out of which around 28 patients were excluded. 14 were those which were not meeting the inclusion criteria. 9 patients declined to participate, and other patients were 5 patients, out of which 3 patients went LAMA and 2 patients refused surgery as they wanted to proceed with laparoscopic procedure. The remaining 67 patients were randomized and were allotted to the peritoneal closure arm 36 patients and the non-closure arm 31 patients. Out of the 36 patients, the patient which received allocated intervention were 31 and the rest of the patients which were converted to EL were 5 patients which were further excluded. Allocated to intervention group B were again 28 patients which received allocated intervention and the 3 patients they did not receive the similar allocated intervention which were further analyzed. The results are as follows. The VAS scoring was done in the post-operative period in which the mean score, the score in the intervention arm were lower overall, but after the analysis, the score it did not come out to be significant. SSI was seen in closure arm. In closure arm, there were less patients with SSI as compared to the non-closure arm. In readmission, the closure arm, 2 patients were readmitted, while in the non-closure arm, only 1 patient was readmitted for seroma. The other secondary objectives, duration of surgery was similar in both the arms. Days of hospitalization were also similar in both the arms. The expenditure was more for the non-intervention arm. Discussion. At all times, the mean VAS score was noted to be lower in the intervention arm, but the difference was only statistically significant in immediate post-op period VAS 0 and at 96 hours. The rate of surgical site infection was more in the intervention arm, but the differences were not significant. No statistically significant difference were found in days of hospitalization or readmission within 1 month and duration of surgery if the peritoneum was left unsutured. Limitations. The extension of the wound intraoperatively was not taken into account. The conversion of muscle splitting to muscle cutting incision was for better access to the operative area was again not taken into account as it can lead to more pain in the post-operative period. The sample size was smaller as was decided than the previous decided sample size. Leaving the peritoneum open, it leads to lesser postoperative pain and more chances of SSI. But as the sample size was not achieved, we need a larger sample size for better correlation and validating the study with statistically significant results.
Commonly, open surgery we do that McBurney or large incision. Commonly.
Sir, commonly we will proceed with the McBurney's incision, sir.
No, you excluded laparoscopic appendectomy.
Sir?
You excluded laparoscopic incision.
Yes, sir.
Right?
Yes.
Then you excluded this McBurney and Lange. Why? Why?
Sir,
In your study, why did you exclude these two groups which we commonly use?
Sir, we included the McBurney and Lange incision, sir. Rest others were excluded.
No. Show me that slide, inclusion and exclusion criteria. Exclusion criteria, open appendectomy without McBurney and Lange incision.
Yes.
What do you mean by that?
Sir, the patients which underwent open appendectomy without the two mentioned incisions, those patients were excluded from the study.
Means minus these two.
Yes, sir.
What are the other incisions?
Sir, we can one that if it is converted to exploratory laparotomy, that those patients were excluded. Other than that, if Rutherford-Morrison incision, medial or extension was given, then those patients were further also excluded from the study.
So pain is less in those group where in this group
Sir,
where you keep the peritoneum open. Postoperative pain, as you say,
Yes,
is
sir.
less.
if we leave the peritoneum open, then in those cases, overall it was seen that in the VAS scoring, the pain was less in the non-closure group. But since we are assuming that we had a smaller sample size, the results were not statistically significant.
What is the difference between this pathology in other incision and your incision? This closure or open?
Sir, if we will not close the peritoneum, then there will be decreased stretching, there will be decreased adhesion, and there will be decreased foreign body, which can further lead to postoperative complications. So this will lead to we assume the hypothesis was so that it will lead to a better postoperative outcome in a peritoneal non-closure.
Why it is not so in Rutherford-Morrison incision? There also you are opening the peritoneum.
Yes, sir.
And you have to close it. Here, if you do not close it, there will be less pain postoperative. That you want to say.
Yes, sir.
What is the difference?
Sir, difference will be in the extension of the incision. As the incision will be extended, it will be associated with more pain in those groups.
Do you have any reason to tell why this peritoneum, if not stitched, it is healed? What is the mechanism of healing of peritoneum if it is not stitched?
In the patient.
Thank you. Finally, one clarification from the organizing team. What I know, the thesis competition includes the thesis of their own thesis, what I think. But in this case, although we have evaluated whether it is her thesis or it is the thesis of Dr. Madhavi Sinha. Organizing team. So whether we will include in the competition or not. Yes, inclusion or exclusion criteria for competition. It will be included even if others thesis.
So this thesis was from a third year PG.
Even if it is others' thesis, they have discussed in the department and it is universally, I mean, they have agreed that this is to be presented by the presenter.
The
They included.
competition will go in favor of the thesis owner or the presenter?
Presenter. Huh?
Yes,
Thesis owner.
that is the conclusion.
Acha, right. thesis owner was Dr. Medhavi.
Yes.
So thesis owner is Dr. Medhavi. So one who has done the project, she is only just presenting
presenter only
because
on,
of her
on behalf
personal
of,
reasons.
on behalf of Dr. Madhavi.
So competition will go for Dr. Medhavi.
Yes. Yes. No, that is the question. We have evaluated, no problem.
Runner for the cricket's batsman.
No. Take it. Thank you.
Thank you, judges, for the intellectual direction throughout the session. Now, I would like to welcome Mr. Shubham Gupta, State Manager from Smith and Nephew Healthcare Private Limited, to share a few words on the topic of advanced wound management.
Yeah, good afternoon, everyone. So this is a basic clinical decision support tool. We can call like time wound bed preparation and vast wound management. So my name is Shubham Gupta from Smith and Nephew. So this is a wound bed preparation time principle where T stands for tissue non-viable, I stands for infection inflammation, M for moisture balance, E for edges of the wound. So why wound bed preparation? Chronic wounds needs to be free from acute models of injury. The chronic wound is completely different pathological entity. The healing process expected in acute wounds has been interrupted in chronic wounds. These wounds will not heal unless their environment is adjusted so that healing can be encouraged. Chronic wounds do not follow the normal sequential phases of wound healing like this: acute, sequential phases of healing. If the wound heal, acute and then chronic. So in time principle, tissue T stands for tissue non-viable or deficient. So what are the factors that affecting tissue stress? There is local edema, vascular supply compromise, deep infection, increased pressure with hyperkeratic callus or ulcer rim, low albumin, increased local pressure, friction and shear, immobility, incontinence of feces or urine. So this is tissue, an example of the necrotic one. Objectives in relation to treating tissue in chronic wounds: clear away dead cells or necrotic tissue, always ensure adequate tissue oxygenation. Tissue non-viable or deficient, so removal of callus and necrotic tissue, decreasing the bacterial burden, removal of phenotypically altered cells, the cells burden, and then debridement. So efficient debridement is essential in treating all wounds. Necrotic tissue is continually building up in chronic wounds. Debridement is an ongoing process. Debridement will allow healthy granulation tissue to form. Debridement reduces wound contamination and reduces further tissue destruction. So types of debridement: autolytic one, surgical sharp, enzymatic debridement, mechanical, biological therapy. So these are the classes of debridement. Autolytic occurs spontaneously in all wounds. Enzymes spontaneously separate necrotic tissue from healthy tissue. Moist dressing can enhance the environment for debridement. Cheap and cost effectiveness. T-shirt can contribute to the delay in surgical sharp debridement. Fastest and effective way of remove debris necrotic tissue, can leave a bleeding base which is known to increase the healing rate of neutrotropic foot ulcers. Surgical debridement is normally performed where there is a wide wound area, where there is a widespread infection, where bone and infected tissue must be removed, where the patient is septic. Usually it is a costly procedure. The surgical debridement, so debridement of a buttock ulcer, say example of enzymatic debridement then uses topical application of exogenous enzymes to the wound surface. Excess exudates may be produced with these agents. Available agents like bacterial collagenase, DNA fibrolysis, papinuria, trypsin. And this one is a mechanical one, used to physically remove debris from wound. Wet to dry dressing, wound irrigation, can be uncomfortable and damage newly formed tissue. Also used to remove bacteria through water pressure. And it's a biological therapy. Larval therapy is a re-emerging Sterile larva of the Lucellus sericata fly is used, produce powerful enzymes which break down dead tissue without harming healthy granulation tissue, also appear to combat clinical infection. There are some examples here. So we can cover it like T, tissue non-viable and deficient. Then I stands for infection inflammation. This is assessing wound infection. The stages, contamination, colonize, critical colonize infection. Systemic factors that increases risk of infection. So vascular disease, edema, malnutrition, diabetic mellitus, alcoholism, prior surgery or radiation, drugs or corticosteroids. So local factor that increase risk of infection, large wound area, increased wound depth, degree of chronicity, presence of foreign bodies, necrotic tissue, mechanisms of injury, degree of post-wound contamination. So this is some examples of persistent inflammation. So biofilms are microorganisms attached to surface aggregated in hydrated polymeric matrix, glycolics of their own synthesis. Bacterial benefits of creating a biofilms, cooperative nutrition strategies, evasion of host immune system, altered phenotype and genotype, resistance of antimicrobials. So we can cover eye as well. Now moist wound healing environment for chronic wounds of healing. Increasing the speed of reepithelialization, earlier and less prolonged angiogenesis, reducing local wound pain, increasing the viability of WBC and decreasing the rate of infection, providing nutrients, proteins and electrolytes that are essential for cell growth. Like this, the desiccated wounds, slows epithelial migration, delays normal healing, act as a source of infection, painful, increased cost. Now it's a wet example. Excess fluid causes maceration of wound margins, inhibitory of healing, conducive to bacterial wound colonization, painful and uncomfortable for the patients, longer treatment time. So moisture balance state. So not too dry, not too wet, not desiccated and not a macerated wound. So factors that influence exudate production, wound type, depth, surface area, burns, extensive ulceration, wound infection, stimulation of inflammatory process, patient's condition, venous hypertension, cardiac failure. Factors, then dressing selection. First, the clinical evidence, wound etiology, tissue type, levels of exudate, patient preference, cost and cost effectiveness. So guidelines for the use of wound dressing, use a dressing that will maintain a moist environment, use clinical judgment to select a moist wound dressing for the wound being treated, choose a dressing that will keep the peri-ulcer skin dry while maintaining the moisture within the wound, use a dressing that will control the wound exudate without leading a desiccation of the wound bed. If possible, use dressing that are easy to apply and do not require frequent changes, as this will decrease the amount of health care provider time required. Fill any cavities within the wound to avoid impaired healing and increase bacterial invasion. So monitor all dressings, particularly those near the anus, which are difficult to keep in place. Review the dressing regime regularly to reflect the changes taking place in the wound. So last one is epidermal margin and non-advancing or undermine. So why does the epidermal margin fail to migrate? Failure of the epidermal margin to migrate across the wound is the most obvious sign that wound is failing to heal. If the margin is undermined, this may be a sign of critical colonization or infection. At a cellular level, the lack of epidermal migration may be due to many different factors: keratinocytes, fibroblasts, non-responsive of wound cells, excessive inflammatory response, abnormalities. What if the epidermis fails to advance? Reconsider the principle of wound bed preparation, that is time. Has necrotic tissue been debrided? Is there a well vascularized wound bed? Has infection been put under control? What is the status of inflammation? To what level has moisture imbalance been corrected? What dressings have been applied? So the next option may be prepare the wound bed for advanced wound healing techniques, hyperbaric oxygen, stem cell therapy, concentrated growth factors. We have covered last one as well. So the systemic approach: debride, manage exudate, manage infection, pack cavities, protect protect, control, order, encourage healing. So we are having some portfolio available with us. That is AWM portfolio. It's an advanced wound management portfolio from Smith and Nephew. So for antimicrobial silver dressings, we are having Acticoat Flex, and 11AG. That is a nanocrystalline silver dressing embedded in it. It works for 3 or as well as 7 days. We are having a perforated sheet available. That is again a nanocrystalline silver dressing in a single polyester layer. It works for 7 days. It is having a perforations inside, and a foam dressing that is named as 11AG. There is a hydrocellular foam dressing, contains silver sulfidazine. Second one is NPWT. It's a single-use negative pressure wound treatment therapy. It's a battery-operated canister-free device to help in terms of reduction of surgical site complications. So these are skincare products like Sika Care. We have silicone gel sheet, post-op dressings, post-op Primapore. It's a hydrosurgical debridement system, and then last foam dressings. So there is a wound bed preparation as a time principle. T stands for tissue, I infection, M moisture, and E edges of the wound. So with this, thank you very much for the time provided. Thank you, sir.
Thank you for giving a brief introduction about the advances available. With no further ado, let's dive into the most awaited hour of the day. All participants and the audience are ready to challenge their minds and tickle their brains. To embark on this eve are our well-known whiz, Dr. Pankaj Kumar Sir, Assistant Professor, Department of General Surgery, AIIMS Bhubaneswar; Dr. Monica Gure, Assistant Professor, Department of General Surgery, AIIMS Bhubaneswar.
I request Dr. Prakash Sahu to actually come to stage for the quiz. He will be the quiz master. No, so sir is the chairman. So any decision, any problem, the sir decision will be final.
Keep your phones with your friends. Please don't bring your phones on the stage. That's a request. To invite the teams which are participating. First, I would like to invite Dr. Pradesh Kumar and Dr. Sartha Subdarshi from SCB Cuttack. I request all the participants to please come forward. Second, I would like to invite Dr. Lavanya Jain and Dr. Satyam Barik from MKCG. Please come this side. You have to pick a chit so that your team number will be allotted. Any of the chit you can pick. That's over there. Next, I would like to invite Dr. Aditya Jain and Dr. Riya Rupak Das from KIMS. Next, I would like to invite Dr. Shakti Bhushan Patnaik and Dr. Abhishek Dubey from VIMSAR. Next team will be Dr. Aravinda Kumar and Yash Chauhan from AIIMS SAM. I would like to invite Dr. Abhishek Jenamani and Soumdip Patnaik. They are from High Tech. I would like to invite Dr. Akarsh and Dr. Ankit from AIIMS Bhubaneswar. And last team will be Dr. Surya Nayak and Kedarnath Parija from PJIMR. So I would like to inform all the participants that in total 3 rounds will be there. In the first round, there will be 5 questions per team. So in first round, if you answer right, you will be getting 10 marks. If you answer wrong, -5 will be there, and it will be passable round. And your second round will be rapid fire round, and third round will be quickest scalpel, in which we will be showing you videos. So it's a sort of buzzer round. Okay, so basically you will take your mic and you will announce your team name. So that person will be first. Like if you are in team 6, so take the mic, say 6. Okay, so that person will be first. So do you want to ask anything?
We will keep telling you the rules. Okay, so we'll start with the first round. So just tell them the rules of first round. Please say it again. Please tell it again.
Okay. So these are the rules of first round, the vital 5. So total 5 questions per team will be there, and for each question you will be given 30 seconds. Okay, and for correct answer you will be getting 10 marks, and for incorrect answer you will be getting -5 marks, and it's a passable round. So if it is passed to next team, if that team answer it correctly, so that team will be getting 5 marks. But if the team don't know the answer and answer it wrongly, so -5 will be there. So keep it in mind, it has negative marking. And if none of the team is able to answer, so basically it will be passed to the audience. Any doubt you want to ask?
Ma'am, if no answer is given, so marks will be 0 or -5?
0. If you answer it wrong, then it will be -5. But
Yes,
if you don't know the answer, so basically you can leave it. Okay.
Yes, ma'am.
Yes. Scorekeeper, ready? Can we start now? Dr. Monica, please.
I would like to thank Dr. Naresh, Dr. Amir for helping us in this quiz. So basically, we'll be starting with the first round. Team 1. Okay, so for you, the question for this round is identify the procedure done in a 35-year-old male with peptic ulcer.
Team 1.
Minded, you have 30 seconds.
Binrat 1.
-5 for team 1.
Team 2. Team 2. Yes.
Team 2. See, you have seen the question, so when it's passed, don't take time.
Sendes and pouch procedure. Sendes and pouch.
Next, -5.
Pass.
Next.
Pass.
Next team 5. -5 to team 5. Team 6.
Team 6.
Kelly Madlener. Kelly Madlener.
Pardon?
Kelly Madlener.
No.
Team 7.
-5.
Team 7.
Team 8.
Pass.
So the answer is audience. Anyone want to answer? No. Okay, sir. Partial gastrectomy. It's fine, but its name is Poshett's procedure. Cindy's is different. Pochette is different. You can't combine. Team 2. It's your turn, and the question for you. First question for you in this round is: 40-year-old male with GRD underwent upper GI endoscopy. Identify the endoscopic view demonstrated in the figure.
J view. J maneuver.
Very good. So 10 marks goes to team 2. So it's basically J maneuver or retroflexion. I would like to request the audience there, if someone is giving right answer, please just give clap for them. So team 3, question for you in this round is: 27-year-old male was driving a motorcycle and collided with a car. Patient was brought to hospital. During physical examination, bluish colorless discoloration was noted over posterior to the earlobe, which is shown in the image. So name this sign.
Team 3. Team 3, you have 30 seconds. Team 4.
Battle sign.
Very good. So 5 marks goes to team 4. Very well answered, team 4. The question for you in this round is: regular triad is seen in?
These are very easy questions. Team 4.
Yes, sir.
Large bowel obstruction.
-5 to team 4. Team 5.
Gallstone ileus.
Very good. Gallstone ileus. So any of the residents sitting in the
Team 5 will get bonus. Plus 5.
Any of the residents from the audience, I would like to ask. So it's a triad basically. So what are the three components in this triad? Any volunteer from residents? Come forward. So your name is Dr. Shweta, and you are from? Very good. Team 5, first question in this round for you is, in gastric carcinoma, splenic lymph node station is, so there are level of lymph node stations, so splenic lymph node station is?
10.
Very good. So 10 marks goes to team 5. Team 6, first question for you in this round is, lymph node of Mesgagni is removed in which surgery? It's removed or sometimes it's seen in which surgery?
Pass.
Team 7.
Pass.
Team 8? Team 1? 2?
Pass.
3? 4?
Lab cholecystectomy.
Very good. Perfect. So 5 marks goes to team 4. Team 4. So regularly we do laparoscopic cholecystectomy, and every time you see lymph node, so basically that lymph node is a lymph node of Mesgagni. Team 7, first question for you in this round is, position in which patient should be placed for air embolism. What should be the position in which a patient of air embolism should be kept?
So you are doing a laparoscopic surgery, suspected patient has air embolism. Which position should you turn the patient?
Foot up and right top.
Tell the name of the position.
Trendelenburg position. With right side up.
-5 to team 7. Next team, team 8.
Team 1.
Reverse Trendelenburg.
No, -5. Team 1, -5 to team 1. Team 2. Team 3.
Team 4.
Pass.
5.
Durant position.
Very good. Very good. Very good. So 5 marks goes to team 5. So basically it's left lateral decubitus position with head down. Team 8, your question for this round is, a patient with a breast abscess is treated with suction and drainage catheter. So what should be the size of abscess? Okay. There are some recommendations that in this size or in this volume of abscess, we can treat it by putting a drain. So what should be the size, or what can be the volume? Anything you can answer.
More than 20 cc or more than 5 centimeter?
-5 goes to team 8, team 1, team 2, team 3.
Team 4.
Pass.
5. 6. 7. All pass. So now they are wiser.
So audience opinion. Anyone want to answer? So you won't be having any negative marking. At least you can try. Any guess? So what Bailey and Love say is, it should be more than 30 ml. the volume, it should be more than 30 ml, or the size should be more than 3 centimeter. Okay, everyone, more than 3 centimeter and more than 30 ml. So back to team 1. So team 1, second question for you.
After 5 questions, then we declare.
So team 1, second question for you in this round is a 58-year-old.
Why don't we calculate now? We can tell the scores at the end of first round. So at the end of first round, team 3, team 6 have yet to open their account. Team 1 with -10, team 2 with -5, team 4 +5, team 7 -10, team 8 -5, and team 5 leading this round with 15 marks.
The participants can actually check their score. If you see there are some discrepancy, please tell us now.
You can see your score.
So any team having any doubt with your marks?
Team 2 is having +5, not minus, +5. Team 2.
So second question for team 1 in this round is a 58-year-old male who is known case of coronary artery disease and is on tablet acetrom, present with sudden onset of left-sided lower abdominal pain after spasmodic coughing. On examination, there is an 8 centimeter tender mass in the lower abdomen that remained unchanged with the contraction of rectus muscle. So this is basically the CT film of the patient. So what is the most likely diagnosis?
Rectus hematoma.
Very good. Rectus sheath hematoma. So +10 goes to team 1. Team 2, the question for you in this round is identify the type of bile duct injury as per Strasbourg classification that is shown in this image.
Type D.
Very good. So 10 marks goes to team 2. Team 3, the question for you. The question for you in this round is the diagnosis. This is basically technetium scan. So diagnosis of technetium 99 scan in this images.
See the image and tell us the diagnosis.
Right solitary thyroid nodule.
Sorry?
A right solitary thyroid nodule.
-5.
-5 goes to team 3. Team 4.
Right toxic nodular goiter.
Very good. So perfect. So +5 goes to team 4. So basically it's a toxic adenoma. Team 4, question for you in this round is what is the GCS of a head injury patient? If the patient is after trauma, the patient is opening eye to pain. Second thing is the patient is confused and the patient is doing flexion in response to the pain.
-11.
-5 goes to team 4. Team 5.
8.
Pardon?
8. Shall I expand it or E2 confuse V4 and M2.
-5. Team 5, -5.
Team 6.
It's 9.
Very
It's
good.
9.
+5 goes to Team 6. So the GCS score is 9. Team 5. Question for you in this round is which of the following is a 90 gene microarray based on molecular diagnostic assay that assign tumor into categories of high or low risk of metastasis in carcinoma breast?
KI67.
-5. It's a name of test. -5 goes to Team 5. It's a name of test. KI67 is something else. Okay. Next Team 6.
Mama print.
Very good. So +5 marks goes to Team 6. Team 6, your question for this round is what is the incision marked by K in the image? Name the incision.
Clamshell incision.
Very good. Clamshell. Clamshell. Okay, we'll give you +10, but clamshell what?
Thoracotomy.
Very good. So +10 goes to Team 6. Team 7, question for you. Second question for you in this round is Jefferson fracture is fracture of. So it's something related to the vertebra. You can see the patient. Okay. Some traction is given, so it's something related to the vertebra.
Very common.
C6.
-5 goes to Team 7. Team 8.
That's the C1 vertebra.
Huh?
C1.
C1 or T1?
C1.
C1, correct. So +5 goes to Team 8. Team 8, name the curve shown in the figure in relation to growth of the tumor over period of time. Team 1.
Pass.
Pass. Team 2.
Pass.
Team 3. 4.
Pass.
5. 6.
Pass.
7. Anyone from the audience? Yes, sir. Perfect, sir. Clap for
Sir, you should not answer. You ask the regent to answer.
So, sir will be telling the marks after this set of rounds. -10 +10 0.
At the end of this round, team 1 with 0 marks, team 2 with 15 marks, team 3 with minus 5 mark, team 4 5 mark, team 5 5 mark, team 6 leading this in this round with 20 marks, team 7 minus 15, and team 8 0.
So you have plenty of questions to buck up. Third set of questions for this round. Team 1, what is the most common neuroendocrine tumor of the pancreas?
Insulinoma.
Minus 5 goes to team 1, team 2,
Pass.
team 3, four,
Pass.
5.
Insulinoma.
You might have heard him, na? You
Sorry, gastrinoma.
minus 5 goes to.
Gastrinoma.
We can give you minus 10 if you will keep on answering.
Again, one more minus.
Minus 5 goes to team 5, team 6.
Glucagonoma.
Minus 5, team 7.
Gastrinoma.
Just listen to your colleagues what they are saying. You are also answering the same thing. Minus 5 goes to team 7, team 8. Pass. So anyone from the audience? So we won't be giving you any marks, but you can tell the answer. So it's known as. Huh? Any of you people are saying it right.
Non-functional.
Incidental humor. Team 2, question for you in this round is gastric ulcer located on the lesser curvature near gastroesophageal junction. It's which type of ulcer?
Type 4.
Very good. So plus 10 goes to team 2. But anyone from the audience, what is the name of classification? Let the audience answer. Audience, anyone want to answer? Tell. From the participants, what is the name of team 2?
Johnson's criteria.
Team 3, your question. Phoenix device shown in the image is used for?
Anal incontinence.
Again, I think we can take it.
So plus 5 goes to team 4. So basically it's used in anal sphincter augmentation. Plus 5 to team 4.
Any other device anyone can mention for anal sphincter augmentation? Any other device? Gatekeeper, spin keepers, anyone? So they are gatekeepers and the spin keepers.
Team 4, your question, third question for this round is identify the flap shown in the image with blue color used for breast reconstruction. Can you appreciate the color? This blue. This blue.
Pass.
Next team, team 5,
Pass.
6,
Pass.
team 7, team 8, team 1, 2,
Pass.
team 3. So anyone from the audience?
Team audience.
Very well, very good. Your huh? Monica, and you are from which college? KIMS, very good. So clap for Monica, please. So this is basically profunda femoris perforator plan. Team 5, your question in this round is, what type of studies is the concierge treatment checklist used to report?
Pass.
Team 6,
Pass.
team 7,
Pass.
team 8,
Pass.
team 1, team 2,
Randomized control trial.
very good.
It's not a very difficult question. Why we are passing
Plus
the
5 to team 2.
consort checklist every time you see the
So plus 5 goes to team 2. So round of applause for team 2. Team 6, your third question in this round is, on which day of menstrual cycle is the breast pain most pronounced in the patients with anti?
On the day of ovulation, day 14.
Minus 5 goes to team 6. Team 7,
You see the patients of cyclical marasthenia and UPD. Now I think you should be able to answer.
Pass.
team 1, 2,
Pass.
3.
Day 21.
Minus 5 goes to team 3. Team 4.
Pass.
So there's a anyone from the audience? So it's a new edition in your. It's being added to the 28th edition of Love and Bailey. The time you go home and read at what time the nodularity is maximum and pain I'll be telling you. So on day 28 the pain is maximum, but all of you go home and read at what time the nodularity is maximum. Okay. Team 7. How many degree of movement does robotic surgery provides? Team 8,
Pass.
team 1, 2,
7.
very good. So plus 5 goes to team 2.
So this was again very easy question. It's very easy.
Team 8, your question for this round is, most common location of spleniculæ is? Team 1,
Learning Asylum.
very good. So plus 5 goes to team 1. Round of applause for team 1, please.
Scores, please.
Team 1 0, team 2 is on 35, team 3 is on
Minus 10. Team 3 is minus 10.
minus 10, team 4
Plus 10.
plus 10, team 5 0, team 6 10, team 7
Minus 20.
minus 20, and team 8 0. Team 1, your fourth question for this round is 19-year-old male presented with skin lesions, or you can see some abnormality given in the image. So name the syndrome. Team 2?
Clipple Trenon syndrome.
Very good. So plus 5 goes to team 2. Plus 5 goes to team 2. Team 2, name the procedure shown in the image.
Paul Mikulicz.
Very good. So plus 10 goes to team 2. Team 3, your question is what is the most common cause of bilateral adrenal hemorrhage causing adrenal insufficiency? Bilateral adrenal hemorrhage causing adrenal insufficiency. Team 4?
Pass.
5?
Pass.
6? Team 6? You want to tell or you want to pass it?
Pass.
Team 8, 7?
Neisseria meningitis infection causing Fredrickson-Waterhouse syndrome.
I can't get you.
Waterhouse-Fredrickson syndrome caused by Neisseria meningitis infection.
Be loud.
Waterhouse-Fredrickson syndrome
That's the syndrome. Cause.
infection by Neisseria meningitis.
Minus 5, team 8.
Team 8. Team 7.
Minus 7 to team
Minus 5 to team
minus
7.
5 to team 7. Team 8. Pass. 1, 2. Anyone from the audience? Trauma because of?
So trauma is partially correct.
Partially you are correct, but trauma because of what? No. So the answer is traumatic obstetric delivery. This is the new thing which I also came across. Team 4, your question in this round is a 35-year-old female complaining of recurrent vomiting of ingested food material, more marked in night time. Upper GI endoscopy findings are suspicious of eclasia cardia, esophageal peristalsis in high resolution manometry as depicted is suggestive of pan-esophageal pressurization along with high lower esophageal sphincter pressure. Okay, so what is your diagnosis? Team 4.
Look at the manometric findings. See the colors and then you should be able to answer.
Pass.
Team 5.
Type 3 acalisaccardia.
Minus 5. Team 5. Minus 5 goes to team 5. Team 6.
Pass. Pass.
7. Team 7.
DES.
-5 goes to team 7, team 8.
Nutcracker. Nutcracker syndrome.
-5 goes to team 8, team 1, 2, 3.
Menetrius disease.
Sorry? -5.
To team 1.
Team 2. No, team 3.
So anyone from the audience? Yes? Very good. So it's
It's a
type
type
2
2
eclampsia. So for all the residents, you will be giving your MCH exam. So motility disorders is very important. Okay. In team 5, your question is what are the pressure settings for management of a chronic wound by vacuum assisted closure? So basically you have to tell the pressure, the amount of pressure which should be applied.
125 mm Hg, -125.
Perfect. So round of applause for team 5, please. So it's intermittent negative pressure of 125 mm of Hg. Team 6, your question is anatomical classification of fistula in ANO as per Park's classification is in relation to which structure?
When we are classifying the fistula, so which structure we actually identify? Landmarks. To define part of
Anal sphincter.
It's very vague term.
you have to be very specific.
External sphincter.
Very good. So plus 10 goes to team 6. Team 7, your question is Henrik's pyramid is related to
Pass.
team 8. Team 1, 2,
Pass.
3, 4,
Pass.
5, 6. Anyone from the audience?
Sorry? Not audible.
Very so it's
Patient safety.
so it's basically related to patient safety. Very good. Team 8, name the scale shown in the which is being shown in the figure. What is the name of the scale? Team 1,
Pass.
5, 6.
7. Anyone from the audience? Yes? Very good. Your name? Deepshika, and you are from which college? KIMS? Okay, so clap for Deepshika, please.
Because now they are discussing and then answer. Very good.
But very good.
Now listen to the kids. All the answers are coming from kids. Prakash is school, please.
Team 1 is on 0. Team 2 is on 50. Team 3 is minus 15. Team 4 is plus 15. Team 5 is plus 5. Team 6 plus 20. Team 7 is minus 10. Minus 25. Minus 25. And
minus 30. Team 7 is minus.
sorry, team 7 is on minus 30.
Team 8 is minus 5.
Team 8 is minus 5. Team 1, your question is type of hernia which is being shown in the image. So it's basically laparoscopic view. What is the type of hernia which is being shown?
Red point arrow. Which one?
This one. This is defect.
Indirect inguinal hand.
This is the defect.
Indirect inguinal hand.
Huh?
Indirect inguinal hand.
Plus 10. Team 2, 16 years old male having autosomal dominant condition.
No, wait. Team 1 got correct answer. Plus 10.
Team 2, 16 years old male having autosomal dominant condition with multiple polyps in small and large bowel with hyperpigmented spots in the mouth and in the perianal skin. So what is this condition?
Peutz-Jeghers syndrome.
Very good. So plus 10 goes to team 2. Team 3, identify the bariatric procedure which is being shown in the image.
Sleeve gastrectomy.
Minus 5 goes to team 3. Team 4.
BPD.
Very good. So plus 5 goes to team 4. So anyone from the audience want to answer what is BPD? Correct. Team 4, your question is vanishing bile duct syndrome is seen in?
Pass.
Team 5?
Pass.
6? Team 7? 8? 1?
PSC.
PH?
Primary sclerosing cholangitis.
Minus 5 goes to team 1. Team 2?
Graft versus host disease.
So it's graft versus host disease. So basically it's seen in
Liver post liver transplantation.
which type of rejection?
Chronic.
Very good. So plus 5 goes to team 2. So it's basically seen in chronic liver graft rejection. Team 5, your question is strongest layer of the stomach is?
Submucosal layer.
Very good. So basically plus 10 goes to team 5. Team 6, name the instrument which is being shown in the image.
Pass.
7? Team 8?
Thyroid retractor.
Pardon?
Thyroid retractor.
Minus 5 goes to team 8. Team 1?
Morris self-retention.
Minus 5 goes to team 1. Team 2?
Pass.
Team 3?
Millen's abdominal retractor.
Minus 5.
Team 4,
Self-retaining abdominal retractor.
what is the name of retractor?
Pass.
You want to answer or you want to pass?
Pass. Pass.
Team 5,
Pass.
so it's basically Balapur. Sorry, I forgot.
Audience? Those who have seen the recording, maybe they should be able to answer. No?
So it's Balapur.
It's a Buckford detector.
Team 7, your question is inguinodynia is defined as post-surgery pain persisting for more than what period of time?
3 months.
Very good. Plus 10 goes to team 7. Team 8, your question is identify the condition which is being shown in the endoscopic image.
JB, gastric antral vascular ectasia.
Very good. So plus 10 goes to team 8. So it. What is the full form of this condition? Gave you told na?
Antral vascular ectasia.
Okay, very good. Another name? Anyone from the audience? Watermelon. Very good. So this ends the first round, and we'll be looking at the score.
So, Prakash sir is calculating the score. So now I think you all are geared up because the next round will be the rapid fire round.
Minus 30 which one?
Rapid fire means 30 seconds you have to answer. So say we tell Monica will tell you the rules. And then after that we'll have the video rounds. That will be quite interesting.
Okay. Team 5 is plus 15.
Do it for the scores.
Team 6 is plus 20.
Or Dr. Monica, I think you can tell the rules for the next round.
Team 7 is minus
So second round is rapid fire round. So per team total 5 questions will be asked. Duration will be 30 seconds. For each correct question answer, you will be getting 5 marks, no negative marking. And wrong answers, if someone is giving, we'll be passing it to the audience.
So at the end of this round, the score goes like this. Team 2 leading with 65 marks.
Round of applause for team 2.
Team 1 and 8 yet to open their accounts. Team 3 minus 25. Team 4 20. Team 5 plus 15. Team 6 plus 20. And Team 7 minus 20.
So you still have 2 rounds.
5 questions, 30 seconds or 30 seconds for each question?
In 30 seconds, you have to answer 5 questions. So we will start asking the questions. Unless you tell me after the next question, they are not going to ask. So if we ask the first question, if you do not say the answer, do not know the answer, say either pass or next question. Okay? This is how we are going to do.
Total duration is 30 seconds for 5 questions.
After we have faced all the 5 questions, can we rehear the questions like pass, 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 again first question?
See all the questions.
Like we are done with all the 5 questions. We have heard the 5 questions. Now we have passed all of them. Now again when we want to hear the questions, can we say pass?
You see all the questions.
Again from
another 30
one.
seconds to answer.
Please mind it, your time is 30 seconds.
30 seconds you answer or start passing the questions. We'll give you another 30 seconds. So the question will be there, all the questions will be there for a total of 1 minute. Is clear? 30 seconds we'll start asking the question. Either you pass.
I was asking within 30 seconds, if we are done before 30 seconds, we have heard all the questions and still some time is left.
Yes, some point will be left. Yes.
Yeah, then again can we go for the first, second again?
You can go to the
Okay, that was all.
The questions will be on display. Can we do it? Start writing one or team it.
So total duration of this rapid fire is 1 minute.
We'll give you 1 minute. Is that okay? Okay. I think they are all are worried for 30 seconds. So
Okay, we'll give you 1 minute.
1 minute. 1 minute we'll try. 1 minute. Keep it 1 minute. They are worried. But 1 minute you have to answer all the questions. I will not allow you more than 1 minute. So, 1.
Team 1, blood loss in class 2 shock is plus 5. Second question is name the lymph node located between pectoralis major and pectoralis minor.
Interpectoral.
Very good. The F plus 5 F and flow model is related as metabolic response to pass. Identify the lesion which is being shown in the image. Identify the procedure which is being shown in the image. So basically, you have answered 2 questions, 3 answers you have to take answer.
Wait till your 1 minute is over. Till then, you can write 3 questions. Over. Okay, the questions goes to audience.
So, third question, event flow model is related as metabolic response to? Very good. Injury. Identify the fourth question, what is the lesion which is being shown in the image? Mucus retention cyst. And what is the procedure? In next picture, what is the procedure? Endoscopic submucosal dissection. Okay. So, plus 10 goes to team 1. Team 2. So your time starts now. T stage of a breast tumor of size 2.5 centimeter invading pectoralis major muscle belongs to
T2.
Plus 5. Maximum wound strength is achieved after how many weeks of healing?
Pass. Pass.
Identify the type of hernia.
Image. Mixed hernia.
We'll give you one more question. Identify the procedure for dysphagia.
Next question.
Identify and name the procedure which is being shown in the figure.
Continuous suction and drainage for necrotic pancreas.
Name the procedure.
Ward. ERT. Burger procedure.
Beggar procedure.
Beggar
Plus
procedure.
5.
Beggar. Ma'am, one more question was
4. Fourth you had not answered.
one extra question. Mixed hernia, we answered that. Answer was written.
Okay, we'll ask you later.
Yes.
Once all the rounds are over.
Okay, so they have secured clause pair.
1 minute. Time is good.
Hey, done. Time is over. One more question we'll ask you. We'll ask you.
We'll ask you one more question. Team 3, your questions, your time start now. Open cardiac massage is categorized to which type of wound classification?
3. Open, close, contaminated.
What is
Third, right type. Third.
where is the transplanted kidney placed during the kidney transplant?
Pass.
Most frequently involved site for pressure sore is in bedridden patient.
Sacrum.
Plus 5, identify the type of procedure given in the image for rectal prolapse.
Mesh rectopexy.
It's a broad term.
Next.
No, sir. Maximum flow rate of a gas through the various needle is?
Maximum flow rate.
10.
They answered only one question plus 5. So, audience, open cardiac massage is categorized in which type of wound classification? These are the questions which are there for audience. If they don't answer, I'll ask the participants. Audience? Pardon? Good. Close contaminated. What is close contaminated?
Please. Second type is.
Is there any classification like close contaminated?
No, there are 4 types. This is the
Is there any
third
term
type.
like close contaminated?
No. Yes, sir. Contaminated.
It's contaminated.
Did you say contaminated?
Yes.
They said
Close contaminated. Where is the transplanted kidney placed during the kidney transplant? Anyone from the participants? Very good. The procedure for rectal prolapse? Ventral mesh rectopexy. Very good. Maximum flow rate of gas through the various audience? 2.5. It's 2.5 liter per minute. Team 4, your time start now.
So team 3 got only 5.
Plus 5, sir. Largest artery of the stomach arises from?
Celiac trunk.
Very good, plus 5. Name the triangle which is being shown in the figure. This figure.
Passaro's triangle.
Plus 5. Identify the instrument.
Humby's knife.
Plus 5. Bronchoscopic picture of the patient with esophageal cancer is shown. What is the T stage?
T3.
Wrong. Identify the retractor which is being shown in the image.
Thompson's.
Plus 5. You still have time. You want to answer question 4?
T4. Pass.
T4 में you have to mention what T4.
T4A.
No. Anyone from the audience? Sir, plus 20.
They answered 4 questions.
4 questions. Anyone from the audience? It's T4B. Team 5, your time starts now. First ligament to be cut in elective splenectomy is?
Gastrosplenic ligament.
Plus 5. Which is the maneuver that can be used for uncontrolled traumatic hepatic bleeding?
Pringle's maneuver.
Plus 5. Identify the type of knot which is being shown in the figure.
Pass. Pass.
Name the type of hydrocele in the figure.
Pass.
What is this position?
Jackknife.
Pardon?
Jackknife.
Okay.
Two they have correct. They have made 2 correct answers. This one.
This is correct, sir.
What did they say answer? What is
Jackknife.
the position?
Jackknife.
So, audience, what is the type of knot? This knot? So, it's someone from here answered it's surgeon's knot. Then this event, what type of hydrocele? Vaginal hydrocele. Team 6, your time starts now. Identify the procedure which is being shown in the image.
Henke Mulki Pyroloplasty.
Plus 5. Name the device in the image.
Sangstein Blakemore.
Plus 5. Name the investigation.
ICG used in.
Plus 5. Size of the true cut needle for the breast biopsy. What is the size of needle?
14.
Plus 5. What is this procedure in management of hemorrhoids?
Ferguson.
No.
Millie Morgan.
Plus 1. So they answered all correctly. Team 7, your time starts now. What is the safest point of entry to the abdomen in open and laparoscopic surgery?
Midline.
Name the procedure given in the image.
PEG.
What is PG?
Percutaneous endoscopic
Plus
gastric.
5. Name the procedure which is being shown in the image.
Pass.
He's a German and the first person to propose hand disinfection, and he is described as saviors of the mother. Hand washing.
Pass.
Identify the type of repair.
Sugar baker.
Huh?
Sugar baker.
Plus 5. So, first question you had not answered it correctly.
Umbilicus.
Umbilical. Plus 5 umbilical cicatrix. Name the procedure.
Mill.
No? Anyone from the audience? Very good. So it's Buhari's plan.
So they made 3 correct.
3 or 2? 3, sir. 3 correct. And who is this person? No? Hand washing. Anyone from the participants?
Ignace Philip. Ignace Philip. Semmelweis.
Team 8, your time starts now. EMR is done for esophageal carcinoma for tumor stage. T1 what? T1? Plus 5. Breast pathology which is being shown in the images. Plus 5. Identify the type of choledochal cyst which is shown in the image. Reconstruction of the breast here is done by which type? Very good. Plus 5. According to Borman classification of advanced gastric cancer, this is which type of gastric carcinoma? So you are left
Type.
this cyst or what is this type of cyst? Choledochal cyst?
Type.
Supraduodenal.
No? So anyone from the audience? Type?
Total 30.
4.
7
So-
is minus 1. 7 का ये हुआ ना 15 plus 1.
One question. The question is, what is the most common source of bleeding in patient with hemoptysis?
Okay. Show.
From which artery?
Yeah, you're asking questions.
Hemoptysis.
Hemoptysis.
10 seconds.
Bronchial artery.
Correct.
Plus 5.
Jump to another question the answer. Plus 5 it becomes 80. So at the end of this round, the score goes like this. Team 2 leading with 80 marks. And team 6 securing the second highest marks 45.
Round of applause for team 6.
Then team 4 with 40 marks. Then team 5 with 30 marks. Then team 8 with 15 marks. Team 1 with 10 marks. And team 7 with minus 5. Team 3 with minus 20. Please see your marks there. Yes. One more round.
So now we are going to the last round for today's speech session. That
It's
will,
going to be the most interesting round.
Dr. Monica will tell you the rules. Sorry? Fine.
So you will be getting 10 marks for the correct response, but -5 for the wrong response. And you have to take your mic, then you have to tell your team number. The first one to announce will answer first. But mind it, you have -5 marking, and you have to announce your team number to attempt the question.
So, Vikas, your decision will be final. Who announces first?
Sir, pass is allowed in this round. Passing the question.
You announce no passing. You announce. You want to answer. You announce your team. You have
Total number of questions.
Suppose team 1, you say team 1, like that.
Sir, if the team answers wrongly, then we get to answer.
Minus.
No passing.
No passing. No passing.
No passing.
Then it's open.
Total number of questions.
And then it's open, and those who answer will not get the marks.
Total number of questions.
Okay.
Total number of questions.
Why you want the total number of questions? You want to answer all the questions.
Suppose we
There are 8 questions. So
suppose we like first we get to answer and we couldn't answer. Will it be passed to other participant?
So no passing. No passing.
After announcing the team name, we get to answer the question. If we answer it wrongly, then that question will be transferred to the next team, or it will be null and void. No passing. Okay.
Then,
But if you answer wrong, you will get negative mark.
we'll be asking audience.
Then it will go to audience, and it's open for everyone.
So
Audience is not
after raising our hand, then we have to answer. That
You
is
have
the
to
rule.
answer. If
You
you
have
don't
we have to answer. If not answered, then negative
you will get
marks.
-5.
You have to tell your team name on the mic, because it's difficult to see all who will be raising the hand.
And if you cannot answer, already raise your hands means -1.
-1.
Clear.
Okay, let's start with the first one. You have to identify the surname.
Team 6,
Team 6.
Dr. Palanivelu.
Okay, we could not play the video.
5 marks or 10 marks? 10 marks.
10 marks.
10 marks.
10 marks to team 6.
Like this video play करना है. Sound audio.
He wrote it. Subsequently, only book all written in a different. But unfortunately, somewhere I see that up and down will be there. In Indian, it went up and down. And thank UK, United Kingdom. And now he used to last 200, 300, 400 years. He used to come UK to learn medicine and going back. Now, again started India coming up, and particularly minimally invasive surgery and other specialties, because the West.
Okay, so next one.
Even surgery,
You have to identify the surname.
Humanitarian thought and action. I have been a surgeon for 60 years and more, and I've had the best of two worlds as a teacher and a consultant in tertiary care hospitals, and as someone who's worked in small towns and rural areas, trying to do what I thought I should. I never thought I had a vision. I just thought I was doing what is normal for somebody to do if he had the need to do it. All of us sitting here, I'm sure if asked about a surgical operation room, would say that it is a sterile area with technology, infrastructure, well-trained surgeons, and you naturally feel that is so all over every place. Nothing could be further from the truth.
All of
5
seniors.
billion people, 70% of the world population, have no access at all to safe, affordable humanitarian thought and action.
So, okay, I want to give some clue to the audience. He has audience no. Sir, बच्चों को answer दे रहे थे sir.
Let the students come. Yes. Very good.
Very good.
Very good. Dr. T.E. Woodward.
He is. He's father of
Father of laparoscopic surgery
India. Indian. He's father of Indian laparoscopic surgery.
Dr. Trahampton E. Woodward am from Mumbai. First laparoscopy surgeon of our country.
So he had his bibliography. He had written it very well with the title "More Than Just Surgery: Life Lessons Beyond OT." Okay, everyone very. It's a very good. Identify.
I was engaged to a monster.
Paolo was an absolute fraudster. And that's why we have to stop him.
Paolo Macchiarini treated people as human lab rats.
She was coughing up pieces of her own flesh. The first liver transplant, the first kidney transplant, the first heart transplant, did they go all well? No. I think that this is the future. The next patients, everything will be better.
The question is, was he torturing people to death?
It's the biggest con in medical history.
This guy might.
Very famous thoracic surgeon.
There's a documentary called Bad Surgeons on his name. Full. So I think I have already given the clue, so participants cannot answer. It goes to audience.
He's a thoracic surgeon.
His license has been suspended. He has done a lot of fraud on research. So basically regenerative medicine. On tracheal transplant, he used to do the tracheal transplant on the patient putting the stem cell, and there was no animal research before doing the human transplant. Very, very famous story. This Dr. Paolo Macchiarini is from Italy. Sorry? The next one.
A British doctor has admitted to burning his initials into the livers of 2 patients during organ transplant surgeries in 2013. Dr. 23-year-old, who was a noted liver, spleen, and pancreas transplant surgeon, reportedly carried out the etchings in front of other doctors using the same tool used to seal bleeding blood vessel.
Anyone? Okay, this surgeon used to engrave.
Transplant surgeon basically. Very famous transplant surgeon.
He used to engrave his initials on the liver with APC. Whenever he operates the patient on the liver, he used to write B. Now,
With
APC. It goes to audience. Dr. Simon Ramon, British surgeon.
A British.
I think this is easy.
Getting more routine and using the software is going to be a real fast way and a standardized way actually of evaluating lesions, which allows you to communicate with, to get more routine and using the software.
CT enterography.
You have to be a little more specific. So you are reaching there. You can give me +5 maybe. It's a sir can decide.
Can you be more specific?
Which part? You see the CT scan?
Team 5. Team 5.
For small bowel, we do it. For small bowel, we do it. This CT.
It's not for the small bowel.
CT
It
enterography.
can be used for the small bowel. Here it's not for the small bowel. It's a large bowel. It's a virtual colonoscopy.
Virtual colonoscopy.
So, sir, can we give him 2 marks or half marks? Okay, we'll give half marks.
Not 10, 5.
Not 5.
Give it 5 marks, yes.
You have to identify the norm.
A single hitch is taken first. This is single hitch. 3 winds should be taken around the
Team
loop.
5. Team 4. Team 5.
Team 4.
This
Rotters
is
no.
second wind, and here it is third wind.
Rotters no.
Correct. It's a Rotters now. +10. Go to the next one.
I was just very happy
Team
that
7.
I would be a part of something that I believe is so monumental. I was just
Neuralink.
very happy that I would be a part of something that I believe is so monumental in this next step forward of helping people with paralysis.
Extremely safe.
Help.
Okay, we'll finish the video.
I was just very happy that I would be a part of something that I believe is so monumental in this next step forward of helping people with paralysis.
Extremely safe, and you have and you can have superhuman abilities. I think probably a lot of people would choose to have.
The next question and the last one. Very easy.
Team 5.
During the procedure, the endoscope is
Team
entered
5.
in the esophagus where an incision or
Boom.
is made in the lining or the mucosa of the esophagus.
So
The
that's
doctor uses a special knife on the tip of the endoscope to tunnel through the wall or the submucosa of the esophagus.
I have a query. When they announced the team, the video wasn't even played. So they had no actually front foot to predict the procedure. When they actually announced their team name, till then even the mucosal incision was not given. So
they could have actually got the negative mark.
If you would have given it wrong, you would have given us negative.
That is pure luck, and
it's okay.
So they could have got negative marks also. Suppose it was a ESD, they would have got negative marks. Over to Prakash.
During the procedure,
For the results.
So, at the end of entire rounds of this quiz, let's give a round of applause to both quiz masters, Pankaj and Monica. Both of them have done a wonderful job.
And a big round of applause for sir to keep the scores. That was the most challenging part.
But you both have done a tremendous work, and you have kept the entire audience alive all throughout the quiz. And thanks to all the participants, all the teams from different colleges. Now we'll declare the score. Team 2 leading with 80 marks. Give a big round of applause for them. So they are the winners. Now the next team securing the second highest mark is team 6 with 60 marks. The third highest mark secured by team 4 with 50 marks. College, actually I do not know. Can team 2 tell your college name? Team 2? AIIMS Bhubaneswar. Another round of applause for AIIMS Bhubaneswar. They are the host and they are the winners. Team 6, the second winner. Can you please tell your college name?
IMS and some hospital.
Another round of applause for them. Team 4.
High Tech Medical College.
Very good. High Tech Medical College. And other teams, I'm not going to declare their marks. You can see in the screen there. First, second, third, they are the winners. They will get the prizes. Thank you all. Thanks, the audience.
Those who are interested to attend, please stay near the registration and sir will be accompanying later. To the end of the day, and I hope we all have had an incredible time. Let's continue the momentum we built today on the next day. Have a lovely evening.